Good morning and welcome. I would first like to remind everyone to please mute your line when you're not speaking. For media and press, the FDA press contact is Nathan Arnold, and his email and phone number are currently displayed, or are going to be displayed in a second. My name is Dr. Sonia Hernandez-Diaz, and I will be chairing this meeting. I will now call the second day of the September 10th, 11th, 2020 joint meeting of the Drug Safety and Risk Management Advisory Committee and the Anesthetic and Analgesic Drug Products Advisory Committee to order. Dr. Phil Bautista is the designated federal officer for this meeting and will begin with introductions.
Thank you, Dr. Hernandez-Diaz. Good morning. My name is Phil Bautista, and I'm the designated federal officer for this meeting. When I call your name, please introduce yourself by saying your name and your affiliation. Start first with the AdPac. Dr. Griffin.
Marie Griffin, pharmacoepidemiologist and internist, professor of health policy emerita, Vanderbilt.
Dr. Hernandez-Diaz.
Sonia Hernandez-Diaz, pharmacoepidemiologist, professor of epidemiology at the Harvard Chan School of Public Health in Boston.
Dr. Mizell.
Steve Mizell, Director of Medication Safety for mHealth Fairview in Minneapolis.
Dr. Mehta.
Hi, Rima Mehta from Pfizer, Head of Risk Management and Safety Surveillance Research, industry representative for the panel.
Dr. Nelson.
Good morning, Louis Nelson. I'm the professor and chair of the Department of Emergency Medicine at Rutgers, New Jersey Medical School in Newark, New Jersey. I'm the director of the Division of Medical Toxicology there as well, and I'm a senior consultant to the New Jersey Poison Control Center.
Dr. Setaguchi.
Good morning, Soko Setaguchi, pharmacoepidemiologist and general internist, professor of medicine and epidemiology at Rutgers University.
Dr. Gudra.
Sociologist at Penn Medical in Philadelphia.
Hi, Dr. Gudra. Can you please repeat that for the record? You didn't come through very clearly.
Savannah Gowdra, one of the anesthesiologists at Penn Medicine, Philadelphia.
Thank you very much. Dr. Higgins.
Dr. Jennifer Higgins, consumer representative to AdPac.
Dr. Horo.
Jay Horo. I'm an anesthesiologist and clinical trialist at Bristol Myers Squibb in Lawrenceville, New Jersey, and industry representative.
Dr. Joza.
Hi, I'm Marianne Joza. I'm an anesthesiologist and pain specialist at University of North Carolina in Chapel Hill.
Dr. McAuliffe.
Hi, I'm Laura McAuliffe. I'm a professor of nursing and the director of the nurse anesthesia program at East Carolina University in Greenville, North Carolina.
Dr. Shobin.
Hi, I'm Abby Shobin. I'm an associate professor of biostatistics at Ohio State.
Dr. Sprintz.
Hi, I'm Michael Sprintz. I'm anesthesiologist, expert in pain medicine and addiction medicine, and personally in long-term recovery. I am a clinical assistant professor at University of Texas Health Science Center and CEO of the Sprint Center for Pain and Sprint Center for Recovery.
Dr. Ehrman.
Rich Ehrman. I'm an anesthesiologist at the Brigham and Women's Hospital in Boston, Massachusetts.
Dr. Zafran.
Morning, anesthesiologist Sharif Zafran, President of the Texas Medical Board, Vice Chair of the Clinical Governance Board for U.S. Anesthesia Partners, Gulf Coast.
Dr. Zakharov.
Hello, good morning. My name is Kevin Zakharoff. My expertise is in anesthesiology and pain medicine. I am a faculty member, clinical instructor, and course director of pain and addiction at the Renaissance School of Medicine at Stony Brook University. Good morning.
Dr. Amir Shahi.
Good morning, Marianne Amrshahi. I am Associate Professor of Emergency Medicine at Georgetown University School of Medicine. I practice at Washington Hospital Center, and I'm a medical toxicologist for the National Capital Poison Center.
Dr. Bateman.
Good morning, Brian Bateman. I'm Chief of Obstetric Anesthesia at Brigham and Women's Hospital and an Associate Professor at Harvard Medical School.
Dr. Coffin.
Good morning, Philip Coffin. I'm an addiction medicine, infectious disease, and internal medicine physician and director of substance use research at the San Francisco Department of Public Health and University of California, San Francisco.
Dr. Davis.
My name is Alex Davis. I'm a decision scientist and associate professor in the Department of Engineering and Public Policy at Carnegie Mellon University.
Dr. Folman.
Yeah, I'm Dean Tolman, head of biostatistics at the National Institute of Allergy and Infectious Diseases.
Dr. Gordon.
Good morning. My name is Adam Gordon. I'm an internal medicine, addiction medicine physician, and health services researcher, professor of medicine and psychiatry at the University of Utah, and section chief of addiction medicine at the Salt Lake City VA healthcare system.
Dr. Green.
Good morning. Hi, I'm Tracy Green. I'm an epidemiologist and a professor at the Heller School for Social Policy and Management, and I direct the Opioid Policy Research Collaborative at Brandeis University.
I see that Dr. Hovinga has joined. Dr. Hovinga, can you please unmute yourself and state your name for the record? Okay, we'll come back to him. Dr. Kertez.
Good morning. I am a professor at the University of Alabama at Birmingham Schools of Medicine and Public Health and a physician at the Birmingham Veterans Affairs Medical Center. I do both addiction medicine and internal medicine. I carry out health services research focused on populations with high levels of addiction and pain, including people who are homeless.
Hi, Dr. Kertez, can you please state your full name for the record? Apologize.
Sorry, Stefan Kertez, K-E-R-T-E-S-Z.
Thank you. Dr. Krebs.
Hi, Erin Krebs. I'm Chief of General Internal Medicine and a Health Services Researcher at the Minneapolis VA Healthcare System and Professor of Medicine at the University of Minnesota.
Dr. Maher.
Hi, I'm Dermot Maher. I'm an assistant professor at Johns Hopkins School of Medicine in the Department of Anesthesiology and Pain Medicine.
Dr. Marshall.
Hi, everyone. I'm Brandon Marshall. I'm an associate professor in epidemiology at the Brown School of Public Health in Providence, Rhode Island.
Mr. O'Brien.
Yes, I'm Joseph O'Brien. I am the president and CEO of the National Scoliosis Foundation. I'm also a patient who has had 6 spinal fusions with scoliosis, and I am the patient representative.
Dr. Zabel.
Hey, good morning, everyone. My name is John Zabel. I'm a senior public health scientist in the Behavioral Health Research Division at RTI International in Atlanta, Georgia, and also a professor of anthropology and human health at Emory University.
Dr. Hovinga, if you are available, can you please unmute yourself and state your name for the record, as well as your affiliation? Okay, we'll come back to him again. Next, we'll move to the FDA participants, starting with Dr. Staffa.
Good morning. I'm Judy Staffa. I'm the Associate Director for Public Health Initiatives in the Office of Surveillance and Epidemiology in the Center for Drugs at FDA.
Dr. Makinich.
Hi, good morning. I'm Jana Makinich. I'm a senior medical epidemiologist in the Division of Epidemiology in the Office of Surveillance and Epidemiology.
Dr. Roca.
Good morning. I'm Rigoberto Roca. I'm acting division director of the Division of Anesthesiology, Addiction Medicine, and Pain Medicine.
Dr. Lloyd.
Good morning. Josh Lloyd, Medical Officer Team Leader from the Controlled Substance Staff, FDA.
Lieutenant Commander Liberator.
Good morning, Lieutenant Commander Mark Liberator. I'm a pharmacist officer in the United States Public Health Service, and I am the Deputy Director for Safety for the Division of Anesthesiology, Addiction Medicine, and Pain Medicine.
Dr. Calderon.
Good morning. This is Sylvia Calderon. I am a senior pharmacologist in the Controlled Substance Staff at the Center's Director's Office in Cedar.
Dr. Zhao.
Good morning. My name is Yuqin Zhao. I'm a mathematical statistician team leader, Division Biometric 7 in Office of Biostatistics, Cedar.
Thank you. Dr. Havinga, if you're available, can you please state your name for the record? If you're not or currently on, we'll come back to you and let you introduce yourself for the record at the next opportune time. For this, I'll hand it back to Dr. Hernandez-Diaz, the chairperson for the meeting.
Thank you, Dr. Batista. For topics such as those being discussed at this meeting, there are often a variety of opinions, some of which are quite strongly held. Our goal is that this meeting will be a fair and open forum for discussion of these issues, and that individuals can express their views without interruptions. Thus, as a gentle reminder, individuals will be allowed to speak into the record only if recognized by the chairperson. We look forward to a productive meeting. In the spirit of the Federal Advisory Committee Act and the Government in the Sunshine Act, we ask that the advisory committee members take care that their conversations about the topic at hand take place in the open forum of the meeting. We are aware that members of the media are anxious to speak with the FDA about these proceedings. However, FDA will refrain from discussing the details of this meeting with the media until its conclusion. Also, the committee is reminded to please refrain from discussing the meeting topic during breaks or lunch. Thank you. And we will proceed with FDA introductory remarks from Dr. Judy Staff.
Good morning again. This is Judy Staffa. I want to welcome you to day 2 of this meeting. I think day 1, from our perspective, was successful. We, I believe, mastered our technology, and I hope, shared with you a lot of informative presentations from FDA, from our invited guest speaker, as well as from our colleagues at Purdue. Based on all of the really thoughtful questions that you have asked and will likely continue to ask, it seems to me that you've been paying close attention, and we really appreciate that. We are very excited to be having a public discussion about these data and to be hearing your thoughts and input. So today, this morning, we will be having several more talks to finish up laying the groundwork, the framework to provide you with all the information that we hope will inform your discussions this afternoon. I will be back after lunch to be sharing with you, walking through the 7 questions we have. I promise they're going to be very challenging questions. We tend to try to answer the easy ones ourselves, and we only bring the difficult ones to you. So there'll be more to come on that. And in between the final 3 talks you're going to hear this morning, we will also have what I'm sure will be a very informative open public hearing where we will hear from members of the public who would like to also share their thinking with us and with the committees. So with that, I will turn it back over to Dr. Hernandez-Diaz. Thank you.
Thank you, Dr. Staffa. We will now proceed with the presentation from Dr. Wilson Compton of the National Institute of Drug Abuse.
Good morning. It's a pleasure to be joining you today on behalf of the National Institute on Drug Abuse. By way of introductions, my name is Wilson Compton, and I'm the Deputy Director at the National Institute on Drug Abuse. My background is as an addiction psychiatrist by training, and I also have done most of my research in population sciences. Today, it's my pleasure to be speaking to you in a general talk about the landscape of the opioid crisis in our country, going back the last couple of decades and summarizing even with some new information as it relates to the current COVID pandemic and how that appears to be impacting the opioid crisis. I think this is an important reminder that these are complex conditions with multiple factors that have an impact on them. And I believe that's part of my goal today, which is to help you understand some of the complexity of the environment surrounding the abuse deterrent formulations that you are wrestling with today. Next slide. I believe you're running the slides for me, so I'll wait for the slides to come up. Next, please. As we think about the opioid crisis, this data from the National Center for Health Statistics, I think, is some of the most important because it reminds us of two key factors in this overdose crisis. And after all, that is what has drawn the attention to these issues, is the remarkable number of people dying from drug overdoses in the United States over the last decades. But what we see is two things from these graphic representation of the overdose death rates in all of the counties around the United States. What we see is that every part of the country has been affected. So we see increases across the past 2 decades, virtually across all parts of the country. But we also immediately notice that it's not evenly distributed. And so the geographic dispersion and geographic differences are one of the factors that I'd like you to keep in mind as you deliberate today, in that one of the complexities of the opioid crisis is that it varies from location to location. That's typical for all drug abuse problems in that there is quite a bit of variation in the geography of these conditions. Next slide. Of course, it's the overall impact that has drawn so much attention. The most recent national data are from 2018, where we saw some 67,000 deaths. The vast majority of those were from opioids, both the prescription and illicit. Next slide. When we look at the history and the trends over time, next, we see some changes. Next slide, please. I'll just say next each time I want you to advance, because we'll go pretty quickly through a number of these. What we see is that the commonly prescribed medications, and this includes the synthetic and non-synthetic commonly prescribed as well as methadone, increased markedly through the 2000s, but began to level off in the last few years as a number of interventions were brought into play. Next slide. Unfortunately, as we saw some leveling off of the prescription-related overdose deaths, we saw a marked increase in heroin. Heroin beginning to increase in 2006 and 2007 and really accelerating after 2010. Again, we see some positive impact in the last few years related to heroin. Next slide. Synthetic opioids other than methadone, which I've called fentanyl, but I put that in quotes, have really skyrocketed just in the last few years. I will go into some of the explanation of this, but the reason I put it in quotes is that this is not the fentanyl that is prescribed. Most of the data strongly suggest that the issues related to this class of substances are from the illicit market. So illicit products shipped to the U.S. and sold on the streets. So in some ways, we can think of this as being much more like heroin in terms of being the illicit drug market distribution. Next slide, please. While we think about prescription opioids being a key part of the first part of this crisis, there's an important factor here. When we say prescription, most of us automatically think that that means that it's the prescription written by a physician such as myself directly to the patient, and that it's that patient who's at risk for misuse and eventual overdose. Well, of course, that can be the case. It's important to keep in mind that prescriptions don't necessarily stay with the person to whom they are prescribed. And so when we look at data from the National Survey on Drug Use and Health, what we find consistently is that persons that misuse prescription opioids, about 1/3 of them report that their medication was from their own prescription, but more than half say they obtained it from friends and relatives. Again, those friends and relatives did obtain it from their own prescription. So what this reminds me is that the role of physicians is multifold here. It's not just in how we write prescriptions to our patients, but it's also in what happens to those medications once they're out in the community, in the medicine cabinets of persons all across the country. Next slide, please. That's one way to look at how the environment in terms of the distribution of these substances relates to the prescription epidemic. Another way we think about the importance of the environment, or in this case economics and the sales of heroin, are looking at the potential price of heroin on streets all across the country. Heroin has generally dropped in price in street value across the 1990s and has remained generally low across the last decade or 2 decades. Next slide. In addition to the generally lower price, we've also seen a marked increase in the availability of heroin, as illustrated by a very interesting book by Sam Quinones that documents new ways that heroin is sold using retail drug selling in new parts of the country that never used to have heroin. So the market for heroin may have shifted as well over the past decade or 2. Next slide, please. When we think about the major issues related to fentanyl, I think it's important to highlight the economics of these issues, and this is illustrated by this graphic from the Wall Street Journal from a few years ago, in which case they documented that the ingredients, the key ingredients used to produce fentanyl, they are shipped from overseas, sometimes directly using mailing or else other overseas services, can be sold on the street for something like 1,000 times their cost. So it's that tremendous profit margin and the way that these products can be relatively inexpensive compared to heroin or prescription agents that helps explain their widespread availability, the interest by the purveyors of these substances, but also it's important to keep in mind the tremendous potency of fentanyl. Fentanyl compounds are something like 50 times more potent than heroin, or approximately 100 times more potent than morphine when it comes to overdose risk. And so that explains 2 things. One, the potential that very small amounts of this substance can cause an overdose, both non-fatal and fatal. And it also explains the illicit marketing, in that smuggling these agents, since they are relatively small quantities compared to the products that they're taking the place of, can be relatively easier to smuggle. Next slide, please. In addition to thinking about these broad environmental issues that influence the prescription, the heroin, and now the synthetic opioids other than methadone or fentanyl illicit markets, an emerging issue in the last 2 years has been methamphetamine. For instance, we documented recently an increase in heroin admissions to treatment programs across the country that include methamphetamine. So this reminds us that when we think about the opioid crisis, it often isn't just opioids, but maybe opioids in combination with multiple other substances. Methamphetamine being among the most prominent in the last few years. Next slide. In fact, when we look at the overdose death rate, some have called this the 4th wave of the overdose crisis, where the 3 previous waves being prescription opioids, then heroin, then the synthetic opioids other than methadone, and most recently increases in stimulant-related deaths, cocaine and methamphetamine, now responsible for something like 26,000 deaths in the most recent full national data from 2018. Next slide, please. Looking at some of the data just from 2019, the most recent data from the National Center for Health Statistics that documents the preliminary results of overdose deaths in the country show that the psychostimulants with abuse potential, that's the orange line, and cocaine deaths have continued to increase in the last few months, as well as the synthetic opioids other than methadone, which I've called fentanyl on previous slides, have also shown an increase, while heroin and the natural and semi-synthetic opioids have been stable or slightly declined. Next slide, please. When we look overall at what's been happening in 2019, what we see is an overall increase in overdose deaths, erasing the progress we made between 2017 and 18. We see heroin, natural and semi-synthetic drugs, and methadone with slight declines, but we see marked increases in the synthetic opioids other than methadone, cocaine, and other psychostimulants, which is predominantly methamphetamine. Next slide, please. Looking briefly at some emerging data during the current COVID-19 pandemic, we see an indication that overdoses may be increasing during these last few months, possibly due to the social isolation, the increasing stress, which drives some people to use more substances. Also, being isolated can be a risk factor for overdose and for fatal overdoses. We know that being alone when using drugs is a predictor of overdose deaths. Next slide, please. I'm going to switch gears a little bit. While I focus for you on the complexity of the overdose crisis as it shifts from one major substance to another, begins to include stimulants in increasing numbers in recent years, I want to step back and look broadly at the issue of overlap of opioids with other substances. This is data from the National Survey on Drug Use and Health that looks at all opioid misuse. So that's prevalent in around 4% of the adult population in the United States. What we see is that among those that misuse opioids, this is a very broad group that includes a broad range of severity from occasional misuse to very regular patterns of misuse. But again, we see much higher than expected rates of use of virtually all other substances, whether that's heavy alcohol, tobacco use, marijuana use, cocaine, or methamphetamine. All of these rates of use of these other substances among the opioid misusers are markedly increased from the expected prevalence. Next slide, please. We can look at the overlap among substances among the overdose deaths. For instance, when we look at prescription opioids, those are the blue bars, but then we divide them into the groups that do and do not also have other synthetic narcotics, i.e. predominantly the synthetics other than methadone or fentanyl. We see that it's those rates, that's the yellow line, have been increasing in the last few years, while those without the other synthetic narcotics have been declining. Next slide. When we look at those who have synthetic opioid overdose deaths in a single year when it particularly increased in 2016, we see that the vast majority of those whose deaths are attributed to synthetic opioids other than methadone, i.e. fentanyl-related deaths, the vast majority, or about 80%, have other drugs or alcohol also in their systems, and their deaths are partially attributed to these other substances as well. So we see other opioids as the most common, but we also see benzodiazepines, alcohol, psychostimulants as being significant contributors to the deaths of these that include the synthetic opioids other than methadone. Next slide, please. Benzodiazepines, of course, have generated a lot of attention because of the recognition that the combination that benzodiazepines plus opioids can be so lethal. What we see is that benzodiazepines have increased but then leveled out and dropped a little bit in 2018, but that drop was mostly among benzodiazepines without any opioids. Those with opioids, particularly synthetic opioids, showed some increases. Next slide, please. When we look among persons who misuse opioids, we see that benzodiazepine use is strongly associated with prescription opioid use disorder and with heroin use disorders. So again, this is a clear reminder that opioid use does not occur in isolation, but overlaps significantly with other substances. And so each time we start considering one substance, we need to be thinking about polydrug use as a key issue. Next slide. Next. Now, there's some interesting data that reminds us that these multiple substances can have mixed effects. And so this is a paper from out of Massachusetts that looked at those who are prescribed benzodiazepines during buprenorphine treatment. What happens during buprenorphine treatment when somebody receives benzodiazepines? What we see is a higher risk of overdose death, a higher risk of non-fatal opioid overdose, higher rates of all-cause mortality, but interestingly, we see a lower risk of discontinuation of buprenorphine. So to me, this is a reminder that the effects of these substances are complex, and even in medical use of these substances, there can be both complications, as illustrated so dramatically by the overdose deaths and the all-cause mortality, but there also can potentially be a benefit when we see in terms of retention in treatment and lower rates of buprenorphine discontinuation in those who were prescribed benzodiazepines while they were undergoing buprenorphine treatment. This is a reminder to me of the complexity, and while this one study isn't a complete answer to the question, it is an important reminder to pay attention to the details. Next slide, please. Now, I've highlighted for you overdose deaths and non-fatal overdoses, issues related to polydrug use, but I also want to really briefly remind us that it's not just overdose deaths that we're concerned about. Opioid misuse has been associated with increasing risk of neonatal abstinence or neonatal opioid withdrawal syndromes, as well as the broad social complications of increasing foster care removal, so broad social impacts of the use of these substances beyond some of the medical and mortality issues I've been describing. Next slide, please. Infectious diseases are clearly at risk for those that use injection drugs. We've seen rising rates of hepatitis C and some very important work by the CDC that reminded us of many of the locations that are vulnerable to outbreaks of hepatitis C or HIV, such as the one we saw so starkly illustrated in rural county in Indiana just a few years ago. Next slide, please. Some of the other adverse outcomes relate to endocarditis, as well as other health complications of injection drug use, whether that's abscesses and cutaneous infections, and other issues related to injection drug use. Next slide, please. Okay, when we shift gears from thinking about all the complexities of opioid misuse, its relationship to other substances, the changes over time in the use of substances out there in the community, the shifts due to broad social factors, including the economics of the drug trade. What are we doing about this? Well, within the Department of Health and Human Services, we've been operating under a 5-point strategy to focus on improving prevention, treatment, and recovery services, improvement to data so we can target our interventions more effectively. If misuse of prescription opioids was what helped start this crisis, what can we do to better address pain without resorting to opioids as readily? How can we better target opioid reversing drugs, naloxone distribution as a key goal for policy and practice to save lives acutely? And finally, the 5th pillar will be better research. And certainly as a representative of the National Institute on Drug Abuse, that's our responsibility, is to help make sure that the research that we're supporting addresses the opioid crisis as much as possible. Next slide. I'm going to go into each of these very briefly just to illustrate the complexity of this landscape as well as you wrestle with your questions today. This is a landmark study that La Rochelle and colleagues completed a few years ago that reminded us that even when patients suffer an overdose on the medications that they are prescribed, they often remain on those opioids over the ensuing months without much of a change in the dose of opioids that is prescribed. About a third of these patients who were on prescription opioids remained on benzodiazepines both before and after their overdose event. This, I think, remarkable study alerted us that there were many areas for potential improvement in clinical practice. Next slide, please. One of the ways that the government has been approaching this is with trying to assist with responsible prescribing. One of the best known of these are the opioid prescribing guidelines for use of opioids in chronic long-term non-cancer pain by the CDC that I refer to as the opioid prescribing guidelines. Unfortunately, as these have been rolled out and implemented, we saw that there was a misinterpretation of some of the guidance, and that many patients were finding that their medications were being discontinued abruptly, or that prescriptions were not being refilled without appropriate consideration of the major risks for morbidity in terms of severe opioid withdrawal when long-term opioids are discontinued abruptly. So we followed up more recently with some guidance around reduction or discontinuation of long-term opioid analgesics to alert the community about the importance of not stopping these abruptly, because rapid reductions can harm patients or put them at risk if not made in a thoughtful, deliberative, collaborative, and measured manner. Next slide. In addition to some of these federal efforts, of course, there have been major efforts at state level. And so as you're wrestling with the broad environment of the opioid crisis, I just remind you that state policy, practice, and legal changes have been implemented in a number of locations. Here are just two examples, one from Florida and one from Washington State, that appear to suggest that there are major policy and legal changes implemented around the time of the peak of this crisis appear to have had an impact in either leveling off in terms of deaths and or hospitalizations. Next slide, please. I also want to point out that it's not just these state policies or federal guidance. There's also the potential importance of community efforts and local efforts. For instance, there's been work to remind us that universal middle school-based drug prevention can have an impact on reducing the risk of misuse of prescription opioids or generally all substances as youth develop into young adults. And so this study from Dick Spoth and colleagues, which is now one of 3 studies, reminds us that their middle school family and universal prevention interventions can have a long-lasting impact on the behavior and outcomes of the children when they were in 6th grade experience as they become emerging adults. Next slide. Some of us suggest that targeting youth to prevent later substance use has been an underutilized response, and this might be a way that communities and others can help reduce this. And certainly it's part of the complexity of the social environment in that some communities are implementing these broad-based interventions that can have long-lasting impacts. Next slide. That's a quick version of some of the ways that we're thinking about prevention issues and some of the prescription guidance and policies. A second major national focus has been on naloxone distribution. Both the nasal spray and auto-injector formulations were approved by the FDA, your FDA, just a few years ago and have saved numerous lives as of this time. It was very exciting to see the Surgeon General advise the public to be prepared, get naloxone, and save lives. We are still working to increase the acceptance and availability of naloxone to save as many lives as possible in addressing this crisis. Next slide. The final area in terms of intervention that I want to highlight for you has to do with medication-assisted treatment, the importance of this. We know that these medications can be helpful in helping people recover from opioid use disorders, helping people change their lives and behavior patterns. The data is quite clear that it reduces opioid-related overdose deaths, improves social function, and if you use medication-assisted treatment successfully, it can improve retention in treatment. Next slide. The issue with these slides, with medication-assisted treatment, is that it's highly underutilized. Relapse rates are very high. It's often not offered to patients, and even when it is offered, patients often don't remain on it long enough for it to have the maximum impact. Next slide. The National Academies of Science, Engineering, and Medicine did a very nice study, and I think the title of this illustrates the key conclusion of their report, that medications for opioid use disorder can save lives. Next slide. I'm going to shift to the final pillar of the 5-point Helping Human Services strategy, which would be research. I'm very pleased that Congress appropriated additional funds, allowing us to enhance research related to pain management and in improving treatments for opioid misuse and addiction, whether that's expanding therapeutic options, optimizing effective treatments, and also working aggressively to develop new medications to treat opioid use disorder. Next slide, please. In addition to the NIH effort, I highlight for you a document from the Office of Science and Technology Policy that reminds us that it's not just NIH and even Helping Human Services, but there are many other parts of the federal government, whether that's the Department of Defense, Veterans Affairs, even Department of Agriculture, that can play a key role in health-related research and development to address the opioid crisis. Next slide. I hope what I've illustrated for you in this broad-based and broad-ranging talk is that the opioid crisis represents the epitome of a complex behavioral health condition, that the factors influencing it are both individual and broad environmental, even economic factors, that the environment of those who purvey opioids is an important domain. Both the licit and illicit markets are essential to understanding this. That while we are focused on this as an opioid crisis, it's not just about opioids. While we see methamphetamine being gaining attention recently, I would suggest to you that it's polydrug use in general and multiple substances that are part of this so-called opioid crisis. Certainly prevention interventions, naloxone distribution, and medication for opioid use disorder are key components of addressing the opioid crisis given current technologies. But at the National Institute on Drug Use and the National Institute of Health more broadly, of course, we're focusing on ongoing research to help improve our current solutions so we can have better approaches to addressing this key public health crisis. Thanks very much for your attention. I'll be happy to take any questions you may have.
Thank you very much, Dr. Compton. Before we take the clarifying questions, I'm going to ask Dr. Hovinghe to introduce himself because we missed him this morning. So please, if you can state your name and affiliation for the record. Dr. Hovinghe.
Can you hear me?
Yes.
Yeah. Can you hear me?
Yes.
Hello?
Yes, we can hear you.
Okay. My name is Khan Hovinghe. I'm a clinical pharmacologist and epidemiologist by training. My faculty appointment is at UT Austin College of Pharmacy as an associate professor and senior vice president in a public-private partnership called Act for Children.
Thank you. We will now take clarifying questions for Dr. Compton. Please use the raise hand icon to indicate that you have a question and clear the icon after you have asked your question. When acknowledged, please remember to state your name for the record before you speak. If you wish for a specific slide to be displayed, please let us know the slide number. Finally, it will be helpful to acknowledge the end of your question with a thank you and the end of your follow-up question with that is all for my question so that we can move on to the next panel member with questions. And we have a question from Dr. Sidel.
Thank you. Thank you for your presentation, Wilson. It was really great. On slide 10, you talk about economics and how heroin increases due to lower price, which I find very interesting and might be related to some of the questions we're asking today. However, my own research shows me that people don't really transition to heroin just because it's cheaper. Like if someone smokes pot and then they're like, wow, heroin is really a cheap price, I'm going to just jump to it. Usually they jump from another opioid. And what's interesting, the research shows that the economics of pills, as they started to, the supply started to diminish, as they became very expensive. Sam actually in his book Dreamland documents them being $1, $1.50 a milligram, which for an 80 milligram pill would be close to $100 for one dose. And so I just wanted to put it in the context that heroin had a lower price in the context of an inverse relationship to increasing prescription opioid costs. And those seem to be a really interesting relationship that was just left out of that. So that's a precursor to basically ask if you could really just talk a little bit more how prescription opioids created a market for illicit opioids. You said that in your statement that prescriptions created a market for opioids, and I'm really interested. Did you mean that kind of an iatrogenic crisis from high prescribing of opioids created, in economic terms, effective demand, so that increases in heroin are in relationship to the prescription opioid crisis, meaning there is a relationship between the two? If you could just elucidate that a little bit more, that would be great. Thank you.
Sure. Thank you very much for your question. Of course, I will be going out on a limb with some of these because the data will all be indirect and based on observational studies. We don't have experiments to help us understand these complex relationships. So I can't rely on randomized trials or other strong evidence for these relationships. So they will be subject to different interpretations of data. I think you raise a number of key points. One is that's important to keep in mind is that data do suggest that the transition from prescription opioids to heroin does occur. There are numerous studies documenting that transition, both local studies like ones out of Ohio, as well as national studies using retrospective information from the National Survey on Drug Use and Health and others. Suggesting that both medical and non-medical use of prescription opioids is a predictor of transition to heroin, particularly non-medical use. So while any use may increase risk, it's particularly non-medical use suggesting participation in an illicit market and potential use of other substances is playing a role. The percentage of people that transition to heroin is quite low. But I would agree with you that even a low percentage transition, if you have a very large number of, a very large initial population, can be a substantial number of people. What I mean by that is if you go back a few years, we see a very large number in terms of something in the many millions misusing prescription opioids a few years ago. And so even a small percentage of many millions still means hundreds of thousands potentially transitioning. The transition is particularly prominent for those who misuse opioids quite frequently, for those who exhibit the symptoms of an opioid use disorder, and for those with co-occurring other conditions, whether that's other psychiatric conditions or co-occurring substance use disorders, suggesting that it may be a progression of the underlying addiction that fuels that transition to heroin, as the decision-making that people experience as their addiction progresses makes it, in some ways, easier for them to make that very dangerous transition. I certainly agree with you that the economic issues are complex.
Thank you for that, Wilson. Very helpful.
Thank you. Mr. O'Brien?
Hi, yes, thank you. I'd like to, I guess, slide 8, addressing the question that was just posed, but in a little bit different perspective. And that is, as your expertise as a psychiatrist for those that are addiction, what I'm not clear on, I mean, I see the data with the transition from prescription to anything else, whatever it is, whatever the poly drug is that goes forward. But I guess from a psychological or psychiatric perspective, is that just a matter of convenience? In other words, is the person really seeking out opioids, or is it just the fact that it's available to them, whether it be in a cabinet or a prescription they get from a doctor or whatever for themselves? That two-thirds or that half, more than half that get it from their family and friends, is it just because it's there, or would they, if they didn't get that, would they be seeking it elsewhere in some other form, whether that be whatever of the other drugs that are available? And then I have a second question, but that's the first question.
Thank you. That's a wonderful question. There are complexities in this data. What I have shown for you is just the rate for the last prescription opioid that was misused. So this includes a broad range of persons, those who just misuse occasionally to those who misuse on a frequent basis or even have a pattern of addiction to their prescription opioids. When we subdivide this group by those who are have an opioid use disorder related to their prescription opioids, we see that there's a bit of a shift. They are still likely to obtain it from friends and relatives, but they have a much higher likelihood of obtaining it from drug dealers and from other sources. So that suggests to me, just as you alluded to, that the reasons for people using these may vary. Certainly we know that for first use, for initial use by teens and by young adults, availability may play a key role. So how easily available something is can play a key role in whether somebody will sample or begin down that pathway and experiment with something. If it isn't readily available, it may not be so easy to sample or experiment with. On the other hand, for those who are regular heavy users, they may obtain it from their friends and relatives when they can, but they will also use other routes, suggesting that it's no longer experimentation or purely availability, but it is an innate desire for that particular substance that's driving their use. Thank you.
Thank you. And the second question is relative to medical-assisted treatment. That is slides 33 and 34. And that is, I was curious in come-upon situations where the availability, one of the problems is the patients can't get the medical-assisted treatment, and the patient community, some of them, the problem they run against is that the provider doesn't want to take the REMS-related regulation education.
We lost Mr. Ryan.
Hello? Yes,
Yeah.
hello, can you hear me now? Okay, sorry. So I don't know how much you heard of that. I got muted somehow. But the question was regarding medical-assisted treatment. In the patient community, there's been experience how much that is the availability, accessibility, not being given. There's such a lack of that being available to patients who do want to get off, who recognize that they've gone beyond. I'm talking about chronic pain or acute pain patients who realize that they're taking the medication not so much now for their pain, but because they're having these symptoms of withdrawal when they come off of it. And the problem that I wanted to address, and I don't know if it's in any of the data with that, was the fact that prescribers were reluctant to take the training that's required in REMS because they didn't want to attract what they perceived as a group of patients that would be problematic for their staff and for their practice, et cetera. Is that just an isolated thing, or is that something that was evident in the studies?
Well, I would clarify that when you refer to REMS, actually what I think you mean is the buprenorphine waiver training, which is required for clinicians that want to be authorized to prescribe buprenorphine for the treatment of opioid use disorder. This actually was a very innovative program when it was implemented now nearly 2 decades ago to move opioid substitution treatment out of the opioid clinic programs, the so-called methadone clinics, and allow it to be practiced in general medical settings. So we have seen many, many clinicians take that training, but as you allude to, some are not interested because they fear that the patients will cause problems for their practice. They're not familiar and they don't have the support to take care of the patients, because it's not just prescribing medications that may be necessary, but it's also the myriad other services that people may need who have an opioid use disorder. So there are barriers to starting prescriptions and engaging in this medical practice. We have seen marked improvements in this due to increasing support through multiple federal initiatives. SAMHSA, for example, has allocated many millions of dollars to the states to expand medications for opioid use disorder, and we are seeing this make a difference. Interestingly, during the COVID pandemic, we've seen a relaxation of telemedicine and telehealth practices, which allow buprenorphine inductions. That means you can start patients on buprenorphine without having an in-person evaluation or physical exam. This is a remarkable change to healthcare practice. And we don't yet have data to show how well these work, but initial indications are that clinicians are taking advantage of them. And this is certainly something that we want to learn about, because that may be a way to expand access to populations that otherwise couldn't receive care. Thank you.
I think that's excellent. And it almost seems to me logical that if someone's going to prescribe a medication, they should be required to take the medication that allows them to get off the patient to come off. But anyways, thank you very much.
Thank you. This is a very interesting discussion, but we have just time for one quick clarifying and concrete question from Dr. Cortez.
Hello, Dr. Compton. This is Dr. Stefan Kertes from University of Alabama at Birmingham. Thank you for your entire presentation and also for noting the clarification of the CDC guideline and issues of taper. My question is whether NIDA has previously staged its own consensus panel or issued any statements on the value or on the lack of value of abuse deterrent formulations, either with this product, which would be oxycodone, or with the opioids in general. Has that come up in the history of NIDA's deliberations for the public?
In general, NIDA is not a policy-making or regulatory agency, so we would not provide that guidance. However, we do certainly have information on our website regarding abuse deterrent formulations and other issues related to the opioid crisis. We don't have a position regarding this particular issue, and we're eager to hear your deliberations this afternoon like everyone else.
Thank you very much. We will now continue with the FDA presentation.
Good morning. My name is Christina Green, and I am an epidemiologist at the FDA. Today I will be presenting the findings from our literature review on the impact of reformulated OxyContin on abuse and opioid-related morbidity and mortality. As discussed yesterday, the FDA required PMR studies 30511 through 30514 designed to assess the impact of OxyContin's reformulation on its abuse and risk of opioid overdose in post-market settings. To supplement and contextualize the formal PMR studies submitted by the sponsor and to better understand the broader public health impact of OxyContin's reformulation, the Division of Epidemiology conducted a review of peer-reviewed and selected gray literature examining the impact of reformulated OxyContin on opioid use, abuse, morbidity, and mortality. My presentation today will briefly discuss the methods used for our literature search. I will then go on to discussing the findings in the literature regarding the impact of the reformulation of OxyContin on dispensing, followed by the impact on non-medical use and other measures of abuse. I will then discuss non-oral abuse and opioid addiction, the substitution of other substances, impact on opioid overdose mortality, and other abuse-related harms. I will then summarize our interpretation of the literature in this area. We conducted a PubMed search of original research articles focused on abuse deterrent formulation, or ADF OxyContin, examining the impact of the reformulation on opioid use, misuse, abuse, morbidity, and mortality. We grouped these articles into two main categories. First, studies that use the same or similar databases and methods as one of the 4 PMR studies described yesterday. We will not discuss these further in this presentation. Second, non-PMR related studies, which we will focus on today. Of note, approximately half of these studies were funded or supported by Purdue or its affiliates. We also examined related review articles and editorials for any additional data that were not previously identified in our original search. I will now discuss findings from the literature on the impact of the reformulation on prescription dispensing. Consistent with the Division of Epidemiology drug utilization findings discussed previously, the literature identified that the number of prescriptions and prescription sales of OxyContin declined. Overall prescriptions for ER oxycodone decreased even more sharply as generics to original OxyContin exited the market contemporaneously with the introduction of the abuse deterrent formulation. One study also found that there was a decrease in average milligrams dispensed for OxyContin prescriptions. We also examined articles that explored the impact on prescription dispensing patterns among patients prescribed original OxyContin. Mishna used a retrospective cohort design in a commercially insured population to examine switching patterns in those dispensed extended-release oxycodone following the reformulation. The study found that 69% of patients continued to receive extended-release or ER oxycodone after the reformulation. 21% of those receiving original ER oxycodone switched to a non-abuse deterrent extended-release formulation after the introduction of reformulated ER oxycodone. 9% stopped receiving ER opioids after the reformulation, most of which switched to immediate release or short-acting opioids. This study did not examine the reasons for switching or discontinuation. Another recent study was published after completion of the literature review included in the briefing document that examined the changes in filling patterns following the reformulation among patients filling prescriptions for original OxyContin 80 milligrams. The study examined this change based on prescription drug monitoring program data from New York City, comparing the changes in fill patterns in the year of the reformulation to changes in the prior year. This study found that less than half of those prescribed original formulation OxyContin 80 milligrams continued to receive prescriptions for OxyContin after the reformulation. Approximately 40% of those receiving original formulation OxyContin switched to another opioid analgesic, and 14% did not continue to receive prescription opioids after the reformulation. In the year prior to the reformulation, however, 85% of those receiving OxyContin 80 milligrams continued to receive prescriptions at the same dosage and strength, with only 5% switching to another opioid analgesic. 71% of those who modified their prescription after the reformulation switched to oxycodone IR, or immediate release, 30 milligrams. Median daily morphine milligram equivalents decreased after the reformulation in both those who continued to receive prescriptions for oxycodone ER and those who switched to other opioid analgesics. There are several possible reasons unrelated to abuse that patients may have switched or discontinued OxyContin following the reformulation. In one U.S. study, providers reported that some patients complained about difficulty swallowing the reformulated product. These findings are consistent with post-marketing reports received by the FDA that resulted in the safety labeling change in 2015. Other study authors noted that physicians may also be less likely to prescribe abuse deterrent formulation OxyContin due to increased awareness of the risk of abuse. Several editorials also noted barriers to prescribing abuse deterrent formulations due to higher cost and lack of insurance coverage. Because of the complex and changing patchwork of insurance coverage in the United States, it is difficult to determine exactly how this impacted OxyContin prescribing and dispensing. Now I will discuss the reformulation's impact on non-medical use, as well as other outcomes such as street price, diversion, and doctor shopping. Several studies examined the impact of reformulated OxyContin on non-medical use of OxyContin in the general population using the National Survey on Drug Use and Health, or NSDUH. One study by Chang found that the reformulation was followed by modest declines in the initiation of non-medical OxyContin use in the United States. Non-medical use here refers to any use other than as directed by a healthcare provider. The graph to the right displays the observed and predicted trend of non-medical use of both OxyContin and other prescription opioids before and after the reformulation. The individual dots represent the observed annual non-medical use rates, and the solid line represents the modeled trend based on these observed annual rates. The dotted line represents the predicted post-reformulation trend based on pre-reformulation trends. The results suggest that initiation of non-medical use of OxyContin declined slightly compared to what was predicted based on the pre-reformulation trend. However, the initiation of other prescription opioid non-medical use also declined, although the modeled post-reformulation trend converges more closely with the trend predicted by the pre-reformulation trend. Fairly wide variability in the post-reformulation estimates is also apparent. A study by Jones also examined the impact of OxyContin's reformulation using NSDUH data, finding that the reformulation was associated with significant declines in the prevalence of non-medical OxyContin use from 2010 to 2013. However, the rate decrease was not significant until 2013, and post-reformulation rates were similar to those previously observed from 2006 to 2009. Of note, neither Chang nor Jones adjusted for reductions in OxyContin dispensing. Declines in OxyContin non-medical use appeared to be affected by the rate of non-medical use prior to the reformulation in the general population. In this figure, the different quartiles represent states with the highest and lowest rates of OxyContin misuse prior to the reformulation. The respective bars represent the change in the rate of OxyContin non-medical use between 2008 and 2012. We see here that the states with the highest rates of pre-reformulation non-medical use, quartiles 3 and 4, experienced the greatest decline. And in the states with the lowest pre-reformulation rates, such as quartile 1, there was a modest increase in reported OxyContin non-medical use based on national survey data. Several studies examined reported prices collected from an anonymous crowdsourcing website, StreetRx. One study found that the mean reported price paid for non-abuse deterrent oxycodone was 19% higher than abuse deterrent oxycodone formulations. However, this study compared prices at least 4 years following the reformulation, and as a result, these findings may not reflect changes in street price at the time of the reformulation. Another study used the same data source to compare the difference in street price of original and reformulated OxyContin. Here, the median price difference between original and reformulated OxyContin decreased over time, from 36% higher for original OxyContin in 2011 to 13% higher for the same formulation in 2015. One important caveat is that the time period examined was after the reformulation, and neither of these prices was compared to the price paid for original OxyContin prior to August 2010. Another caveat for both of these studies is that the reported street prices are not independently verified and are also subject to product misclassification. In a separate qualitative study, participants reported that reformulated OxyContin was cheaper due to the increased difficulty manipulating the product for abuse. A study by Severtson used data from the RADAR's drug diversion program to examine drug diversion based on recorded drugs in law enforcement cases. Investigators found that following the reformulation, the prescription-adjusted rate of OxyContin diversion cases declined significantly more than that of cases involving other opioids. Drug diversion data are based on cases associated with arrests or street buys reported by a convenient sample of participating drug diversion investigators. These are therefore a measure of law enforcement activity and it's not entirely clear to what degree these case numbers represent actual levels of diversion or abuse of these products in the community. The impact of the reformulation on doctor shopping rates was also examined using pharmacy claims in one study, which defined doctor shopping as overlapping prescriptions from at least 2 prescribers and at least 3 pharmacies. According to this study, the rate of doctor shopping decreased 50% for OxyContin after the reformulation, but a similar decline was not observed for comparators. It's important to keep in mind that measures of doctor shopping may not necessarily indicate abuse. We are unable to ascribe a motive for seeking medications from multiple prescribers and pharmacies, and while it is likely that some individuals who engage in this behavior are seeking drugs for the purpose of abuse or diversion, doctor shopping metrics have not been well characterized as a measure of abuse. I will now discuss the findings relevant to the impact of the reformulation on non-oral abuse and opioid addiction. Several U.S. studies in our review describe decreases in non-oral OxyContin abuse in 2 populations with a high prevalence of non-oral opioid abuse. Both of these studies, however, relied on retrospective report and recall of past abuse behavior. A study by Havens measured the impact of OxyContin's reformulation in individuals who had abused original formulation OxyContin using serial cross-sectional interviews that asked about recent abuse of oxycodone. They found that reports of past month snorting and injecting of OxyContin decreased from the time of the reformulation to a later time period spanning from December 2010 to September 2011. A study by Cicero to individuals entering treatment for opioid use disorder who reported abusing both original and reformulated OxyContin. Among these participants, 43% reported switching from injecting or inhaling the drug to swallowing it whole following the reformulation. The Australian NOMAD study examined a prospective cohort of individuals who tamper with prescription opioids and a variety of other data sources to assess the impact of OxyContin's reformulation on multiple opioid-related outcomes. 3 months prior to the reformulation, 55% of individuals in the prospective cohort reported past month non-ADF 80 milligram OxyContin injection. Yet 1 year after the reformulation, 2% of these individuals reported past month injection of the reformulated OxyContin product. Reported injection of other drugs also declined to a lesser degree, and the study did not account for other factors that may have impacted abuse behaviors, such as participation in treatment or changing availability of OxyContin and other opioids. Additionally, safe injection site data from Sydney showed a decline in the number of visits to inject OxyContin after reformulation. Given individuals selected for the cohort study were already tampering with prescription opioids, this study provides no information on whether the reformulation deterred initiation of non-oral abuse of OxyContin. Now I will describe several studies that examine the impact of OxyContin's reformulation on opioid addiction. Using serial cross-sectional NISDA data and a difference in differences design, Wolf compared multiple outcomes in individuals who used OxyContin non-medically prior to the reformulation to those who non-medically used other prescription pain relievers during the same period, defining pre-reformulation use as reportedly occurring prior to 2011. Authors found pre-reformulation OxyContin non-medical use was not associated with a change in the prevalence of prescription pain reliever use disorder after the reformulation. However, there were several methodological limitations. Because different participants were surveyed each year, there was no longitudinal follow-up to allow estimation of the incidence of substance use disorders. There may have been several sources of bias. First, there was a variable time interval between the reported initiation of non-medical use and the time that the outcome was measured. Second, there may have been underrepresentation of individuals who used original OxyContin non-medically and developed more serious outcomes, such as advanced opioid use disorders leading to homelessness, incarceration, residential treatment, or fatal drug overdose. A retrospective claims cohort study by Mishna attempted to examine the impact of the reformulation on opioid addiction using opioid abuse and dependence as an outcome. Investigators found higher rates of health insurance claims coded as opioid abuse in patients who switched or discontinued treatment of extended-release oxycodone after the reformulation. The rates of these opioid abuse claims were highest among those who switched to immediate-release or short-acting opioids. However, investigators did not capture cash purchases or claims submitted to other insurers. It's important to note that administrative claims-based algorithms that use opioid abuse and dependence codes have not been found to accurately identify opioid abuse and addiction. I will now discuss the impact of the reformulation on the substitution of other substances. Several studies reported on OxyContin's reformulation's impact on the substitution of other prescription or illicit opioids. The serial cross-sectional study by Havens found that the reported prevalence of immediate-release oxycodone abuse increased after the reformulation, including a 64% increase in the prevalence of injection and a 50% increase in the prevalence of insufflation of oxycodone immediate release. A study by Cicero reported that 1/3 of individuals entering treatment for opioid use disorder, any lifetime abuse of original OxyContin, reported replacing OxyContin with other drugs following the reformulation. 70% of those who replaced original OxyContin switched to heroin. Again, in both of these studies, pre-reformulation use was measured retrospectively, as study participants were surveyed after OxyContin's reformulation, potentially introducing recall bias. Two analyses of internet posts also found that OxyContin's reformulation led some individuals to switch from OxyContin to heroin and other prescription opioids. However, because the internet is dynamic and the samples featured in these studies are undefined, it is not clear how well these results are representative of individuals who abuse OxyContin or other opioids. Australian data provided mixed results regarding shifts to heroin after the introduction of OxyContin's reformulation there in 2014. Based on an annual serial cross-sectional survey of individuals who report injecting drugs, the proportion of individuals reporting past 6-month heroin injection remained stable. Data from a safe injection site in Sydney showed a 3-fold numeric increase in visits to inject heroin from the time of the reformulation in April 2014 through January 2016. However, the mean pre-post change in visits was not statistically significant. A separate study found increases in heroin-related ambulance encounters and emergency department visits following the introduction of the reformulation in Australia. A U.S. study by Carlson examined heroin initiation over a 3-year period from May 2010 to May 2013 in a cohort of young, non-dependent individuals misusing prescription drugs in Ohio. Investigators found that all individuals who initiated heroin over the follow-up period reported misuse of original OxyContin, yet among those who did not initiate heroin, only 46% of individuals reported past misuse of original OxyContin. Investigators also found non-oral use of prescription opioids was strongly associated with heroin initiation. However, investigators were unable directly to measure the effect of OxyContin's reformulation on heroin initiation. As discussed previously, a study by Wolf used NISTA data to compare multiple outcomes in individuals who used OxyContin non-medically prior to the reformulation to those who used other prescription pain relievers non-medically during the same time period. Investigators found that pre-reformulation OxyContin misuse was not associated with a post-reformulation change in the prevalence of heroin use or heroin use disorder. However, investigators did find that heroin initiation increased in both groups, yet this increase was smaller among people who had used OxyContin non-medically prior to the reformulation, compared to those who had used other prescription pain relievers non-medically prior to the reformulation. I will now discuss findings relevant to opioid overdose following the reformulation. In a study by Sussler, authors used spontaneous reporting data reported to Purdue Pharma to assess the impact of OxyContin's reformulation on overdose deaths by conducting a time series analysis. There were 326 reported fatal cases that met selection criteria, which included the requirement that there was reports that mention a specific date of death. The decline in case reports appear around the second year after the reformulation, marked by the green vertical line in the figure. Although statistical analyses by the authors supported a significant change in trends at the time reformulated OxyContin was introduced, FDA reviewers noted serious flaws in the methodology. Foremost among these is that spontaneous reporting of exposures and outcomes cannot be used to estimate incidence or make inferences regarding trends. Reported cases do not represent totality of events occurring in the general population. Many factors can influence reporting of adverse events, and reporting may decline over a product life cycle. In this analysis, the author's case selection criteria could have biased results, as the authors selected only reports with a date of death included and excluded reports associated with litigation, which may have increased in recent years. And finally, there was no appropriate comparator used to account for variability in reporting. 2 U.S. studies evaluated the impact of the reformulation on prescription opioid overdose deaths. These studies found mixed evidence on OxyContin's reformulation's impact on prescription opioid-related mortality. A study by Evans used structural Sorry about that. A study by Evans used structural break techniques to evaluate the impact of the reformulation on prescription opioid-related mortality, finding the decline in prescription opioid mortality in areas with higher exposure to oxycodone and lower exposure to heroin prior to the reformulation, suggesting that the availability of heroin might be an important factor in assessing the reformulation's effect on this outcome. It's important to note, however, that this particular study relied on oxycodone shipment data rather than on rates of OxyContin non-medical use. A study by Alpert found a small, non-significant decrease in prescription opioid-related mortality in states with higher rates of previous OxyContin non-medical use. However, the study did not account for the changing availability of prescription opioids. Several ecological studies estimated the impact of OxyContin's reformulation on heroin overdose in the U.S. These studies found that states with high pre-reformulation rates of oxycodone shipments, non-medical OxyContin use, and heroin deaths experienced larger increases in heroin-related deaths after the reformulation. 2 of these studies also examined pre-reformulation levels of non-medical use of other prescription opioids and found no association with increases in heroin-related deaths. In each of these 4 studies, the authors concluded that OxyContin's reformulation significantly contributed to the increase in heroin overdose deaths at an aggregate level. This figure illustrates how heroin mortality rates changed based on pre-reformulation oxycodone shipments and heroin availability. In this study by Evans, heroin mortality rates served as a proxy for heroin availability in the region. Overall, investigators found a statistically significant upward inflection in heroin-related overdose mortality trends 1 month after the introduction of ADF OxyContin, yet increases in heroin mortality differed based on the previous rate of heroin deaths. States with above median oxycodone shipment rates and above median heroin mortality rates prior to the reformulation experienced a greater increase in heroin deaths. Yet all states experienced some degree of increase in heroin mortality following the reformulation when compared to the previous or baseline heroin mortality rate. 2 related studies evaluated the impact of reformulated OxyContin on overall opioid-related mortality. A study by Alpert concluded that OxyContin's reformulation did not impact overall opioid overdose rates in the U.S. through 2013. A subsequent study using similar methods by Powell estimated that the reformulation's contribution to increasing synthetic opioid mortality further offset any reduction in prescription opioid deaths attributable to OxyContin's abuse deterrent formulation. Powell also found that overdose deaths involving synthetic opioids increased more in states that had higher pre-reformulation rates of OxyContin misuse, whereas this association was not seen for other prescription pain relievers. There are several considerations to take into account. In the U.S., efforts to address unregulated pain clinics, such as the Florida pill mill crackdown, were implemented around the same time as the reformulation. Evans estimated that the Florida pill mill crackdown explains at most 25% of the observed increase in heroin mortality after the reformulation. Additionally, the complex mixture of data limitations, concurrent interventions, and secular trends make it difficult to determine the exact contribution of OxyContin's reformulation to U.S. opioid mortality trends. The impact of the reformulation on overdose appears to depend in part on the local environment, including the availability and use of other opioids, as well as other local policies. I will now discuss other abuse-related harms potentially associated with the reformulation, specifically hepatitis C transmission. Evidence of other adverse effects, particularly infectious complications of drug abuse, possibly related to OxyContin's reformulation, is limited. We found 2 studies that noted an association between higher pre-reformulation OxyContin misuse rates and greater increases in post-reformulation hepatitis C infection rates at the state level. One of these studies also examined pre-reformulation levels of non-medical use of other prescription pain relievers and did not find this same association. While the literature on this outcome is currently limited, there is growing interest in investigating infectious disease transmission and other injection-related adverse outcomes following the reformulation. I will now provide a summary and FDA's interpretation of the literature. There are several limitations in the studies we reviewed that preclude the ability to draw firm conclusions regarding the impact of the reformulation. No U.S. studies reviewed had published pre-specified protocols. Although this is common for observational studies in the peer-reviewed literature, the inability to distinguish between pre-specified and post-hoc analyses limits our understanding of the rationale for comparator, time period, and outcome selection, and the extent to which negative findings were not published. Many studies also provided limited detail on methods, and there was considerable variability in both how the exposure and outcome was defined across different studies and time periods. Many studies also consisted of non-representative samples of participants, resulting in limited generalizability of study participants. Multiple studies relied on participant recall of past abuse behaviors, introducing potential recall bias. Several studies used unvalidated outcome algorithms through the use of insurance claims-based abuse and addiction measures. And finally, many studies used ecologic study designs. We cannot make individual level inferences based on group level associations reported in such studies. Despite noting some serious limitations, the review team found that the literature supports the hypothesis that OxyContin's reformulation reduced its attractiveness for abuse and diversion in populations who abuse prescription opioids non-orally. Studies suggest that there were modest declines in OxyContin non-medical use in the general population after reformulation. However, it remains unclear how much of this decline was due to the abuse deterrent formulation and not other factors, such as reductions in prescription dispensing. Studies also suggest that while some individuals substituted different prescription or illicit opioids in place of OxyContin after the reformulation, these substitution effects varied across populations, based in part on baseline substance abuse patterns and drug availability. The literature also provided no reliable evidence on the impact of OxyContin's reformulation on the risk of addiction. Ecologic studies suggest neutral or possibly adverse impact on fatal opioid overdose, implying that any decreases in fatal prescription opioid overdose due to the reformulation may have been offset or more than offset by increases in fatal illicit opioid overdose due to substitution of other opioids. Additionally, similar ecologic analysis suggests that OxyContin's reformulation contributed to increases in hepatitis C infection in the United States. However, it remains difficult to determine the exact causal role of OxyContin's reformulation in these trends due to data limitations, concurrent interventions, changes in geographical heterogeneity in heroin availability and use, and the complex drivers of drug abuse behaviors. Thank you for your time. This concludes my presentation. My colleague, Dr. Jana Makinich, will now discuss the FDA's summary of the post-marketing findings.
Hi, good morning again. This is Jana Makinich. I'm a senior medical epidemiologist at FDA, and I'm going to summarize the FDA review team's overall interpretation of the post-marketing data. Wait a moment for my slides. Okay. You've heard a lot of information over the past day and a half, including a high-level summary of the experimental evidence supporting OxyContin's abuse deterrent labeling and the regulatory history related to the required post-marketing studies. You heard about how a public health systems approach can be used to consider the broader public health impact of OxyContin's reformulation. Our guest speaker, Dr. Dasgupta, discussed some of the scientific issues in conducting and interpreting post-marketing studies in this area. And then you heard the sponsors and FDA's interpretations of the PMR study results. This morning, you heard about how the opioid crisis has grown and changed over the years since reformulated OxyContin was developed and introduced to the market. And finally, you just heard the findings of FDA's review of the published literature in this area. In this presentation, I will attempt to summarize the FDA review team's overall findings on the effectiveness and the public health impact of OxyContin's reformulation. Given the number, heterogeneity, and methodologic challenges of these post-marketing studies, our approach was to make a reasoned qualitative synthesis of the totality of evidence, including an assessment of the strength of the evidence using fundamental principles of epidemiology and causal inference, including such considerations as temporal association, the range of possible effect sizes based on different models and definitions, the consistency of findings both within and across studies, and whether the findings align with the evidence from the Category 1 through 3 studies. We consider the possibility of alternative explanations for observed reductions, such as other concurrent interventions, secular trends, and selection bias. And finally, we consider the overall quality of the data and whether statistical methods were appropriate. The primary goal of the required post-marketing studies was to determine whether the evidence shows that OxyContin's reformulation reduced its abuse by specific routes of administration as predicted by the experimental studies. This question relates to the safety of OxyContin as a regulated medical product. But as a public health agency, we must also consider the broader public health impacts of this intervention, particularly in the setting of an ongoing and evolving public health crisis. Viewing the issue through this wider lens includes consideration of multiple outcomes, the potential for varying impacts across different populations, unintended consequences, and the complex system of interrelated clinical, sociocultural, and economic factors that drive behavior. I will now summarize the FDA review team findings. First, a few reminders of what we saw with respect to prescription trends and patterns. These data provide important context for interpreting results of the other epidemiologic studies and are in themselves an important part of understanding the overall impacts of the reformulation. Both before and after its reformulation, OxyContin has represented a small fraction of the opioid analgesic market in the U.S. Following its reformulation, there was a steady decline in OxyContin dispensing, with decreases in prescribing of other opioid analgesics generally not beginning until 2 to 3 years later. Initial declines in OxyContin dispensing were greatest for higher dosage strengths, particularly the 80 milligram tablets. Many patients discontinued OxyContin after its reformulation, most of these switching to other opioid analgesics, and the total milligrams per OxyContin prescription declined. As we've touched on at various points in the presentation, there are few empiric data on the reasons for these observed changes, but there are a number of plausible contributing factors. First, of course, is the reduced demand for purposes of abuse or diversion, with some patients self-selecting away from OxyContin due to the product's abuse deterrent properties. With the contemporaneous exit of generics from the market following settlements of patent litigation lawsuits, however, there may also have been changes in insurance coverage and costs to patients. Because of the fragmented nature of health insurance in the U.S., we don't have good data on this. At the time of the reformulation, there were already shifts occurring in the opioid analgesic market. In particular, we saw increases in prescribing of immediate single-entity oxycodone that predated the reformulation and have continued since then. Around the time of OxyContin's market transition, there were also large-scale efforts to reduce unlawful opioid prescribing, most notably the multifaceted interventions to shut down the rapidly proliferating Florida pill mills. There may also have been increases in prescriber awareness of OxyContin's abuse risk, for example, as a result of communications associated with the OxyContin Risk Evaluation and Mitigation Strategy, or REMS, that was approved at the time of the reformulated product approval. And finally, there were post-marketing reports of excipient-related problems with the abuse deterrent formulation, such as choking and difficulty swallowing the pill, that may have influenced the choice of opioid analgesic for some patients. Despite the various study limitations, the review team found the evidence to be fairly compelling that the reformulation reduced abuse of OxyContin by non-oral routes, including both snorting and injecting, relative to the original formulation. Although we did not think that the magnitude of effect could be easily quantified due to the range of estimates across analyses and studies, the uncertain influence of other factors on prescribing trends, and variable data quality. The strongest data supporting this conclusion came from PMR1, the NaviPro ASIMD study, which included people being assessed for or entering substance abuse treatment. PMR2, which analyzed calls to U.S. poison control centers, as well as several studies in the published literature, including some of the work done in Australia, provided corroborating evidence for this finding. The estimated effect sizes varied widely, both within and across studies, depending on the study population, the choice of comparators, adjustment for utilization, site inclusion criteria, and other study parameters. We also found that these reductions were observed primarily in populations with more advanced substance use disorders or who were already tampering with prescription opioids to abuse them through non-oral routes. We did not find the evidence to be robust that the reformulation reduced overall OxyContin abuse. In PMR1, this was reflected by a range of effect estimates that included both increases and decreases in overall OxyContin abuse rates relative to comparators. There was also a suggestion of some shift toward oral routes of abuse in this population. In the RADAR's Poison Center study, the large majority of OxyContin abuse calls involved oral abuse, both before and after its reformulation. We did see reductions in overall abuse calls involving OxyContin, but also large reductions for multiple comparators. Decreases in the population-based abuse rates were greater for OxyContin than for comparators, but this was not true for models that accounted for changes in utilization. We also saw large declines in rates of other non-abuse related calls, both for OxyContin and for comparators, even after adjusting for changes in drug utilization. Given all of these findings, it was difficult to determine whether the observed reductions in overall OxyContin abuse were largely due to the abuse deterrent formulation versus other factors. The overall abuse findings were also mixed in PMR3, the RADAR's treatment center study, which studied people entering treatment for opioid use disorder. As in PMR2, large reductions in abuse rates were seen for OxyContin as well as comparators. Decreases in population-based abuse rates were greater for OxyContin than for comparators, but not in those accounting for changes in the number of tablets dispensed. There's been a lot of discussion in the last 2 days about the appropriateness of these utilization-based or adjusted abuse rates or ratios. And this is not surprising, as this has been a subject of debate in this area for many years. I want to note that this is not a new concept that you need to somehow adjust for different levels of community level availability of a drug when trying to compare its intrinsic abuse liability to other drugs. The RADARS program has been doing this for years using a variety of utilization denominators. The basic concept is that if one drug is less likely to be abused than another drug, then for a given amount of drug dispensed from pharmacies into communities, you should see fewer cases of abuse. If after the reformulation, less OxyContin was being dispensed to people who were diverting or abusing it, then the pool of people getting the drug should be less likely to abuse or divert it, and you would expect the number of abuse cases per tablets dispensed to also decline to some degree. We certainly recognize the crude nature of this metric and the assumptions of linearity that it forces, which may not be met, particularly at very low or very high levels of dispensing. In the reissued PMRs, we asked that the sponsor propose different methods for accounting for utilization, which gave us Model 3, which adjusted for utilization as a variable in the regression models. While this provided more flexibility, it required different assumptions and had some additional issues, which Dr. Lee outlined in her memo in the briefing document. So to be clear, this was just one of many factors that we considered in our overall assessment of the strength of the evidence. The team also found the evidence from the published literature to be relatively weak with respect to the ADF meaningfully reducing overall OxyContin abuse. Studies analyzing national survey data reported modest declines in self-reported non-medical use of OxyContin in the general population, with non-medical use or misuse here defined as any use other than as directed by a healthcare provider. The observed declines largely mirrored decreases in OxyContin prescriptions, and substantial declines in non-medical use of other prescription opioids were also observed. Therefore, it was again difficult to determine how much of the observed decrease was directly attributable to OxyContin's abuse deterrent properties. Several studies also suggest that the reformulation reduced OxyContin diversion and doctor shopping. These data do provide some indirect evidence of decreased OxyContin abuse levels in the community overall, but they are not a direct measure of abuse and have many other limitations. A third review finding was that relative to the amount of drug dispensed from pharmacies, rates of both overall and non-oral abuse of reformulated OxyContin remained relatively high among the prescription opioids examined. This was seen in all three of the PMRs examining abuse rates, but it is important to keep in mind that such direct cross-sectional comparisons of drugs must be interpreted cautiously due to the non-representative samples, missing formulation data, and the potential for product misclassification in these studies. Nonetheless, this observation is a reminder that OxyContin's abuse deterrent formulation was evaluated in comparison to the original formulation that was removed from the market and not to otherly currently marketed opioid analgesics. Thus, while the reformulation does appear to have improved the safety of OxyContin with respect to non-oral abuse of the product, the evidence does not indicate that abuse-deterrent OxyContin is necessarily safer than other marketed opioid analgesics. Our fourth main finding was that it remains unclear if OxyContin's reformulation had an overall public health benefit. This finding has multiple components. As I noted previously, the strongest evidence for a reduction in non-oral OxyContin abuse came from populations with more advanced substance use disorders. For example, in people being assessed for treatment who were identified as having moderate to severe addiction or who were recruited because they were already tampering with prescription opioids prior to the reformulation. The benefit of the ADF is not entirely clear in these populations where polysubstance abuse is common and where substitution of other opioids is likely. Published studies indicate that some substitution did occur, including both prescription opioids and heroin after OxyContin's reformulation. Data from the RADAR's Poison Center and Treatment Center PMR studies also showed increases in heroin abuse rates shortly after OxyContin's reformulation, although these studies were not designed to assess a causal association between the reformulation and increases in reported heroin use. It is certainly possible that the ADF deterred non-oral OxyContin abuse and reduced harms in those without advanced substance use disorders and who were not already regularly abusing by non-oral routes, but we have little evidence to support this hypothesis. Although the absence of evidence does not imply evidence of absence, it is important to note that we do not have and probably never will have direct evidence on whether OxyContin's reformulation reduced the risk of abuse in patients dispensed the drug. We also have no data on whether the abuse-deterrent formulation reduced initiation of snorting or injecting, either in patients or others. And finally, we do not have evidence on whether OxyContin's abuse-deterrent properties slow the progression of opioid use disorder or reduce the risk of new addiction, either in patients or others using the drug. Overdose is clearly an important public health outcome. And again, the impact of the reformulation on this outcome is not straightforward and may vary in different populations. PMR4, the claims-based study, provided some new evidence on the impact of OxyContin's reformulation on the risk of fatal and non-fatal overdose among insured patients who were dispensed the drug. This study found no evidence that the reformulation reduced the risk of opioid overdose in patients dispensed OxyContin overall. In the subset of patients dispensed OxyContin alone with no other opioids, the results were more favorable. However, the implications of this finding with respect to public health impact are not entirely straightforward. First, the effect estimates were only significant in the commercial claims cohorts and not in the Medicaid cohort where overdose rates are higher. Second, OxyContin use without any other opioids is relatively uncommon. And finally, it is possible that patients receiving the ADF were at lower risk of overdose due to a lower prevalence of substance use disorders and risky drug use behaviors, or because they were prescribed lower doses of OxyContin. Such a change in the risk profile of the OxyContin user cohort could occur if higher risk patients seeking to abuse OxyContin migrated away from this product, or if prescribers increasingly chose alternative analgesics for patients they perceived to be at higher risk of abuse or overdose. The former would be consistent with an abuse deterrent effect, but it is less clear whether a lower incidence of overdose in a lower risk user population means that the ADF reduced the risk of opioid overdose, either in patients getting the reformulated product or in patients who avoided it due to its abuse deterrent properties, particularly if they switched to other opioids, either prescription or illicit. TMR4 looked at the risk of overdose in patients dispensed OxyContin, but we know that others also access prescription opioids through diversion. Several published ecologic studies have examined the impact of OxyContin's reformulation on population trends in opioid overdose more broadly. These studies have suggested that the reformulation had a neutral or possibly adverse impact on opioid overdose in the United States. The overdose studies conclude that any decreases in prescription opioid overdose due to the reformulation were offset or more than offset by increases in illicit opioid overdose due to substitution effects. Analyses using similar methods suggest OxyContin's reformulation contributed to increases in hepatitis C infection in the U.S. Still, despite these studies' use of methods to try to control for other factors, it remains difficult to determine the exact causal role of OxyContin's reformulation in these trends, given data and design limitations, concurrent interventions, such as the efforts to close down the pill mills, changes and geographic variation in the availability of heroin and later in illicitly manufactured fentanyl, and the complex drivers of drug abuse and addiction. Before I close, I just want to touch briefly on a couple of other considerations related to unintended effects of the reformulation. These have been mentioned briefly and are discussed in more detail in your briefing document. They are also described in the OxyContin label. Following the reformulation, the agency began to receive reports about difficulties swallowing OxyContin pills, including choking, regurgitation, and tablets getting stuck in the throat, as well as rare reports of intestinal obstruction. FDA has also received 6 reports of thrombotic microangiopathy, or TMA, in individuals who have used the reformulated products intravenously. This problem was reported earlier and in higher numbers for the reformulated oxymorphone product, Opana ER, that has since been removed from the market. Opana ER, like OxyContin, used polyethylene oxide, or PEO, for its hardening and gelling properties. Although spontaneous reports cannot be used to estimate the incidence of an adverse event, the low number of reports for OxyContin over a 10-year period suggests that this may be an infrequently occurring event. FDA-supported work is ongoing to better understand risks associated with injection of products containing PEO, but laboratory studies to date suggest that the risk of TMA may increase with higher molecular weight PEO, such as that used in the reformulated Opana ER product. In summary, the review team concluded that despite the many scientific challenges and data limitations, the evidence is fairly compelling that the reformulation reduced OxyContin abuse by non-oral routes, including both snorting and injecting, relative to the original formulation, thereby qualitatively confirming the findings of the Category 1 through 3 studies. The effects on overall OxyContin abuse and overdose risk are less clear. Uncertainty remains about the overall public health impact of OxyContin's reformulation. Impacts likely varied across different populations, in part depending on the severity of substance use disorders in the population and the availability and use of substitute opioids. The reduction in non-oral abuse was observed primarily in populations with more advanced substance use disorders, where polysubstance abuse is common and where there appears to have been some unintended consequence, including substitution of heroin and other illicit opioids. Finally, it is possible that the ADF has reduced non-oral abuse and associated harms in non-dependent patients and others who are not already abusing via non-oral routes. But based on our review of the available evidence, we concluded that the impact of the ADF on the initiation of snorting or injecting, on the progression of opioid use disorder, and on the incidence of new addictions remains unknown. We very much look forward to hearing input from the public and the committee members' perspectives and interpretations on the information that has been presented. This concludes my presentation, and we will now take clarifying questions. Thank you. So we will not take clarifying questions for the FDA, but please remember to use the raise hand function to state your name for the record and then to lower your hand when you are done. Thank you. Okay. Any clarifying questions? Dr. Coffin.
Hi, thank you both for excellent presentations. This is a question targeted at Dr. Green. There was, I apologize, I don't recall the slide or the study author, but there was one paper that you mentioned that suggested that the reformulation may have been associated with the emergence of the increase in synthetic opioid overdose. I've always pondered that as it's certainly separated by several years, so it's a little hard to tie the spike in fentanyl overdose mortality to the reformulation. However, I've always wondered if there was sort of a supply and demand issue, given the number of people who were previously opioid dependent and then didn't have access to opioids, and I don't think it's only the reformulation. There were all the other activities that went on as well. That kind of created the need for more opioids in the illicit supply that spurred the fentanyl market. But I'm curious on that paper if you have any additional insights from that could help us.
Yes, sure. If you don't mind going to slide 31 in my presentation. That's the Powell 2020 study. So yes, so what this study was basically doing, they did an analysis very similar to the other Alpert paper that only looked at the outcome until 2013. And the Alpert paper wasn't really able to find an association with synthetic opioid overdose because that didn't really kick off until after 2013. Powell, however, looked at the pre-reformulation OxyContin non-medical use rates at the state level from 2004 to 2008, and they measured that against the rate of synthetic opioid overdose deaths, finding that there was a big increase in 2013. So they found that higher rates of OxyContin non-medical use prior to the reformulation were associated with higher rates of synthetic opioid overdose deaths. Now, obviously, there is that time difference, but that's just what that paper did. They did find that association because they looked at the outcome over a longer period of time.
Thank you.
Dr. Spence. Dr. Spence, you have a question? Okay, we may be having, yeah.
My apologies, this is Dr. Sprintz. I got dropped off and then I'm back.
Yes, please state your name and your question.
Perfect. Hi, this is Dr. Michael Sprintz, and my question is for Dr. Green, and it's relating to slide 15. I was curious about actually two questions. My first question was about the GI problems and the ADF excipient related risks. And my question was that, when the patients made the complaints about choking, were they asked about the context of the situation? Did FDA gather that? Meaning were these patients who previously crushed OxyContin for patients with dysphagia and other issues, or did we not get that information?
So are you referring to the study? Are you referring to Dr. McInich's presentation?
No, I'm
Dr. McInich.
Oh, my
sorry,
apologies. My apologies. Yes, I am. Sorry about that.
So there's sort of two sources of information on this, and one was a published study that Dr. Green mentioned where providers reported that their patients were complaining about this issue, and I think there really was not very much detail provided in that paper. Would you agree with that, Dr. Green?
Yes, I would.
Okay. And then second, there was an FDA review of FAERS reports, of spontaneous reports of this problem. And to speak to that and any further details about those cases, I would like to ask if Dr. Munker from our Division of Pharmacovigilance might be able to comment on that. Maybe she's not able to open her phone line.
Well, this is helpful. I mean, and that was
Mm-hmm.
part of my question, because a lot of times in my own clinic, I have found that there's a lot of times patients will make generalized complaints about something if there's a medication that they don't necessarily want, but versus true adverse events where I don't necessarily have evidence of anything at that point. And so I was curious how well it was pursued. And it sounds like I got my information on that one. Thank you. And
yeah,
my second question.
I would just say it was thought to be likely enough to be causally related to the product itself that it was included in the OxyContin label, but certainly in those reports there's often limited detail. So we're just sort of limited to what you get from the reports in terms of interpreting the patient's motivation or things like that.
Great. Yeah. Thank you. I appreciate that. And on the TMA with the thrombotic microangiopathy, what was the limit that the FDA looks at? Where Opana was pulled from the market, and there were probably more than 6 reports. But I'm curious how the FDA made the decision not to pull OxyContin for reports of this, and they did Opana. And am I missing more information? I'm assuming that I am.
Sure. So I just want to make clear that the reports of the thrombotic microangiopathy were not the sole reason that product was removed from the market. There was a fairly clear observed shift among people who are abusing the product from the insufflation to injection routes, and then that injection was also associated with a number of adverse consequences, including this thrombotic microangiopathy, as well as the HIV outbreak that actually Dr. Compton mentioned. So it was sort of a whole constellation of circumstances that led the FDA to make that decision. There were substantially more cases. The number was around 60. I don't have it exactly in my head, but it was on the order of 10 times more cases than, somebody just said 59 cases, than has been seen for the whole marketing period for OxyContin. We can't make really direct comparisons of incidents based on these spontaneous reports, but as I mentioned, the relatively low number that we have gotten for OxyContin suggests, that this is relatively infrequently occurring with this product.
Okay. Yeah. Thank you. That was interesting how the ADF formulation of Opana actually led to, on a larger scale, while it did what it was necessarily supposed to do, led to a public health problem with increased deaths as an indirect consequence. So thank you for that.
Thank you. Dr. Sibel?
Hi, thank you so much. This is actually a great transition. I'm really excited about this slide. We've been talking for a day and a half on abuse deterrence, but we haven't actually talked about the abuse deterrence and the actual incipients used in that, and if they cause harm for consistency, looking at Opana, I think it's important to look at the abuse deterrent formulation, and if people trying to manipulate that, those are putting themselves at increased risks. The person who just spoke, not the FDA person, but the person on the committee, really brought up a really salient point. I just want to thank him for that. There's two real things that get in the way of people crushing pills and injecting them, and one is the anti-crush mechanism, which is the polyethylene oxide, PEO, the high molecular weight of that's compressed really forcefully, and it's impossible to crush a pill. And that's one thing that is very impressive with the new the reformulation OxyContin. I've done research all over the country and observed people trying to crush them, and it's nearly impossible. Once they were crushed, they add water to them. The hydroxyethyl cellulose that's in the product, that is a part of a timer X, and that allows for the extended release as the drug goes through your body. The kind of heterodispersed polysaccharides regulate water penetration into the tablet, and they create a gel layer. When you take that pill and put it in a cooker and you add water to it, the same thing happens. It gels. And what we found with Opana, and we did this research as part of the investigation in Scott County with CDC, is we found that people could just add more water and override the cellulose. It's kind of like a sponge. If it fills with water, then the water flows out, and they were able to make a solution by adding more water. But what that did is it created a really big drug solution that they couldn't inject in one injection episode. And so they either injected multiple times to finish that, putting them at risk, or it provided the ability to share the supply. Now you have 3 or 4 shots in one solution, and that's what we believe actually contributed to HIV transmission. And so since those same products are used in this medication, I think it behooves us really to think about what is the evidence related to that. And the one thing, and this is leading up to my question, I know it's verbose, I apologize. The one thing that I think that the reformulation did is it really did successful anti-crushing. And that really distinguishes Opana in this context from OxyContin. Opana could be crushed, and then you just had to deal with the gelling. OxyContin is very, very difficult, almost impossible to crush. And when I asked pharma before, it's that their answer was that there's different levels of cost and expertise for the anti-crushing, and if you go a little cheaper route, it's not as good. And so it's a little more expensive to do the high molecular weight, PEO. And so this is all to say for FDA, and I should have asked this question yesterday, is the reformulated OxyContin that's on the market now using that same PEO in the original reformulation, meaning when the reformulation happened in 11 and 12, and they used that anti-crush mechanism, is it the same anti-crush mechanism that they use today? Ergo, is it equally difficult, or have they changed that from that original formulation? Sorry for the long, verbose question.
This is Dr. McInerney. I don't have an answer to that question. Maybe this is more a question for the sponsor, for Purdue, because I think that is proprietary information that we don't have.
Are they present, or did I miss that because of yesterday? Should have asked it yesterday.
No, we have to be recognized. Sponsor's here. There's a question for the sponsor related to whether the PEO and the manufacturing process is currently the same as it was in 2010 at the time of the reformulation. Is that, am I understanding the question correctly?
Exactly.
Okay.
Yes, you are. Thank you.
Thank you. Thank you. This is Jennifer Giordano with Purdue Pharma. Yes, the formulation has remained the same since 2010 with regard to the molecular weight
of the polyethylene oxide.
Great.
Perfect.
Thank you.
Thank you. So, Dr. Holman.
Yeah, thanks. This is Dean Fulman from NIH. I wanted to thank the speakers and then have a question for Dr. Green on page 27. You reported a study that I thought was kind of interesting where it looked at fatal overdoses over time. And that seems kind of clean because death is clear, and then I would imagine you could ascribe the drug to it pretty accurately as well. You pointed out a number of problems with this, which are there, but you also, mentioned that if you had a comparator drug, that would provide a nice relevant yardstick to try and improve this. And then it seemed like it would offer fairly higher quality evidence than what was done. So just your view on adding a comparator to this for getting at the fatal overdose issue, avoiding sort of the substitution issue, which I know is maybe beyond this and very difficult.
Yes, thank you for your question. I am going to defer this question to my colleague, Dr. Malika Munker, which worked on reviewing this study and providing kind of the context as well as the critique of it. So Malika.
Sure. Thank you for the question. If I'm understanding, the question is regarding whether a comparator, inclusion of a comparator here could improve inferences drawn from this type of analysis. Am I understanding that question correct?
That's correct.
Okay. So first, I think yes, in the sense it would make it a better analysis. Would it be an appropriate analysis given that the data is spontaneous reporting data? There are duplicates. There are other issues with spontaneous reports. They're influenced by litigation, media reports, that kind of thing. So as a data source to look at trends, it's not good. So even if you were to add a comparator, this type of analysis would not really add much value. So to answer your question, maybe it would be a little bit better, but other data sources with a comparator to look at trends would be much more valuable.
Yeah, thanks. Just to drill a little further, then you mentioned sort of media reports of sensitivity could affect the reporting rates, but I'm thinking, how could that be if, you see an overdose death, you're going to report that as a death, and then you're going to look for drugs there, I would think, are measured in the body. So just like how could, I don't know, media awareness of a particular drug affect those aspects?
So overdose.
Could I jump in here and help a little bit?
Absolutely.
Thank you, Malika. I think the issue here is spontaneous reporting data is really valuable data for detecting signals. So I think where the media comes in is with new safety signals, when we receive reports about them, that can really help us to do some crude looking to see if something is happening and gain some information that we can then turn into more substantive evaluations to get at more of the details. But with something like an overdose with an opioid, that's a very well-known event. So it's very challenging to figure out what percentage of those would someone call FDA and report such an outcome, particularly at a time when there are many overdoses from opioids of all types occurring. So the factors that influence reporting, I think, go well. I mean, they could certainly include the media, but it could go well beyond the media in terms of which reports actually end up with FDA, and that could vary tremendously across different opioids. For example, given the reformulation of OxyContin and the publication or the publicity around that may or may not cause people to report fatal overdoses they become aware of more or less. So I think it's the uncertainty around these data, and again, their strength is in signal detection. They are not really very useful for evaluating the impact of any kind of intervention, and we strongly discourage trying to use them in more quantitative approaches. Does that help understand kind of the way we best use these data, in our opinion?
Oh, yeah, that's a very thorough answer. For some reason, I thought maybe you gathered this from police reports or something, but if it's sort of people reporting to you, that's totally different, and I understand. It's a great answer. That's all.
Thank you. Let's take one last question from Dr. Gulra. Dr. Gulra, do you have still a question? Maybe we have a, yeah.
Yeah, this question is for, Dr. Gowda from Penn Medicine. This question is for Dr. Green, and this is in connection with slide 34. The connection between hepatitis C and the ADF. One, can you quantify it? And second, if I look at the graph, it looks like the hepatitis was already on the increase before 2010. And the third thing is, I know it is more of correlation. What could be the factor that might have contributed to this increase, if it is a real increase, or if the increase is related to introduction of ADF? Thank you.
Okay, thank you. I'll go ahead and take this question. So the study actually did quantify the association, and they provide a little bit more detail into that, finding that increased rates of pre-reformulation OxyContin non-medical use tended to be associated with higher rates of hepatitis C following the reformulation. And that's kind of where you're seeing this graph, is that you do see a slight deviation prior to the reformulation. However, it does seem like there's this big difference after the reformulation, where you're seeing the rates of hepatitis C go up far more in the group that had higher previous pre-reformulation rates of OxyContin non-medical use compared to the other group. So it is quantified in the study, and it is statistically significant, and it's also in both studies actually cited there. And they didn't find this association for the non-medical use of other prescription pain relievers in the Powell 2019 study. And then you also had another question. Can you repeat your last question, please?
Yeah, what's the likely cause? What's the hypothesis?
Well, the study hypothesized that this was an injection-related adverse event, and so that there was an increase in injection. However, we have to remember that this is, population-level data, and this is an ecologic study. So that's the argument that they were making, is that the abuse deterrent formulation may have led to an increase in some sort of injection-related adverse event.
Were there any specific states which had more of this seen than other states? Any
well, I mean, according to the study, it's the states that had higher rates of OxyContin non-medical use prior to the reformulation.
Any other blood-borne infections, hepatitis B or HIV?
So the HESTI did examine those outcomes, and they didn't find anywhere near the statistical significance of the effect that they found in hepatitis C.
All right, thank you.
Okay, thank you. We'll take one last clarifying statement from Purdue. I acknowledge them now, so you can continue your clarification on the formulations and events.
Thank you very much. This is Jennifer Giordano with Purdue. We'd like to make an important clarification regarding the formulations of OxyContin and Opana. PEO varies greatly, and that's polyethylene oxide, the polymer that's used in the formulation. OxyContin uses a molecular weight of about 4 million, while Opana uses a molecular weight of about 7 million.
Another important difference is these products are manufactured differently, which imparts different properties to the product. Thank you.
Thank you. Very useful. Thank you. So we will now break for lunch. If you allow me, we will reconvene in 35 minutes, if that's allowed, so that we will be back at 12 p.m. Eastern Time. Panel members, please remember that there should be no chatting or discussing of the meeting topics with other panel members during the lunch break. Additionally, you should plan to please rejoin at around 11:45 plus Eastern Time to ensure that you are connected before we reconvene at 12 p.m. Thank you.
Audio recording for this meeting has ended. Audio recording for this meeting has begun.
Welcome back. We will now begin the open public hearing session. Both the FDA and the public believe in a transparent process for information gathering and decision making. To ensure such transparency at the open public hearing session of the advisory committee meeting, FDA believes that it is important to understand the context of an individual's presentation. For this reason, FDA encourages you, the open public hearing speaker, at the beginning of your written or oral statement to advise the committee of any financial relationship that you may have with the sponsor, its product, and if known, its direct competitors. For example, this financial information may include the sponsor's payment of your travel, lodging, and in this case, more likely other expenses in connection with your participation in the meeting. Likewise, FDA encouraged you at the beginning of your statement to advise the committee if you do have or do not have any such financial relationship. If you choose not to address this issue of financial relationship at the beginning of your statement, it will not preclude you from speaking. The FDA and this committee place great importance in the open public hearing process. The insights and comments provided can help the agency and this committee in their consideration of the issues before them. That said, in many instances and for many topics, there will be a variety of opinions. One of our goals for today is for this open public hearing to be conducted in a fair and open way where every participant is listened to carefully and treated with dignity, courtesy, and respect. Therefore, please speak only when recognized by the chairperson. Thank you for your cooperation. Speaker number one, your audio is connected. Speaker number one, Dr. Sidney Wolf, begin and introduce yourself. Please state your name and any organization you are representing for the record.
Dr. Sidney Wolf, Public Citizens Health Research Group. I do not have any financial conflicts of interest. Next slide, please. Next slide, please. Yes. These are data that were presented by Dr. Eggers yesterday. I'd just like to focus on the first group, individuals who require opioid analgesic for the treatment of pain, but are not yet abusers at all. When I was on the Drug Safety Advisory Committee from 2008 to 2012, Dr. Nelson was on then. Not infrequently, an opioid company seeking approval would try and increase the meeting's focus on just that first class, benefits and risks to intended recipients of opioid pain relief, rather than on the broader public health concern of the people in the second and third group. I'm delighted to see that this meeting, in a very important and I think precedent-setting way, is focusing on all the groups and the overall effect on the public health. Next slide, please. Next slide, please. As you know, the previous one, I haven't done, please go back to the previous slide. That's the one I want to talk about. As you know, the FDA asked the National Academies, the next slide now, please. Yeah. Yeah, that slide, that's fine. The National Academies were asked by the FDA in 2016 to provide a helpful framework for regulatory approval and not approval of opioid. And their conclusion, looking at what FDA had done up until that time, was that the FDA has failed to adequately incorporate public health considerations into opioid-related regulatory decisions. This meeting certainly would be looked upon favorably by the National Academies because it's gone into great detail. The purpose of the meeting, to make it a little simpler, is that in 2014, Purdue wanted to upgrade, so to speak, the description and the labeling of abuse deterrent formulations, which was then and is still now saying that it's something that is expected to make abuse difficult. They wanted to change it to it actually deters abuse, and they sent in 2014 a package of data trying to get that approved. And the FDA scheduled an advisory committee meeting in 2015, and when the FDA sent out to the advisory committee and to the company their views on the package that had been submitted by Purdue, the company canceled the meeting. And so now, fast forward to now, today's meeting, amongst other things, is trying to look at the question, is there evidence that it actually deters abuse in the community? Next slide, please. Next slide, please. So right before it was finally approved, the advisory committee, right before 2010, was concerned about several things. Abusing ingestion, oral route, would not provide any protection because people could just take more pills. They also said that a post-marketing epidemiological study to assess the impact of reformulation on the actual abuse is essential. This is 10 years ago they said this. The next slide, please. So Dr. Eggers and others during the meeting, I believe from looking at the slides today, are raising the issue of what is the bias of the doctor, what's the impact on the doctor of promotion of these drugs. So this is a letter sent in 2003 before the reformulation to Purdue, essentially saying a series of ads in the Journal of American Medical Association for OxyContin was illegal because it was overstating the risk, minimizing the serious safety risks, and promoting it for uses beyond which have been proven safe and effective. And they asked all these ads to be stopped because they were illegal. They're essentially accentuating the positive and eliminating the negative, for those of us that remember that famous and predictive song back a long time ago. Next slide, please. Yes, these are just some of the materials that were in the ads which the FDA released at the time they wrote this letter. It can be life with relief. Also, it works when it's time to consider Q4, Q6 opioids. Remember, this one just takes 2. In other words, instead of needing to take it every 6 times or 4 times a day, you take these 2. Next slide. Again, next slide, please. Next slide, please. Could I have the next slide, please? Several years after that, in 2007, as many of you know, the company, individuals in the company pleaded guilty to criminal charges, and there was a total of $600 million assessed because of deceptive marketing of, again, pre-reformulation OxyContin. And this is from the statement issued on the day, May 10th, 2007, that the prosecution was announced. And what they said is Purdue supervisors and employees sponsored training that used graphs that exaggerated differences between the blood plasma levels of OxyContin compared to immediate-release opioids. These were used to falsely teach Purdue salesperson supervisors that OxyContin might result in less euphoria and less potential for abuse than short-acting opioids. This is a long criminal information which went on for about 70 pages, but between the advertising back in 2003, which was deemed illegal, and this, the company clearly was engaging in criminal and civil violations in the way that they were promoting it. The issue raised about what is the bias that doctors might have, and advertising is one way of having bias if it's illegal. Next slide. Cover the next slide, please. Yeah. Just 6 months after that, en route to getting the approval of the drug that we're talking about today, reformulated OxyContin, the company sent in studies which were intending to get the reformulation. And the FDA reviewed the studies and basically rejected those studies for the following reasons. Poor quality of the studies submitted support sponsors' proposed labeling claims, in other words, to try and say it actually deters abuse rather than is expected to. Sponsors plan to market the two high-dose tablet strengths in the original formulation and not reformulated at the same time with the same name that they were marketing the lower strength tablets. The agency said this is unacceptable and rejected this. So anyway, the thing I'm pointing is that this company didn't seem to be educable, and having just paid a massive criminal civil penalty, they were still doing things that were misleading, attempting really things that was misleading. Next slide, please. Next slide, please. So the overall ask is discuss the broader public health impacts, positive and negative, of the reformulation within the complex and evolving landscape of opioid use, abuse, and addiction. Next slide. Next slide, please. So these, as has been discussed by the FDA in the briefing package, is the analyses of the 4 studies. The first one, basically, they're just saying that if you look overall at both the intravenous, intranasal, and the oral, there's not compelling enough that the overall abuse is down. And the other ones were just not felt to achieve the goal the company wanted, which was to be able to say it really deters abuse. Next slide, please. Next slide, please, yeah. These are data, again, in the reviewing package, saying that there's been a significant decrease in the total number of prescriptions of abuse-deterrent formulations just between 2011, when there were 5.6 million, and in 2019, when they were down to 2.7 million. As a percentage of both overall opioids and so forth, it's down. More recent published studies, which I think are more sensitive for finding out whether or not there really is community-wide adverse effect, and these are studies discussed in the briefing package, look at public health effects after versus before reformulation and raise serious questions about the net effect is positive, whether it's a positive, as in the Powell study published last year. Next slide. Next slide, please. Just to simplify this, the y-axis is infection rate per 100,000 people in various states. And the states are divided into 2 groups. The states that had higher rates of abuse of OxyContin before the reformulation, and states that had lower rates. And what you can see is that the states with higher rates, the green or blue line, diverges even before the reformulation and then really widens after the reformulation. In other words, in those states, and again, these are not randomized controlled studies, these are, I think, cleverly looked at, designed epidemiological studies, and most of these studies showing these kinds of adverse effects, whether it's deaths or so forth, have been published in the last couple of years, and I think that they provide more insight as to whether there is a problem or not. So in conclusion, I believe that the collected evidence thus far with abuse deterrent formulations is tilting towards the negative side, that they're doing more harm than good. This is a drug that in 10 years has not been able to do the kinds of post-marketing studies that would show that there's a decreased amount of abuse in the form of what happens in the community and so forth. 3 years ago, Opana ER, a big-selling abuse-deterrent opioid, was taken off the market because the epidemiological studies showed clearly that the abuse-deterrent form was more dangerous than the non-abuse deterrent earlier form. In addition to that, there have been a number of companies trying to get abuse deterrent formulations. These were presented at FDA advisory committee meetings, and these have been rejected mainly because even before it gets out in the community, namely in the studies, clinical and in
Dr.
vitro.
Wolf, final words, please.
Anyway,
wrap up.
Thank you for inviting me. I hope this has been useful, and I again commend the FDA for what they have done to broaden this issue to the public health concerns that the national academies were wanting to have. Thanks.
Thank you. Speaker number 2, your audio is connected now. Will speaker number 2 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. Could I have slide 1? Good afternoon. My name is Edwin Thompson. Could I have slide 1? Good afternoon. My name is Edwin Thompson. I'm the president of Pharmaceutical Manufacturing Research Services. Next slide. Simply put, reformulated OxyContin does not have physiochemical properties that deter abuse. Absent these properties, reformulated OxyContin is prevented from having meaningful abuse deterrent properties. No amount, no interpretation of epidemiological studies can cure the absence of physiochemical properties required for abuse deterrence. The FDA did not have the required data to label reformulated OxyContin in 2013, and they do not have it today. You're going to be asked to fix this by adding a disclaimer rather than curing the original sin. OxyContin is not the only abuse deterrent product. The FDA approved 10 abuse deterrent products. 7 of those 10 have voluntarily withdrawn from the market or not even launched in the marketplace. These companies spent hundreds of millions of dollars to get their drug approved, and they did. They spent hundreds of millions of dollars to get abuse deterrent labeling, and they did. So what happened? It's not about abuse deterrent properties. It's about price. The FDA exclusively gave Purdue price protection. And when these companies didn't get price protection from the FDA, they cut their losses and left the marketplace. Yesterday, one of the panel members, and I apologize because I didn't get her name, but ma'am, you hit it right on the head. It was about price. You are spot on. Except Purdue refused to answer your question, and the FDA wouldn't even acknowledge you. Before you go any further, before you even entertain these questions, you should demand that both groups answer your questions about price. It is really important, critical. I've worked 47 years in the U.S. narcotic business. I'm the inventor of 17 worldwide opioid abuse deterrent patents, 5 in the United States, including multiple platforms for those products. I assure you it's about price. Abuse deterrent products should be priced as generic pricing. Let's look at the evidence. In 2016, we notified the FDA that a simple method existed in which an untrained, unskilled person can extract oxycodone from reformulated OxyContin into a 9 to 16 milligram per ml non-viscous solution in minutes. Multiple times we provided the FDA with the 9-minute film demonstrating this process. We asked the FDA to show you the film so that you would have full disclosure before you voted today. If they had shown you the film, we wouldn't even be here today. Next slide. Next slide, please. Yep. If you can cut it, if you have access, no, go back to that slide, please. Please return to the prior slide. If you can cut it, if you have access to water, and if you have a syringe, you can IV 16 milligrams per ml of reformulated OxyContin. Next slide. Please, next slide. This is a cut tablet. this is a commercially available 80 milligram reformulated OxyContin tablet. It is required to be able to cut it, to be able to test it analytically. Everyone, including the FDA, knows that you can cut this tablet. Next slide, please. Simply cover the tablet with hot water. Any water. Next slide. The viscosity of the solution is 2. You've heard a great deal about the gelling properties. Well, you just saw that it's not necessary. You can have 100 ways that fail, but you only need one to succeed. This is a viscosity of 2. For reference, water is 1 and milk is 3. Next slide, please. We have an extracted oxycodone solution of 9 to 16 milligrams per ml with a viscosity of 2 that can be syringed and injected. It is impossible for this to produce abuse deterrent labeling. Next slide, please. So how did we get here? Dr. Bob Rappaport, the DAP Division Director, reviewed and wrote, quote, "These features also render the product almost impossible to dissolve, syringe, and inject." I just showed you that's not true. Doubling down, Dr. Throckmorton, the CEDAR Deputy Director, wrote to Dr. Woodcock, quote, "OCR, this is reformulated OxyContin, gradually forms a viscous hydrogel, for example, a gelatinous mass that resists passage through a needle. The in vitro testing was sufficient to demonstrate that OCR prevents oxycodone from being drawn into a syringe to any meaningful extent." Nothing could be further from the truth. You just saw the physical evidence. Next slide, please. This process precludes reformulated OxyContin from having meaningful IV abuse deterrent properties. Dr. Dasgupta told you yesterday that there is a product-centric and a people-centric part of the data. Well, the product-centric data fails flat on its face, and it disqualifies the people-centric data. It makes all the statistical work that you've seen a kabuki dance. Next slide, please. Reformulated OxyContin has no impact on intranasal abuse. Intranasal abuse of oxycodone in any formulation is less effective, less dangerous route of abuse than oral. Next slide. You're looking at Cmax, including non-abuse deterrent formulations. People abuse oxycodone to get increased blood levels. Simple. Any formulation, IR oxycodone, oral beats nasal. You get a higher Cmax and a lower Tmax with oral. If true, intranasal should decline and stop, and oral abuse should increase. Isn't that what happened? Next slide, please. Oxycodone's physiochemical properties prevent reformulated OxyContin from having any meaningful intranasal abuse deterrent properties. Next slide, please. Epidemiologic data cannot reverse the enormous increases in consumption of reformulated OxyContin. Next slide, please. This is the APQ, if you're not familiar with it. And for background, this is the government's prospectively approved volume of oxycodone for consumption by year. The pre-reformulation volume of oxycodone does not return for 8 years. It's not even imaginable that if oxycodone was not reformulated, we would have something worse than this. This slide is an indictment for the opioid epidemic. This is an iatrogenic epidemic sanctioned by the federal government. This is the root cause, the story. Next slide, please. Reformulated OxyContin did not shift misuse, abuse, and deaths to heroin. Dr. Compton was so gracious to speak to you today. He's probably the world's expert in this area, and he put the heroin issue to bed. Let me quote his publication in the New England Journal of Medicine in 2016. Moreover, a separate study showed no significant differences between the prevalence of heroin before the introduction of the reformulation and the prevalence after the reformulated drug was available. Over with. Next slide,
40
please.
more seconds.
Reformulated OxyContin does not have, cannot have, meaningful intranasal or IV abuse deterrent properties. I'm available to show any committee member that film or answer any of their questions, and the chair can allow you to ask them of me if you wish, and I'm available at any time. I thank you for listening to me. I hope that you make the right decision. This is the end of my presentation.
Perfect. Thank you very much. Speaker number 3, your audio is connected now. Will speaker number 3 begin and introduce yourself? Please state your name and any organization you're representing for the record.
Thank you. This is Dr. Miguel de la Garza, and I'm representing the Florida Society of Interventional Pain Physicians. I do not have a slide deck, but I'd like to read a statement prepared by myself for our organization. I would like to thank you for the opportunity to directly address you regarding this very important topic. My name is Dr. Miguel de la Garza. I'm a board-certified interventional pain physician with 4 offices in 3 counties in the Tampa Bay area of Florida. I attended medical school and residency in anesthesia at prestigious institutions. I published articles and abstracts on the topics of interventional pain, anesthesia, pain education, and associated topics. And I am board certified for addiction treatment and also for the treatment of chronic pain patients. I'm president-elect for our society, the Florida Society of Interventional Pain Physicians, a nonprofit educational foundation. I'm here on my own volition, representing myself, our society, and the patients that we see in our practices. I'm not being compensated for my testimony. And I would also like to say that the Florida Society of Interventional Pain Physicians represents over 300 physicians devoted to promoting development and practice of safe, high-quality, cost-effective interventional pain treatment techniques for the diagnosis and treatment of pain and related disorders, and to ensure appropriate access to interventional pain medicine and management for the doctors of those treatments in the state of Florida. SEP has been a leader in promoting fair legislation, access to care, and promotes well-developed research, and continues to expand our mission in the public and political arena. We host a large conference yearly which draws physicians, physician extenders, and industry experts from all over the United States. Yearly, we examine and report the latest literature devoted to the responsible use of opioids for the treatment of chronic pain. We have examined the available literature regarding abuse-deterrent opioids, or ADOs, and recommend their use in the treatment of acute and chronic pain. We strongly recommend their utilization as first-line therapy when all other reasonable alternatives have been tried and failed, and the appropriate use of opioids is required for the treatment of pain. The utilization of abuse-deterrent formulations, or ADF opioids, should supersede the utilization of non-ADF opioids for the treatment of pain in general. The use of opioids to treat acute and chronic non-malignant and malignant pain has steadily increased since the late 1990s. With the increase in opioid use, prescription opioid abuse increased to evident proportions. In 2012, an estimated 2.1 million Americans suffered through abuse substance-related disorders related to prescription opioid pain relievers. Yet, prescription drug abuse still continues even now despite multiple efforts to the contrary. There is a clear need to deter the misuse and abuse of prescription opioid by various methods of adulteration, commonly referred to as tampering. Opioids are often tampered by crushing, breaking, or dissolving them. This may lead to dangerous intake methods such as snorting, injecting, or chewing. This increases the rate of absorption, leading to euphoria, but can also cause toxicity, overdose, and death. The U.S. FDA has been diligently assessing and approving the pain medications designed to minimize abuse. Many manufacturers offer various abuse-deterrent formulations. However, many of these are no longer available, having been voluntarily withdrawn from the market. They have demonstrated reduced preference among known drug abusers without diminished analgesic properties compared to non-ADO formulations. Abuse-deterrent opioids make it difficult for abusers to alter the medications to maximize the euphoric effects via rapid delivery routes. Some abuse-deterrent formulations have physical or barrier technologies which prevent the abuser from altering the formulation by crushing, snorting, or chewing. Some have chemical compositions which reduce the euphoric effects if adulterated. While these formulations cannot stop all misuse, diversion, or abuse, they can reduce the likelihood of the molecule for injection, snorting, or crushing for illicit use. Diversion of prescription opioids is a significant source of illicit opioid abuse in the United States. Abuse-deterrent formulations reduce the chances of adulteration and resultant euphoric effects when abused, thus reducing the demand for diversion. Patients do deserve access to pain medication to palliate their pain and improve their level of function. Abuse-deterrent opioid medications control pain while reducing the potential for abuse or misuse. We request that the FDA-approved abuse-deterrent formulations be required for all payers, including Medicare, Medicaid, Medicare Advantage plans, and private payer insurance. Furthermore, we advocate them as preferred agents without prior authorizations or step edits to ensure the availability for patients and when physicians choose to prescribe them. Often the cheapest formulary drug is a high-dose, short-acting Schedule II opioid. Multiple studies have demonstrated and clinical experience illustrates that these preparations lead to habituation, tolerance, dose escalation, and are often associated with adulteration, which leads to dose dumping and resulting euphoric effects in patients who are high risk or known drug addicts. These types of opioids are the most sought after and abused and adulterated opioids, leading to chewing, crushing, insufflation, and eventually injection. This leads to increased morbidity and mortality. Abuse-deterrent formulations have shown reduction in all three categories of adulteration and decreased drug likability and would use drug again. Not all formulations have equal abuse-deterrent properties, but short-acting and long-acting abuse-deterrent formulations have characteristics which must be examined upon their own individual merit. But the truth is that any formulation that has some abuse deterrence is better than a cheaper formulation which has no inherent abuse deterrent properties at all. This is clearly seen in RADAR's data, which has both long-acting and short-acting opioids with regard to street price, drugs of choice that are abused, and those that are associated with high frequency of overdose deaths. With regard the OxyContin Category 4 data, it is clear that manipulation of the formulated version defeats its intended abuse deterrent properties. This leads to a shifting of abuse from one ingestion route to another, and the overall abuse of the product is still present. As a result, the abuse of OxyContin is not lower than other ADF opioids and non-ADF products. The Category 3 data is a mixed bag of results, which in some cases shows reduction in likability and would use drug again. But the technology is easily defeated with simple chemical and mechanical extraction techniques, which were known within weeks of OxyContin's formulation, and the prior presenter clearly illustrated this was the case. Category 4 data also shows that abuse deterrent technology fails, and it resembles the immediate release formulation of the same dose in terms of pharmacodynamics. However, when taken intact without manipulation, it does retain some abuse deterrent properties. This is a better medical product for opioid use long-term than a readily available high-dose, short-acting oxycodone product, vis-a-vis oxycodone or oxycodone trademark, instant release 30 milligram. This has no inherent abuse deterrent properties at all. Furthermore, other formulations of long-acting oxycodone have shown Category 1, 2, and 3 abuse deterrent data, which in our opinion is superior to OxyContin formulation of long-acting oxycodone. But Category 4 data is only available in a few posters presented at Pain Week in 2019. In reference to this data, RADAR's data shows that Xtampza, specifically trademark name, has less misuse, abuse, and diversion as compared to comparator group of ADF long-acting opioids. For this group, approximately 80% was comprised of OxyContin or generic equivalent medications. This early Category 4 data is key to understanding how ADF technology impacts all forms of abuse of long-acting opioids. This is key to the reduction in the global harm for the U.S. population. It is important to note that although there are many long-acting opioid technologies with ADS, only 2 remain readily available for me or my colleagues to prescribe. In addition, there's only one short-acting opioid with ADF technology that is also readily available to prescribe for patients to receive over-the-counter at the pharmacy level. While there are generic long-acting and short-acting opioids available, the data is not readily available to review, and the formulations are not readily available at the pharmacy counter for our patients for various reasons, mainly those as articulated previously. The whole market share for all abuse deterrent formulations represents less than 5% of the total opioids prescribed in the United States. This is simply a travesty. This needs to change. The FDA should push for the ADF technology to be available at the pharmacy counter where the patient will have access to its use. In this time of incomplete data, mostly category 4, we readily encourage the FDA to compel carriers to cover abuse deterrent formulations of opioids so there is more category 4 data that can be obtained. This will lead to a plethora of data points, especially for RADAR's data, which could satisfy most post-marketing analysis for which ADS are truly superior to non-ADS, so that we can put this issue to bed about abuse, misuse, and diversion of ADF technology versus non-ADS. While no technology can stop all opioid abuse, misuse, or diversion, we still think that this epidemic and drug overdoses happening in the United States deserves careful scrutiny and attention. We expect that the FDA will act in accordance with good scientific principles and will ensure appropriate access to opioids to palliate pain, but also balance the inherent risk associated with these compounds in the public at large. We respectfully ask that OxyContin continue to be available for public utilization to be prescribed by physicians in the United States while allowing all appropriate abuse deterrent formulations, long-acting and short-acting opioids, to continue to be available and for each of these to be reviewed upon their own individual merit so that decisions can be made about their appropriate use within the United States for physicians and patients for chronic pain and also acute pain. Thank you for your consideration in this matter, and I appreciate the opportunity to address the FDA on behalf of my colleagues and my patients.
Thank you. Speaker number 4, your audio is connected now. Will speaker number 4 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Thank you to the FDA and committee members for the chance to comment today. My name is Dr. Richard Malamut, and I am the Chief Medical Officer of Collegium Pharmaceutical. I have no financial or other affiliations with Purdue. Our mission is to be the leader in responsible pain management. We strive to bring meaningfully differentiated products to people who suffer from pain, as well as to clinicians and caregivers who treat and support them. Collegium is equally committed to mitigation of the opioid crisis, including prescription opioid misuse, abuse, and diversion. We developed Xtampza ER, a long-acting abuse deterrent formulation, or ADF, of oxycodone with the goal of delivering pain relief while mitigating the risk of abuse, misuse, and diversion. With the support of FDA, different approaches to abuse deterrence have been pioneered. This has led to multiple marketed ADFs that embody different technologies supported by different in vitro and clinical abuse liability data and associated with differentiated labels. We applaud the agency and this committee for undertaking the critical task of assessing the real-world impact of the first abuse deterrent formulation, reformulated OxyContin. In undertaking this assessment, it is particularly important to recognize that not all ADFs are the same, and accordingly, each formulation needs to be evaluated on its own merits. If I could have my next slide, slide 2. Like OxyContin, our product, Xtampza ER, is an extended-release abuse deterrent version of oxycodone. Xtampza ER entered the market in mid-2016, 6 years after the reformulated OxyContin. Its formulation is fundamentally different with respect to the dosage form, features, and inactive ingredients as seen here. Xtampza ER utilizes Collegium's proprietary Deterrex technology. Each Xtampza capsule contains microspheres that are about 300 microns in diameter. Each microsphere contains oxycodone in the form of a lipophilic fatty acid salt, and the salt is homogeneously dispersed in hydrophobic fatty acid and waxes. This combination of features is designed to provide physical and chemical barriers to common forms of tampering, as well as to provide extended drug release. The design further allows for alternative dosing strategies such as sprinkling on soft foods or through feeding tubes. Xtampza ER's label is differentiated from the reformulated OxyContin label in that it describes abuse deterrent properties with respect to all 3 routes of administration, intravenous, intranasal, and oral. Specifically, Xtampza ER's label states that the formulation has properties that are expected to make abuse via injection difficult, and that the formulation is expected to reduce abuse via the intranasal and oral routes. Xtampza ER has been shown to maintain its extended release profile following chewing, which is important not only to deter one common manner of abuse, but also to mitigate the risk of unintentional misuse by patients. This is critically important as we know that abuse via the oral route is the most common form of abuse of prescription opioids. If I could have my next slide, slide 3, please. The label for Xtampza ER also contains data comparing the impact of physical manipulation with reformulated OxyContin. The results of 2 Category 2 pharmacokinetic studies demonstrated that crushed Xtampza ER was bioequivalent to intact Xtampza ER as seen in the left panel, while crushed reformulated OxyContin lost its extended release characteristics and became bioequivalent to a crushed immediate release oxycodone tablet shown in the orange and is seen in the right panel. Based upon the totality of the data, and as we noted earlier, Xtampza ER is the only extended release opioid, including both abuse deterrent and traditional formulations, not required to have language in its box warning regarding the dangers of crushing, chewing, or dissolving the formulation. Post-marketing studies are important for assessing whether ADFs reduce prescription opioid abuse in real-world settings. Collegium takes our obligation to perform post-marketing studies seriously and will be submitting the final report for the first phase of such studies to the agency later this month. We will also work with the agency in the design of subsequent studies to fulfill our post-marketing study obligations. Collegium is also committed to sharing the results of our surveillance with the medical community. A manuscript titled Post-Marketing Analysis of Misuse, Abuse, and Diversion of Xtampza ER was recently accepted for publication in Pain Medicine and is currently in press. If I got out my next slide, slide 4. The manuscript assessed abuse, misuse, and diversion of Xtampza ER using radar system data sources. Over the past couple days, you have already heard much about how these data sources have been utilized in the surveillance of OxyContin. In this publication, Xtampza ER was compared to, number 1, other ADF ER products combined in which OxyContin accounted for 88% of the utilization. Number 2, non-ADF ER products combined. And third, immediate release oxycodone. Information on drug utilization was obtained from the IQVIA database. Drug utilization adjusted estimates accounted for different degrees of exposure to prescription opioid products. 2 measures of exposure were used, prescriptions dispensed and morphine equivalent grams dispensed. If I could have my next slide, slide 5. During the study period, which represents the first 3 years after launch, Xtampza ER total prescriptions increased 50-fold as seen in the blue dotted line. In contrast, cases from poison centers, substance abuse treatment centers, and diversion, represented by the lines along the bottom of the figure, were infrequent and did not increase. If I could have my next slide, slide 6. This slide displays the relative differences in rates between Xtampza ER and comparator groups in 3 data systems. Poison centers, seen in the leftmost box, treatment centers, combined, shown in the center box, and diversion reports, shown in the right-hand box. Notably, the Poison Center Program and Treatment Center Program data reflect administration by any route, including oral. When adjusted for the number of prescriptions dispensed, Xtampza ER had statistically significantly lower rates of poison center exposures, past month abuse, and diversion compared to other ADF ER products combined, which again was largely comprised of OxyContin and depicted in the blue. Similar findings were found when compared to non-ADF ER products depicted with orange symbols. And when compared against IR oxycodone depicted with green symbols, Xtampza ER was statistically significantly lower in all comparisons except for past month abuse in the treatment center program. If I could have my next slide, slide 7. When adjusted for morphine equivalent grams dispensed, Xtampza ER had statistically lower rates in all three data systems compared to all three product groupings. Again, the Poison Center program and Treatment Center program data reflect all routes of administration, including oral. Collegium is encouraged that the current surveillance data for Xtampza ER demonstrates low rates of misuse, abuse, and diversion for the studied periods and is consistent with the expectations identified in the pre-marketing studies performed to obtain Category 1 through 3 associated claims. Because surveillance data inherently represent a single snapshot in time, and because real-world rates of abuse may change over time, we remain committed to post-marketing studies and surveillance, and we will continue to share this information with both the agency and the healthcare community at large. In alignment with FDA and many stakeholders here today, Collegium believes that ADS have an important role to play in the twin effort to treat severe pain while lowering the risk of abuse and diversion. Their potential to have a positive impact is dependent upon and proportionate to the existence of supportive and coordinated policies to promote responsible pain management at each point in the healthcare chain, from patient to payer to prescribing physician. While we acknowledge that ADS by themselves will not solve the opioid crisis, we believe that they can and should be an important part of the solution. Finally, we look forward to contributing to the body of knowledge regarding the real-world impact of ADS and supporting the agency in its assessment of such data. Thank you for allowing me to comment on behalf of Collegium Pharmaceutical.
Thank you. Speaker number 5, your audio is connected now. Will speaker number 5 begin and introduce yourself? Please state your name and any organization you are representing for the record.
Sure. My name is Dr. Andrew Kolodny. I'm the Medical Director for Opioid Policy Research at Brandeis University, and I'm the Executive Director of Physicians for Responsible Opioid Prescribing. My comments today are on behalf of Physicians for Responsible Opioid Prescribing, PROP. Next slide. This is my disclosure statement. Next slide. What is the opioid crisis? Or in other words, how should we frame the problem? Or what is the problem that ADF opioids can potentially impact? Next slide. We know well how Purdue frames the problem. We know this from internal documents that have recently become public. We know it from their actions, and we know it from their public statements. Purdue would like the medical community, regulators, and the public to believe that the opioid crisis is a drug abuse problem, that people are abusing good medicines, chewing them, snorting them, injecting them, because it feels good. If Purdue's framing of the problem is accurate, then making pills harder to crush would indeed be a potential solution. But we don't have an epidemic of drug abuse. We have an epidemic of opioid use disorder. And while it's true that some people became addicted to opioids by misusing them, there are also many who became addicted to opioids taking them as prescribed. And even for the folks who became addicted through misuse, for the vast majority, their addiction began by swallowing pills whole. It's a subset that may transition to snorting or injecting. Most stick to oral use. Next slide. As I mentioned, the correct way to frame the problem is an epidemic of opioid use disorder, meaning that the reason we're seeing record high levels of opioid overdose deaths, the reason we're seeing heroin and fentanyl flood into non-urban communities, the reason we've seen a dramatic increase in infants born opioid-dependent, children winding up in the foster care system, outbreaks of injection-related infectious diseases, impact on the workforce. The driver behind all of these health and social problems that we refer to as the opioid crisis has really been a sharp increase
in the prevalence, the number of people addicted to opioids. Next slide. This is a map of the United States 3 years into the epidemic, 1999. And what you're seeing here with states that show up as red or maroon are the states with the highest rate of people seeking treatment for addiction to prescription opioids. And I'd like you to see what happens to the map as we go forward in time. So this is 3 years into the epidemic. Next slide. This is 2001. Next slide. 2003. Next slide. 2005. Next slide. 2007. Next slide. And 2009. What you can see is that in every state in the country, we've experienced a sharp increase in the prevalence, the number of people seeking treatment for addiction to prescription opioids. And when you have a sharp increase in a disease over a short period of time, that is the definition of an epidemic. Now, what caused the maps to turn red? Next slide. Next slide. The CDC has been pretty clear about what's caused an epidemic of opioid addiction. The green line on this slide represents prescribing or consumption of opioids. The red line represents deaths involving prescription opioids, and the blue line represents addiction involving prescription opioids. And the CDC's point in putting this graph together has been that as the prescribing took off, rates of addiction and overdose deaths increased in parallel. And their message, as we all know, has been that the medical community needs to prescribe more cautiously, that the green line needs to come down. Manufacturers of opioids have not agreed with the CDC. What they've really argued is that that green line can continue to go up, but if we make pills harder to crush for snorting or injecting, then we can see the red line and blue line go down. And that's really been their message with regard to ADF opioids. Next slide. Fortunately, prescribing has come down, but we are still massively overprescribing in the United States. What you're looking here at is oxycodone consumption in the U.S. compared to oxycodone consumption in Europe. It's not even close. Next slide. This is a paper that just came out a couple of months ago looking at more recent prescribing data in the United States. This was looking at prescribing after surgery, looking at opioids that patients were sent home from the hospital with. And what they found was that 91% of U.S. patients were prescribed opioids compared to only 5% of non-U.S. patients after having the same surgical procedures in different parts of the world. Again, we are still massively overprescribing, which means that many people are still being unnecessarily exposed to opioids, and it means that we still have a high incidence rate of opioid use disorder in the U.S. Next slide. ADF opioids are not less addictive. This is a really important point because if the medical community believes that ADF opioids are less addictive, it may provide them with a false sense of security. And unfortunately, many prescribers do in fact believe that ADF opioids are less addictive. Next slide. In a survey of primary care physicians, we found nearly half of the physicians that were surveyed believed that abuse-deterrent formulations were less addictive than non-ADF opioids. So at a time when we really want to encourage the medical community to prescribe opioids more cautiously, you have a class of opioid that's being promoted as in a way that can result in more prescribing. Next slide. What should FDA do? FDA should cease use of the ADF term and call them what they are, crush resistant. We know that ADF opioids can be abused by different routes. And we know that the medical community and the public generally use the term abuse and addiction interchangeably, and they can falsely imply that the products are less addictive. They should be called what they are. If a pill has been made harder to crush and it can be demonstrated that it's harder to crush, it should be called crush resistant. But the FDA should really stop allowing use of the term ADF. FDA should cease providing exclusivity or patent protection for so-called ADF technology. Every time a new opioid, anytime a new pharmaceutical product gets approved, a manufacturer doesn't sit on its hands hoping that doctors will prescribe the new product. They will do everything they can to increase prescribing of the product that they invested in bringing to market. And so if exclusivity is allowed, that encourages more ADF opioids. That means more opioids on the market that are going to be promoted at a time when we want less opioids to be prescribed. We don't need fancy technology. All that's really necessary is for FDA to require pills that are safer in the sense that they have a higher ratio of starch or filler to active ingredient. Not many people are crushing and snorting regular strength Vicodin, because what a patient will tell you is if they try to do that, they're going to get a lot of junk up their nose. You don't need fancy technology. There's no need for products on the market that have extremely high doses of opioids in them. Lowering the dose, increasing the filler rate, you have a safer product. FDA should cease approving new opioids, and they should limit the on-label indication. Next slide.
40 seconds.
This is a CDC statement on opioid use for chronic pain, and what the CDC said was that for the vast majority of patients, the known serious and too often fatal risks far outweigh the unproven and transient benefits. This message from the CDC is at odds with FDA's opioid labeling. If there's one important lesson we can learn from COVID, it's that when government gives conflicting messages, the public health can be negatively impacted. People can get sick and people can die. Right now we're in a situation where FDA is allowing opioids to be promoted for conditions where they haven't been proven safe or effective. Thank you for your time.
Thank you. Speaker number 6, your audio is connected now. Will speaker number 6 begin to introduce yourself? Please state your name and any organization you are representing for the record.
Good afternoon. I'm Adrienne Fu Berman. I'm a physician and professor in the Department of Pharmacology and Physiology and the Department of Family Medicine at Georgetown University Medical Center. I direct Farmed Out, a Georgetown University Medical Center project that advances evidence-based prescribing and educates healthcare professionals and students about pharmaceutical and medical device marketing practices. My disclosure is that I am a paid expert witness at the request of plaintiffs in litigation regarding pharmaceutical marketing practices, including opioid marketing. Next slide, please. I'm here today to bring marketing into this discussion of ADF formulations. The history of OxyContin marketing is the history of the opioid epidemic in America. Pharmaceutical manufacturers influence physicians through drug reps, seeding misleading articles into medical journals, creating misleading educational modules, and paying key opinion leaders to address their peers at meetings and events. They also fund advocacy groups and professional organizations to convey marketing messages. Next slide, please. Purdue and other opioid makers distorted the perceptions of consumers and healthcare providers about pain and about opioids. Opioid manufacturers convinced healthcare providers that they were opiophobic if they denied opioids to patients with back pain or arthritis. They persuaded prescribers that opioids rarely caused addiction and that patients with genuine pain were somehow resistant to addiction. They persuaded physicians that clear signs of addiction were actually signs of pseudo-addiction and would be eased by increasing opioid doses. This aggressive marketing resulted in hundreds of thousands. A consistent theme in the marketing of opioids, dating back to the late 19th century, has been the message that every new opioid formulation is safer or less addictive than what is already on the market. Heroin, developed by Bayer, was promoted as safer than morphine. Vicodin was promoted by Knoll as less addictive than Percocet. Ultram, tramadol, was promoted as if it had no abuse potential at all. And Purdue promoted its original formulation of OxyContin as having a lower abuse potential than existing products. Unfortunately, this marketing continues today in more subtle forms. So-called abuse deterrent formulations are part of that marketing. For opioid manufacturers, abuse deterrent formulations serve two functions. The first is to extend patent life and keep prices high. ADFs are far more expensive than other formulations. The second is to preserve a lucrative prescription opioid market by making prescribers and patients more comfortable with drugs that shouldn't be prescribed. The very term abuse deterrent is a marketing term, implying that the product has intrinsic properties that decrease addictive potential. Almost half of physicians, and probably a higher proportion of patients, think the term abuse deterrent means less addictive. That misunderstanding is not an accident. Next slide, please. In fact, abuse deterrent opioids are just as likely to cause addiction as conventional preparations. And by the way, the graphic I'm showing here is one that has been shown to various legislators, et cetera, about how hard it is to break an abuse deterrent formulation. They're just as likely to cause addiction as conventional preparations. They're just less convenient to turn into an injectable form. And injecting OxyContin isn't the most popular mode of use anyway. Most abuse of OxyContin is by swallowing the pills. You've seen data that may or may not show that reformulated OxyContin reduces the use of the drug intravenously. You've also seen heroin use go up in the same period. Whether or not there is a causal relationship there, there is a general causal relationship. Most IV drug users started with oral opioids. So any opioid prescriptions, including ADF, will lay the foundation for a new generation of IV drug users. It bears noting that opioid harms fall most heavily upon those with psychological and socioeconomic vulnerabilities to addiction. One question for the committee addresses the unintended adverse consequences that the reformulation of OxyContin had. An adverse consequence, although perhaps not unintended, was to perpetuate the myth that new opioid formulations are somehow safer than older formulations. Opioids, all opioids, put patients at risk for addiction, narcotic bowel syndrome, immune suppression, cardiac arrhythmias, respiratory depression, and premature death. The way to prevent these adverse effects is by not overprescribing opioids, and we are still overprescribing opioids. In 2016, 1 in 5 Americans received an opioid prescription. Opioids were prescribed to more than 1 in 4 of the 48 million beneficiaries in Medicare Part D in 2019. The U.S. uses more opioids than anywhere else in the world. Although opioids are valuable for end-of-life care, cancer-related pain, and acute pain, ADFs are not usually used for cancer pain or end-of-life care. These drugs are most likely used for chronic pain, a condition for which they have not been shown to be effective. Consensus is growing that opioids for chronic non-malignant pain are generally both ineffective and harmful, decreasing function and worsening quality of life. We don't need better opioids, we need fewer opioids. OxyContin's reformulation does not prevent abuse, addiction, misuse, diversion, or death. What abuse deterrent formulation prevents is criticism. Embedded in the matrix of ADF is a false sense of security. These drugs are wolves in sheep's clothing. The term abuse deterrent should not be used at all. The best way to prevent addiction and overdose deaths is through fewer opioid prescriptions. Thank you.
Thank you very much. So the open public hearing portion of this meeting has now concluded, and we will no longer take comments from the audience. The committee will now turn its attention to address the task at hand, which is the careful consideration of the data before the committee, as well as the public comments. However, we have time until 2 where we can go back to clarifying questions before we start our discussion of the questions at hand. We had a list with some of you, and we know that some of the questions might refer to Dr. Dasgupta, and he's still around to answer potential questions on drug utilization, etc. The first one on my list now is Dr. Sibel. Dr. Sibel, do you have
Hi. Oh, thank you. Yep, thank you. I think I forgot to put my hand up, but I do have a question, since nobody else does. So, I don't know what we're allowed to talk about with, other meetings. I'm not going to disclose anything, but when FDA was deliberating over Opana, extended release oxymorphone, the brand version, we discussed kind of the use of non-oral routes, specifically insufflation and injecting. And the abuse deterrent formulation is almost identical to Opana. It uses the hydroxycellulose as its extended release formula, and it uses PEO, albeit that the sponsor said they use 4 million compared to the 7 million in Opana. So there definitely seems to be a different level there. So I guess my question to FDA, if you can answer it, you might be able to not, is what does the FDA see as the difference between these two medications? Because we've heard a lot of stuff about on data from 5, 8, 10 years ago on overdose, but we really haven't heard anything about the abuse deterrent formulation itself. And since it's so close to Opana, and since FDA made that recommendation for Opana, I'm a little confused in terms of why there hasn't been more discussion on the actual excipients, on actually what's going on in the world, in the real world. And so I don't know if you can answer that, but I've been thinking about on and on because there's such a homophilia there, and I don't know why one and not the other. So I don't know if you can answer that, but I needed to say it because it's been nagging at me the whole time.
Hi, this is Jana McInich.
Oh, good. Yeah, go ahead, Jana.
I think that we do want to limit the discussion today to the product OxyContin that we're here to discuss. But I will say that in the post-marketing data, we did not see a shift from snorting to injection for OxyContin, and we were on the lookout for that possibility. And just to clarify, of course, that the Opana ER product was an oxymorphone product, and OxyContin, of course, is oxycodone, and there are also pharmacologic differences in terms of the level of oral bioavailability and things like that, in addition to the abuse deterrent mechanisms and properties between the two products that may affect patterns of abuse. And there may be others from FDA that might want to jump in on that, but hopefully that helps answer your question.
Thanks.
Okay. Dr. Nelson.
Thank you, Louis Nelson. I wondered when Dr. McInich or Dr. Green reviewed the unintended consequences of opioid use and ADFs as they did, if they did come across anything or have any comments about the risk of developing opioid use disorder or addiction, or another area that interests me, which is opioid-induced hyperalgesia. Thank you.
Hi, this is Dr. McInich. I'll answer the first question regarding the impact on the risk of developing addiction. We did look at this. We didn't find any compelling data to inform this question. This is really a longitudinal question, right? It's a question of risk or incidence. And what we have available to try to study that is retrospective data, right? We can't go back in time to before OxyContin was reformulated and design a prospective study where we could collect detailed data on, the development of addiction. And what we've learned actually from some other work done under post-marketing requirements is that the claims data, the claims-based data that we often use for pharmacoepidemiologic studies to look at that kind of risk, perform those claims-based algorithms using the ICD coding perform very, very poorly in ascertaining addiction, opioid use disorder. These are often carve-outs. It's not well integrated into medical systems. It's not often covered by insurance, and so we don't find those kinds of studies to be very useful. And so we're really limited. I think I said in my talk we may never have that data. I don't mean to be pessimistic, but at least for OxyContin, where there was that total market transition, I don't know that we'll have good data on that. With regard to your second question about the hyperalgesia, perhaps one of our colleagues from DAP might be able to answer that question. There's ongoing work in that area, not specific to ADS. I will say that in the literature, we did not see anything related to ADS and hyperalgesia.
Yeah, this is Dr. Roca from the Division of Anesthesiology, Addiction Medicine, and Pain Medicine. We have not seen any risk at this point with respect to hyperalgesia, any connection. It's definitely an interesting thing that we are keeping an eye out for, but we don't have any data to make a connection at this point.
Right, thank you. And I guess the same question reversed. There's probably no reason to think the risk would be lower of either of those with these formulations.
This is Dr. Roca again. I don't think you can make an assessment either one way or the other. So it's hard to say whether it will be a lower risk or higher risk. You're correct.
Okay, thank you.
Thank you. Dr. Bateman.
Brian Bateman, this is a question for Dr. Makinich and relates to slides 7 and 8 in the FDA summary of findings. So the main finding 1, you note that FDA came to the conclusion that the reformulation reduced abuse by non-oral routes, but then in main finding 2, the conclusion is that it doesn't reduce abuse overall. And of course, the non-oral routes of abuse are a subset of overall abuse. And so I'm hoping you can help me kind of reconcile these points, and I think it's important because it goes to some of the voting questions that we'll have later. Is the notion that the prevalence of abuse by the oral route is so much more common than abuse by non-oral routes that the lack of an effect there subsumes any benefit that would or obscures any benefit that would be observed in relation to abuse by non-oral routes? Or is there another interpretation?
Yeah, this is a very good question. I totally understand the question. And I think that our conclusion was, it was based primarily on the data that we saw, the strength of the evidence that we saw. And again, I think it may reflect different patterns in different populations. In the poison center data, the large majority of abuse is oral, and I think that is still probably true in kind of general population, misuse and abuse of the product, and so the kind of overall rates are going to be dominated by that route. In the more enriched populations, the treatment center populations, the selected cohorts of people that are with more advanced substance use disorder, who are already tampering or have high prevalence of non-oral use. There was, at least in the NAVAPRO study and in one of the published studies based on the radar skip data, some indication of a shift to oral abuse of OxyContin in people with more advanced substance use disorders. So I don't know if it's that if they have that available, they're going to use it in any way they can, as part of their armamentarium of opioids that they're using, or what exactly. But I think it's sort of a combination of those things that led us to that conclusion that the evidence really just wasn't that strong for the reduction in overall abuse.
Thank you. One quick follow-up, if I can. In your review, did you come across population-based estimates for the route of abuse of OxyContin in the pre-reformulation period from the National Survey on Drug Use and Health or some other source that would give us a sense of the kind of relative prevalence of oral abuse versus nasal abuse versus intravenous abuse?
Yeah, the National Survey on Drug Use and Health doesn't collect route data for specific products. There's some information about have you ever injected drugs, but not for specific products. Probably and Christina, feel free to jump in, but probably the closest to sort of population-based data that we have available with route information is the Poison Center data, where obviously this is a subset of abuse. So people for whom there's some problem, some adverse outcome that is leading to a call to a poison center, and in that study. And again, Alex can jump in with exact numbers, but it was 60 to 70% oral in the teens for non-oral, and then another proportion in the teens for unknown route where it wasn't reported.
I apologize.
Alex, please correct me.
I was on mute, double muted. This is Alex Core from FDA. If you pull up slide 31 of my talk, you can sort of see the proportion of abuse calls broken out by route if you're interested in the numbers. But in the pre-period OxyContin, about 68% were for oral abuse, and that increased slightly to about 72, and then you see sort of the commensurate decrease in non-oral. Sorry, this was slide 31. For OxyContin, so that's in blue. So if that helps sort of contextualize of what Jana was talking about. Again, this would be a very, very small subset, maybe of the larger pie, but maybe it gives you an idea. Okay, thank you.
Yes, thank you. Mr. O'Brien.
Yes, thank you. My question is a general one. I guess I need some more granular understanding of oral abuse of OxyContin. So, like with all pills, I can take 4 instead of 1. But if I take the 4, that does not affect the time release function. So I'm looking at bioequivalence and dose dumping concerns. So I guess in addition to that, as we saw the sample of a hammer to the pill, so if I was to take a hammer and crush it to the extent it can be crushed into large, and now I orally take it, is that impacting the time release function? Am I dose dumping, or am I still getting the same allocation of the oxycodone as I would otherwise? And that could be the FDA, the sponsor. It doesn't matter, whoever has the answer.
Is Dr. Calderon available to answer this question?
Yes, this is Sylvia Calderon from the controlled substance staff. Regardless, even if you can break or cut your the tablet, you still retain a high percentage of extended release properties.
Thank you very much.
Thank you. Dr. Marshall.
Thanks. Brandon Marshall from the Brown School of Public Health. I think my question is for Dr. Green. I'm very interested in this issue of switching and discontinuation post reformulation. And so we know that this was common, and there's maybe some signal that opioid abuse claims increased after these events. And yet in study 35014, participants were censored 15 days after ceasing a prescription. And so I'm wondering, I guess, two things. In your review, did you find any studies that examined overdose rates after switching or discontinuing reformulated OxyContin? And then the second question is, in that study, in that PMR4 study, was that a design decision made by the sponsor, or was that following some kind of guidance from FDA?
This is Alex Sikora from FDA. To answer your second question, I'm not sure who, the protocol and the decisions to for the study design and methods that were ultimately chosen, that was a back and forth for a long period of time between the industry and FDA. And so those decisions are made based on the data, based on sort of the science at the time, where the science is at that moment in time. So obviously, in retrospect, maybe some of these things should have been put in as sensitivity analyses, but I think at the time, sort of our thinking was to get a handle on sort of overdose rates in among people with any OxyContin use versus those with use alone, and that is a pretty tricky comparison given how often people intermittently use concomitant opioids. So I think that the goal of the study was to sort of figure out what are groups of patients that are at least we can sort of disentangle from each other and look at them. So obviously, yes, there's probably other things we could have done. I'm not sure that at the time we were sort of thinking about that fully, but certainly it's something that is important to look at, and probably is something that future work in this area should sort of consider this switching phenomenon with patients and what that means for these kind of studies.
Thank you. Dr. Spin? Dr. Spin, if you have a question? Maybe let's move to Dr. Maisel, and then we will go back to Dr. Spin. Members of the committee, please put down your hand in the icon if your question has been responded.
Thank you. Steve Maisel with mHealth Fairview in Minneapolis. I have two questions. One is, one of the public panelists had a slide that quoted Dr. Compton. And I was wondering if we, can put that back up and then give him a chance to comment on that slide, if Dr. Compton's still with us.
I believe he was going to leave for the day.
Oh, I thought I heard that he was still with us.
He's still here with us?
Okay, well, if he's not, that's fine. We'll move on. When somebody's quoted like that who's there, I would like to hear them respond one way or another. Second question, and this probably goes to the FDA and maybe to Judy staff in particular. Could you re-ground us
once again on the FDA's definition of an abuse deterrent formulation.
This is Judy Staffa. I think the language is used to describe, and I know we've talked before about our 2015 guidance, and there's language in there, but if you want the specific language, I'm wondering if Patrick Rollerson from our Office of Regulatory Policy might have that specific language fresher in his mind. Patrick, is that something you could help us with?
But while we're waiting for a minute, I mean, the purpose of the question is we keep talking about abuse deterrence formulations here, but you know, without a common mental model of what that means, I think many of us are thinking of this in different ways.
Right. This is Judy again. I can start the conversation. I think when we wrote this guidance, we recognized that to develop abuse deterrent formulations would be an iterative type of process because, of course, as abuse, something that deters abuse is marketed and then deters abuse, it's going to change the level. And so we struggled with trying to find, is there a bar, a number, a specific level that we would say an abuse deterrent formulation of a product should specifically deter abuse X amount compared to the original formulation. And that became challenging. And so what you'll see in some of the questions is we used the term meaningfully reduce, knowing that that might change over time. And so I think that's been some of the confusion. What we were trying to do is to have a model that would be adaptive to a changing environment and to allow for formulations that were increasingly better at doing this. So I think that's one aspect of the confusion. Patrick, did I see you able to pop in and help more with this?
He's having trouble with his audio. Maybe we could come back to this?
Sure.
Yeah,
yes, that would be a good idea.
Let's come back to this definition. Dr. Marcel, do you have further questions or shall we come back to these questions?
That was it. Thank you very much. Thank you.
Thank you so much. We will come back as soon as Dr. Patrick is ready. Dr. Gordon.
Thank you. Adam Gordon, the University of Utah. It strikes me that this is a question and clarifying question for both the sponsor as well as the FDA. It strikes me that we've heard a lot of epidemiological data, surveillance data, and a little bit of pharmacoepi data over the course of the last 2 days. But one voice that I haven't heard a lot of is the patient perspective of the formulation changes. In our reviewing documents, pre-review documents, specifically on page 764 of the 888 document, there was reference to 3 qualitative studies, and a specific one that I'm very interested in is the Bauer study, which looked at patients' perspectives of the formulary switching and their impact on their drug use. I guess the 2 questions I have from both the sponsor as well as the FDA are, number one, is there any other literature out there in the peer-reviewed literature regarding these patients' perspectives of what they did with the formulary change? And then secondly, in any of your evaluations, post-marketing data or evaluations, was there any consideration of evaluating patient perspectives? And I say this, and I'll just say this brief, I'm sure discussion will happen later today, but there was a lot of patient opinions during the period where the formulary changed that we all likely saw as providers. And I'm just very interested if there's any more data out there. Thank you.
This is Dr. McInnes. There was one study that you mentioned specifically, the Brewer study.
that maybe Dr. Green can speak to? Any details about that to share? Christina, we can't hear you.
Okay.
No,
sorry about
this
that.
Is Adam
I was
Gordon.
double muted. Yes. This is Dr. Green, Dr. Christina Green. And the study by Buer really sought to understand changing drug use patterns resulting from the reformulation by interviewing individuals in rural Kentucky. And so it really focused more on an abuse population. So it really looked at the issues that people reported following the reformulation with the abuse deterrent formulation in comparison to the original OxyContin. And it was, you know, a small amount of participants, about 25 participants, but it really gathered a lot of like objections from individuals who were abusing the original drug. And they really had, you know, they talked about the lack of potency, the length of effect, that it was more difficult to inject or snort, that kind of deal.
Thank you.
Thank you. And we have now Dr. Patrick Rollerson.
Yeah, can people hear me?
Yep.
Okay, great. So the question was, you know, how do we define abuse deterrence for purposes of our evaluation of these products? I'd say there's two relevant quotes from our final guidance from 2015. The first is that basically there's lots of different ways that one could make an abuse deterrent opioid, but most abuse deterrent technologies that we've seen and all of the ones that we've labeled are either designed to make manipulation more difficult or to make abuse of the manipulated product less attractive or less rewarding. And the other thing that the other way we describe it is, you know, for purposes of the guidance and our evaluation, abuse deterrent properties are defined as those properties that have been shown to meaningfully deter abuse, even if they do not fully prevent abuse. And we distinguish between abuse and misuse, defining abuse as the intentional non-therapeutic use of a drug to achieve a desirable psychological or physiological effect. Whereas misuse would be, you know, therapeutic, an attempt to achieve a therapeutic effect.
Okay, thank you for the clarification.
So this is Stephen. That was my question. Just to follow through on that, if I could. What we're getting at here is it's really a subjective evaluation. There's nothing objective about this. It's in terms of meaningful and those kinds of things, which is a qualitative piece, not a quantitative piece. Correct?
Well, I would say it's true that we did not, that we intentionally did not define the term with you know, objective parameters built into the definition. But of course, what we consider to be a meaningful difference that might be conferred by an abuse deterrent formulation is, you know, obviously based upon objective data.
Thanks.
Okay, thank you, Dr. Maisel. Dr. Springs, are you ready for your questions?
Yes, I am. I got my mute taken care of. My first one is for the FDA, and I'd like to ask the FDA for clarity on exactly what the vote is going to impact. And what I mean is, you know, what decision is the FDA trying to make regarding OxyContin that sparked this meeting and these questions? And then will the results of this vote impact the labeling of ADF OxyContin, or to either narrow it or remove it, or is there any impact at all on their labeling, and you're just looking for overall understanding? I'm just not clear on exactly where we're going with this, of the intention for our results.
This is Judy Staffa. That's actually a great question. I think as the Purdue folks have already told you, they have not submitted a request for a labeling supplement. So we are not directly, that could be an outcome of these conversations, but it is not necessarily an outcome of these conversations. We plan to take this information back and discuss it and decide what are our next steps. And I think some of the questions, as I walk through them when we get to that point, I think it will give you a better understanding. This is the first product for which we have had post-marketing data. So we are trying to make sure we get input and discussion publicly about what these data are, how we interpret them, how you interpret them, and what folks think about them. And then we plan to take this information back and determine what the next steps are.
Okay, so we're right now it's just information gathering, although it could result in specific changes either to the labeling of this product and or others.
Today we're talking about this product for the moment.
Okay.
But yes, we will be discussing whether and what kind of regulatory action or communication we may take with the information we have learned from these studies and from today's discussion.
Okay, great. And then I guess my other question is, what's the standard that we're being asked to hold? Meaning, unlike a lot of other evaluations, is the FDA stating that in this situation specifically, evidence supporting a qualitative but not quantitative impact is acceptable? The answer to the question is yes?
No, this is... I don't think that's not really what Patrick had meant. I think what Patrick was saying is that what we did not do in our guidance was we did not define a threshold. We did not say if an abuse deterrent product deters abuse by 20% compared to the original product, then we will call that abuse deterrent. That is not the standard that we have adopted, and there were many, many good scientific reasons for that. So given kind of the newness of this field and the limited data, and you've heard about a day and a half now of all of the challenges of studying this, we made, put in our guidance a goal of having a meaningful reduction. And that is actually one of the discussion questions that we're going to be talking about is what does that look like in this case for this product? And what do people think about the data that they're seeing? So it's not a qualitative standard, but it's how best to interpret the amount and the quantitative and qualitative data, the totality of evidence that we have put forward that you've heard from the public, kind of the whole package, what your thoughts are on that. I hope that's clear.
Okay, that was perfect. All right, thank you. Thank you, I'm done.
Great. Dr. Safran?
I think you mean, is that me, Dr. Kertész?
I meant Dr. Sharif Safran, but you are next.
Safran. Apologies.
Maybe actually Dr. Safran is not ready at this point. Dr. Kertész, if you want to go next.
Hello, this is Dr. Stefan Kertész from University of Alabama at Birmingham. And this question is probably for Dr. Green, and I would hope Dr. Dasgupta would comment. One of the issues we'll wrestle with is changes in heroin use in relation to entry into the market of the abuse deterrent formulation of OxyContin. And that has left me looking a lot at that literature that Dr. Green reviewed for us, where the findings seem so divergent in some of the analyses, particularly when state-level exposure to OxyContin is the predictor variable. It looks like that if that the more there is in the state, even adjusting for other pain reliever misuse at the state level, there's a bunch more heroin use, and that's really represented in the Powell study from 2020, and there's some individual reports where people say, I moved to heroin, but then in a paper authored, referenced by Dr. Green by FDA authors, looking at National Survey on Drug Use and Health data by Dr. Wolf, it is difficult to tell what, it looks like there's less misuse or less use of heroin, less use of prescription opioid relievers among people with a history of prior OxyContin misuse after the transition to, I guess, abuse deterrent formulations. These results at the individual level are contradictory to each other, and of course the state level analyses, which are ecological, often make things look terrible by comparison. I wonder if Dr. Dasgupta could comment, and I wonder if Dr. Green could comment, because I may have misrepresented the literature there.
Yeah, and we can call upon Dr. Dasgupta if he's still with us, and Dr. Green, Christina Green, to answer this question.
Sure. So this is Dr. Dasgupta. Thank you for the question. So with those specific studies, one of the things that makes it really hard to interpret is that the exposure, so the amount of drug dispensed that they used was oxycodone and not OxyContin specifically in pharmacies. So in one of the papers, they used all oxycodone. Another of the papers from the same group, they used OxyContin shipped to distributors, which includes like in-hospital use and all these other kind of factors. So it's a little bit hard to kind of put a pure linear trend onto those papers. So I think they're circumstantial. But the question, I mean, we did a study back in 2002 where we were looking at whether OxyContin causes transitions to heroin. And so this question has been around a really long time in different formats, even regardless of the abuse deterrent formulation with OxyContin more generally. In that original study from way back then, we found that people who transitioned from OxyContin to heroin, this is the original formulation, did so like within a year of initiating OxyContin use. So the transition was really rapid. So for the people who transitioned, and not everybody transitioned. So when we look at these serial cross-sectional annual studies, it's really, really hard to understand what that means, because the time resolution you need to get to a causal understanding really needs to be less than a year, because that's when, for those who do transition, a lot of that happens very early on. That's all I have for now, unless you want to follow up.
Great. Thank you, Dr. Dasgupta. This is Dr. Green, and I just wanted to clarify kind of what Dr. Dasgupta was saying about the Wolf study, is that yes, that was a serial cross-sectional study. If you can go to slide 25, please, in my presentation. Slide 25. I can just click through it. Slide 25. All right, so the main issue with this is that there was a variability in terms of when they're measuring the outcome. So if you're looking at this post-reformulation cohort of individuals who misused OxyContin prior to the reformulation or misused other prescription pain relievers prior to the reformulation, you're looking at a lag in time. And so they're measuring the outcome, or the exposure, I should say. They're measuring the exposure retrospectively. And that's going to differ regarding whether they're looking at a cohort or a cross-sectional sample of individuals prior to the reformulation or whether it's post-reformulation. And the further out you go from the reformulation, the bigger that potential for bias could be. Another issue with this study is that you're looking at a group of individuals who were community dwelling and who could have been identified by NISDA. So you're unable to capture the individuals who had the outcomes that wouldn't be captured in the sample. So let's say they were going to treatment centers, or they were homeless or incarcerated, or they died. You're not going to capture that. So that study, it gives one little picture, but it doesn't give kind of the more severe outcomes. And then also, would you please go to slide 29 in my presentation? So I think with these studies, and I think Dr. Dasgupta brings up a good point. The study he's referring to is the Evans study, which looked at the oxycodone shipment data prior to the reformulation as the measure of OxyContin abuse. And there were other studies like Alpert, for instance, and Powell as well, that they actually looked at OxyContin non-medical use prior to the reformulation. And they're basically finding that same issue, that states that had high pre-reformulation non-medical OxyContin use tend to experience larger increases in heroin-related deaths after the reformulation. And this association wasn't really found in the Alpert 2018 study for non-medical use of other prescription opioids and the increase in heroin-related deaths. But again, we have to be really, really careful with this data, because this is looking at everything at an aggregate level. So the level of analysis is the state, and we're looking at everything at a state level. So we can't really draw individual level inferences based on ecologic data, but it's still interesting to look at. Did I answer that well? Did I clarify?
Yeah, no, you yes, as clear as I can get. Thank you.
Thank you. Dr. Safran.
Hi, can you guys hear me now?
Yes.
Okay, great, thank you. Sharif Zafran with the Texas Medical Board. I guess I just want to clarify a couple of things. When I was looking at the data here, again, you talked about a decrease in non-oral use of OxyContin, but maybe a slight increase in the oral use of OxyContin. And I'm wondering, is that because it couldn't be altered, therefore there was an increase in the use of the unchanged tablet? And I guess the other thing I would kind of like secondarily ask with that is, are we looking at increased abuse potential, or, a decreased abuse potential, or a decrease or an increase in the severity or the morbidity or mortality in whichever abuse potential is going down or up? And the reason I ask that is that if there's an increase in the oral use, where the release of the drug is not altered, and yes, it may be an increase in abuse, but the morbidity and mortality because of it is not increased, as opposed to something that could be inhaled or taken IV, where the uptake is significantly higher and it can cause respiratory depression. To me, that means something, even though both may show an increase in abuse potential. One can easily lead to death, whereas the other one doesn't. Is that something that we should be looking for? Did I miss that anywhere in the data? I didn't really hear that part of it out there.
This is Dr. McInnes. I'll try to address your question, although I'm not sure we have. I think you're asking more of a why question or an interpretation question that the epidemiologic data are not necessarily able to speak to. The oral abuse, should clarify that the Poison Center study actually found a large decrease in oral abuse of OxyContin, and also a large decrease in oral abuse of multiple other comparator opioids. The NaviPro, the treatment center data, or people that are being assessed for or entering treatment, saw modest increases, not a big jump, but modest increases in both the proportion of people who report abusing OxyContin who report abusing it orally, and they could report multiple routes, so it's not even necessarily a zero-sum game. It can they can report more than one route, as well as a decrease in the number of cases reporting a slight increase in the number of cases reporting oral abuse in that population. In the RADAR's treatment center study, our study, the PMR study actually did not look at root of abuse. It was not collected at that time, but there were some follow-up studies done and published in the literature using one of the populations, the SKIP, the Survey of Key Informant Patients, that's part of that RADAR's treatment center program, that interviewed individuals entering treatment for opioid use disorder who reported abusing both the original and the reformulated OxyContin. And a substantial minority of those patients, they're patients of treatment centers, reported that they shifted from non-oral to oral abuse of OxyContin. So I just wanted to clarify that in terms of the data. Was there another question a clarifying question that we can answer about that?
Well, I mean, yeah, kind of along those lines, and this is what I'm trying to get at, is was there any change in morbidity and mortality? In other words, even if there was an increase in certain formulations of substance use, did that correlate with an increase in deaths, for example? And the reason, again, I'm asking that is that the form of abuse, even though it might have increased, was it less deadly to the patient? And even though it's not necessarily something that we're actually looking at specifically, but in my mind, it does make a little bit of a difference from the standpoint of, is something going to be deadly to somebody if they're going to use it more or less?
Right, yeah, and unfortunately, we don't have root data that is linked to death data. And in the death data, generally root is not well documented. The PMR-4 study in patients, insured patients who were dispensed OxyContin, we've discussed those findings in terms of not seeing a change in the overall overdose incidence and some decrease in the incidence of opioid overdose in patients that got OxyContin alone with no other opioids. We don't know what people were doing with their route of abuse in that population. We just don't have those data to make that.
Okay, well, that's helpful. I just think, no, that's helpful. I think that would be very helpful in assessing these kind of drugs and these kind of formulations. I mean, in my mind, it would make a little bit of a difference. But thank you.
It would be wonderful. Yeah.
Yep. Thank you, Dr. Green, Tracy Green.
Thank you. Yes, this is Tracy Green. I have a question actually for Dr. Green, and that is, I think I have the unique perspective. I was on the National Academy of Sciences, Engineering and Medicine 18-month study to do the recommendations. That really, I think, was a very exciting process, thinking about public health impacts of, considering public health impact of prescription opioid decision-making at the FDA and elsewhere. And I think the one recommendation that, one of the many recommendations that really stuck with me was 4-1, which is really to consider the potential effects on the illicit markets of policies and programs for prescription opioids. And that was really a recommendation directed at FDA. So I'm excited to have questions about diversion and heroin use coming up, although clearly they weren't there at the beginning because we wouldn't be here today if maybe they had, because they would have been part of the decision-making and design of the PMR. But nevertheless, we're discussing today. And so one of the questions that, and topics that came up very prominently in the chapter 4 around the recommendation had to do with illicit markets. And I didn't see discussed, or I'm curious in the literature or otherwise, but I did see in some slides from, I think slide 14 in your presentation on the effects of the reformulation on drug prices, on street drug prices, both the non-ADF and the ADF. And I saw some mention in Dr. Compton's slide 11 about the price of heroin changing over time and the kind of intertwined nature of effects of shifts in the market on intended and perhaps unintended also effects on the illicit drug marketplace and otherwise. But my question is actually around the question around counterfeits, something that hasn't been, I think, discussed yet. Fake medications, medications made to look like other drugs that are perhaps of interest, pressed with heroin early on because the street price was so low, and then now, as Dr. Compton's slide 11 really showed, how fentanyl is pressed into pain medication that is available on the street and internet and otherwise. So I was curious in your literature review if you saw any mention, and I understand that FDA has an office specifically looking at counterfeit medications. I don't know if anything came through data sources on that end, spontaneous reporting or otherwise, around data and how this may be even considered, or should we consider it, an unintended consequence of reformulation, the creation of a huge counterfeit medication problem.
Hi, this is Dr. McIntosh. I'll try to address that, and then Dr. Green can jump in if there's anything that she came across in the literature. But yeah, we are certainly aware of the issue of counterfeit pharmaceuticals. It's not something that we really have good data on. You know, most of the information that we get from it is the same place that everybody else does. The lay media. It's certainly something to consider, you know, in terms of unintended consequences. But I'm afraid we really don't have data to, you know, inform the question of, you know, the magnitude or specifically the relationship to the reformulation or, you know, other abuse deterrent opioids.
This is Dr. Green. I just wanted to add that this seems to be something that is mentioned as a confounder in other studies, but it wasn't something we really encountered within our literature review. So it wasn't, you know, the literature we encountered didn't really look at the prices of illicit drugs. It was more focused on,
thank you. I think this really hits a little bit at that larger question that came up a number of times in our readings around what's a confounder and what's a mediator. This really strikes me as a good example of something that maybe, is it a confounder, is it a mediator, and how to measure and look at that maybe in studies going forward if we can't quite see it here. Thank you.
Thank you. And I'm going now to call Purdue because I think they had some information as part of the clarification that they can provide.
Donald with Purdue. We'd like to ask Dr. Jody Green to discuss non-oral routes of abuse and the relative dangers.
Hi, this is Dr. Jody Green, Chief Scientific Officer at Inflection. And the question earlier about the increased risk with non-oral abuse of opioids. While we have not specifically analyzed this for OxyContin, we did publish a study in 2017 where we used National Poison Data System data to evaluate the risks of outcome associated with oral exposures to any opioid compared to that of non-oral exposures. And what we found is that over 2 times higher risk of life-threatening event or death when the opioid exposure was via the non-oral route as compared to the oral route. And when we try to bring this back to the evaluation of the ADF medications, it's really important to keep in mind what the intent of the ADF is, which is to deter the non-oral use. So I think that this is a great example of one of the ways to evaluate a kind of risk reduction, knowing that those non-oral exposures come with a much higher risk of life-threatening events and death. Thank you.
Okay, thank you for the clarification and the data. Dr. Krebs? Dr. Krebs, do you have a question? If
This is Erin. I'm sorry. This is Erin Krebs from Minneapolis, CA. I apologize. So my question is actually about, I guess related issue, intended or unintended effects on development of incident addiction. We've been talking about really closely related concepts, but I think addiction is really important here as something that is related to obviously abuse and overdose, but also because this is a chronic disease that carries with it serious lifelong consequences for patients, for people. And I think kind of classically the old-fashioned view of addiction, is the idea that people progress through recreational drug abuse and then develop dependence and addiction. But I think those mechanisms are clearly different in the populations we're talking about here. So we have patients who are prescribed opioids, and clearly the motivation for use there is pain relief. And some have hypothesized that really the pathway to addiction in patients with chronic pain who are prescribed opioids is different in that first they develop dependence and that they have a physiologic adaptation that requires them to take the drug to feel normal, that they can't easily stop using the drug, that they have escalating needs for it, and that any behavioral aspects of addiction like loss of control or compulsion to use develop subsequently. And then in the population of people who are not prescribed opioids, I'm sorry, I don't remember who showed the data, but I think that was from the National Survey of Drug Use and Health that patients who misuse or have non-medical use of opioids, that the primary motivation there, again, is relief of pain or other kinds of distress rather than, a kind of a recreational high kind of use. And so, certainly in both of those populations and both of those circumstances, it's oral use that is the issue, and in people who are prescribed opioids, it may not be abuse at all, but simply use as directed. And so just curious, and we've not talked about this, and I suspect it's not there, but if Dr. Green or anyone else could comment on any evidence that that there's been an effect in terms of increasing or decreasing the development of incident addiction.
Hi, this is Jana Makinich. I think you've hit on kind of the million-dollar question, and at least based on our review of the evidence, we see this exact question as one of the big remaining uncertainties about the reformulation and about ADF. As you mentioned, there are a number of different pathways, right, in different populations, and that's actually been laid out nicely in a qualitative way in an article by Washington group, Stumbo and Yarborough, and there are also, hypothetical changes to the risk of addiction based on changes in the reinforcing and rewarding effects when drugs are snorted or dose dumped. But there's really nothing in the real world evidence or in clinical trials or anything like that to inform this question. And as you say, many people become addicted, dependent, and in some cases addicted without ever transitioning from the oral route. Although in some of these kind of very small trajectory studies, people do described that transition from, oral to non-oral to be an important inflection point in their trajectory of, substance use disorder. So it's not that it is unimportant, but whether the ADF can do anything to change that trajectory, that progression, I think remains unknown.
Or even could, the concept of ADFs even increase risk by continuing to divorce in people's minds the idea of, use as directed or use for relief or avoidance of distress from abuse and addiction.
Mm-hmm. Yeah, let's take one last clarifying question from Dr. Setouchi, and then we will have time for discussion, so we can come back to all these interesting topics. Dr. Setouchi.
Thank you. My question is related to the FDA's presentation yesterday on the drug utilization analysis, as well as today's Dr. Green's presentation on the impact of dispensing, reviewing the existing literature. My question is really how we can interpret the decrease in utilization after the reformulation. Specifically, I wonder if you can comment that if it is a result of reformulation or other reasons not related to reformulation. The reason I'm asking is because if it's a result of reformulation, then the analysis with offsetting or adjusting for drug utilization seems like asking a different question from not offsetting or adjusting drug utilization. In other words, if the reduced utilization is a result of reformulation, then the analysis adjusting for offsetting for utilization is answering a question about the direct effect of reformulation, versus whereas the analysis without adjusting or offsetting for utilization is asking about a total sort of effect, maybe including direct and then also indirect effect as a result of reduced utilization in terms of the outcome related to abuse or overdose. So I would also be interested in if what I just said is how the FDA review team would view in terms of interpret the different models and different analysis that conducted in the post-market data.
Hi, this is Dr. McInich. I'm not sure if it's a clarifying question, but I think that we do agree with your interpretation of this question about utilization adjustment. And I think we touched on it, Dr. Lee in her presentation, and I did in my presentation as well, that we don't have really good data on exactly all the reasons for the changes in utilization. We make some assumptions and we triangulate based on different sources of data and what that change in utilization looked like, in part to the changes in the higher dosage strengths and things like that. But in general, I think the review team thinks that there were multiple contributors to the changes in utilization, one of which very likely was the reformulation and the abuse deterrent effects, but that was probably not the only driver of those changes. Okay,
So
thank
then
you. Thank you all. Sorry, Dr. Setouchi?
That's okay. So I guess my question was related to which sort of primary effect is that are we in the questions that FDA laid out later on for the discussion, are we looking at that sort of total effect, or are we sort of trying to understand the direct effect of the reformulation? Because really it depends on which analysis we should be primarily looking at in terms of interpreting the results.
Yeah, I think we can continue the discussion. Dr. McCanny, do you have the answer to this?
I just said I'm not quite sure how to answer that. Maybe when we get to the voting questions, if we can try to clarify the question, if that would be helpful. Or actually,
Yeah,
Dr. Lee would like to respond. Hi, can you hear me?
Yes. Yes.
Oh, hi, can you hear me?
Yes,
Hello.
we
can. Okay. Yeah. Yeah. I think I understand what Dr. said. Because depending on, you would look at it as a mediator or a confounder. If you look at it as a mediator and if you adjust for it, then you would end up estimating direct effect only, ignoring indirect effect. But our answer is we don't know. We don't know. We should view it as a mediator, or we should view it as a, confounder, or if that, drug utilization is something else, so we should put it, as a different pathway in the causal pathway between ADF and abuse. And again, that's why, because of this uncertainty, we used a lot of different modeling approach, and then just try to, look at the range, because we believe the truth is between somewhere. And if there's an evidence, then the evidence should be robust. I hope this answers some of your question, but yeah, the simple answer is we don't know. And we hope that we can figure out.
Yeah, well, I think we can discuss this as part of the wording of the questions and the discussion. Thank you, Dr. Lee. So we will now proceed with the charge to the committee from Dr. Judy Staffa.
Hi. So now we are at the point where we're going to, I'd like to just walk through the questions that we have teed up that I think you've all had a chance to look at. So the way we have structured these are 7 questions. The first 4 really relate to the PMR studies 1 through 4 that you heard about quite a bit yesterday. So this first question is a discussion question, and I think several of the questions in this last session kind of relate to this, and so I'd like to just try to explain it a little bit. The question is to discuss whether the evidence shows that OxyContin's reformulation with abuse deterrent properties has meaningfully reduced its abuse by 1 or more routes or overall, and related adverse outcomes, including overdose. Please share the scientific rationale for your opinion, including what you believe to constitute a meaningful reduction. So I think we talked about this a little bit, that in the guidance that we have put out, basically with the controlled studies, the category 1 through 3, basically abuse deterrence is defined as a product. It's always relative to the original product. There's always a comparator. And so that's the basic concept of abuse deterrent. It's more abuse deterrent than what. And so here, the studies were done in such a way as to compare the reformulated OxyContin with its original. And so in the category 1 through 3 studies, you may see some percentage of reduction of release of the active pharmaceutical ingredient when the product is manipulated. So the question is, compared to the original formulation where manipulation may result in 100% release, that's determined to be, well, that is somewhat abuse deterrent. So the question now is, now we have data in the real world, which is of course a different setting than in controlled settings. And so the question is, what would represent a meaningful reduction? And again, we are open. We would like to hear kind of your thoughts on whether the data you've heard suggest that a meaningful reduction has occurred and what you think that looks like. So this is a discussion question, and we're very interested in hearing your views. The next 3 questions are voting questions, where we're actually going to be asking you to answer the question of, does the available evidence demonstrate that the reformulation of OxyContin meaningfully reduced abuse of this product, again, relative to the original formulation, by 1 or more non-oral routes? So here we're going to first tackle non-oral routes. And if your answer to this question is yes, we're very interested in understanding what drove that answer. So we're very interested in hearing which routes of abuse have specifically, like which of the non-oral routes. Is there a particular population, one or more, where you think this was demonstrated? And then your thinking on which stream of evidence, because you've heard many, did you find the most compelling? If your answer is no, it would be very helpful for us to understand, is this no coming from the fact that you believe that there is compelling evidence that says it is not, does not demonstrate meaningful reduction of abuse, or is it that you think your no is related to you don't think that there's enough or adequate evidence? And if so, what additional information would you need to feel that it could be? So that's question 2. That will be a voting question. Question 3 is also a voting question. Again, this is moving toward, does the available evidence demonstrate that the reformulation of OxyContin meaningfully reduced overall abuse? So this would be abuse by any or all routes. And again, relative to the original formulation. And again, depending on what your answer is, we'll be very interested in hearing your rationale. Equally important to your vote is your rationale around a yes answer or a no answer. Question 4 is the final voting question, and that will be voting, does the available evidence demonstrate that OxyContin's reformulation meaningfully reduced the risk of opioid overdose? Again, relative to the original formulation. And again, this is, we're very interested in hearing your rationale behind a yes or a no answer to that question. Then questions 5 and 6 move more into the realm of the public health impact. So in question 5, it's a discussion question. We'd like you to discuss whether the available evidence indicates that the reformulation of OxyContin had any important unintended adverse consequences. So it's really targeted toward those unintended adverse consequences that we're very interested in hearing about. And again, if you can kind of focus in your discussion, what were those, if you saw any, and which population do you believe they occurred, and again, which piece of evidence or stream of evidence did you find most compelling in forming your opinion about this? And again, if you did not think that the available data were sufficient, if there is additional information that you think would be needed to really provide a better answer to this question, we'd love to hear about that. Question 6, again, this is more not just about unintended adverse consequences, but we'd like you to consider the totality of evidence and to discuss the overall public health impact of the reformulation. Again, so this would be overall both positive and negative impact. And explain, again, what was the evidence you found most compelling, and if you think there's insufficient evidence, what additional information do you think is needed to address this question? And then finally, our last question is about, I think, a question that one of you had brought up about next steps. We'd like you to discuss, is there any information that you've heard that you think is important for us to convey to clinicians, patients, and the public about the post-marketing evidence of reformulated OxyContin's effectiveness? And its effectiveness in reducing abuse and related adverse outcomes, and or its overall public health impact. And remembering in addressing this question, FDA has many vehicles to communicate, one of which I think you brought up was labeling, but there are many other ways we communicate with patients, with clinicians, and with the public. So I think what we'd like to hear is, what do you think is important to communicate? More important to us than the specific vehicle. Although, again, if you have recommendations around that, obviously, we're welcome to hear them. But it's important to us to understand if there are particular pieces of information that you think are important to communicate. So with that, I will turn it back over to Dr. Hernandez-Diaz, and looking forward to a great discussion of the questions. Thanks.
Thank you, Dr. Staffa. The committee will now turn its attention to address the task at hand, the careful consideration of the data before the committee, as well as the public comments. We will proceed with the questions to the committee and committee discussion. I would like to remind public observers that while this meeting is open for public observation, public attendees may not participate except at the specific request of the panel. So after I read each question, we will pause for any question or comments concerning its wording, to make sure that it's clear to all of us. and then we will open the question to discussion. And I would like you to focus on the question in front of us, but keeping in mind two things. One is that there is going to be a vote later, so all the things that are affecting potentially your vote later on, all the concerns or issues, this is the time to discuss them, and do not tell us your vote. And I will also for you to keep in mind that there are going to be other discussion questions about public health and intended consequences or next steps. So please, let's focus first on the discussion of the first question. You will have the opportunity to discuss other things later on for questions 5, 6, and 7. Okay, so let's read the question, paying attention to the wording and clarity. Question 1 for discussion. Discuss whether the evidence shows that OxyContin's reformulation with abuse-deterrent properties has meaningfully reduced its abuse by 1 or more routes or overall, and related adverse outcomes, including overdose. Please share the scientific rationale for your opinion, including what you believe to constitute a meaningful reduction. So first, any question about the wording? Dr. Maisel.
Hi, thank you. Steve Maisel from Fairview in Minneapolis. You know, the key word in this question or charge is right in the middle of the second line, the word meaningfully. We talked about this a little bit before. What is a meaningful reduction in abuse? We know that nobody's claiming that OxyContin's formulation is going to reduce abuse by the oral route because it's not designed for that, and you know, but that's where the majority of the abuse is. So you know, what all it can do is make it a little bit harder to abuse it by nasal or by injection. If somebody is hell-bent on doing this, there are a gajillion websites where people can go to and learn how to dilute this stuff for injection or nasally or whatever. So you know, it can deter the very casual early user or abuser rather of OxyContin. But if somebody is hell-bent on abusing this by one of those routes, it can't get there. So it gets into the word, you know, what's meaningful. And I don't know that it is a meaningful reduction in risk to make it a little bit harder at the beginning, and then they go online, they figure out how to do it later, and they go ahead and do it. So that's you know, that's how I'm looking at this. It just doesn't meet the criterion for me of the term meaningful.
Okay, thank you. So other than clarifying how meaningful, before we go into the discussion, any other clarifying question about the wording before we answer the question? Dr. Folman? Dr. Folman, any clarifying question about the wording? Okay, maybe Dr. Coffin, any question about the wording? Okay, maybe you do not have questions about the wording, and if that is the case, we can proceed with the question itself. So let's open it out. Let's open this for the discussion of the question, assuming there are no concerns about the wording. Okay, so Dr. Folman.
Yeah, thanks. I can speak again. So yeah, I do a lot of clinical trials and sort of in large cardiovascular trials. what we often power the studies are for maybe a 25% effect reduction in bad outcomes. And so that's one way you can operationalize this. I know the FDA mentioned something like 20% earlier, and they were hesitant to do it, but I need some kind of reference. And so from the trial background that I have, that's how I'm going to formulate this, basically. Just that's how I'm going to do it. And then also it has to be statistically significant. So that's my sort of operational way of trying to address this. The other thing has to do, I guess, with the earlier comment about what is its intended benefit, really? And I think it really is intended for to prevent non-oral abuse, basically. And the farther away you get from that, the less likely it's to show an effect and more likely to be made complex, I guess, with the off-target effects, unintended consequences, and so on that are really so difficult to deal with. And I guess just a couple other comments then about the denominator issue and whether we should use drug utilization. You know, I'm sympathetic to the drug utilization control in a way, but I don't really know if it's like a mediator or a confounder, and so I don't really know if I should invoke it or not. There was some, stuff shown the other day that suggested when you did incorporate drug utilization into the model, there was a better fit, which sort of seems satisfying at the start, but then the more I thought about it, I don't know if better fit really means that now you've successfully controlled for the problem or not. It's a thing that I don't know if it's doing, it's evidence that it's doing what we want it to. So I'm a little wary of the drug utilization just because I don't really know much to bank in it in this. So anyway, those are just some thoughts I have, that I've been thinking about over the last couple of days. Over.
Okay. Thank you. So to take your point about how to deal with the utilization, because I think this is one of the key issues for the interpretation. I agree with Dr. Sotowuchi that it is not a question of its statistical fitting of the models and whether the fit is better or worse. It's just a different question. So whether to adjust for the utilization that happens after the change or not is not a question of whether it is statistically better, but what is your question? So that if we want to ask what is the consequences of the reformulation, what happens afterwards, and if that includes a decrease in use that then results in a decrease in abuse, that's part of the effect. So if we then adjust, control, or stratify by the utilization, then the question we are asking now is whether there is an impact that is not mediated through the lower use. So I think it is not a question of what is the better model, but what is the question we are asking. And within adjusting or not for utilization, then there may be better ways or better models. So, but I think this is one topic that we can maybe discuss a little bit. And Dr. Sotowuchi, I don't know if you want to come back and kind of wrap up that discussion about what is the impact of introducing utilization in the model, and how shall we interpret the results with and without utilization.
Thank you, Dr. Hernandez-Diaz. This is Soko Sotowuchi at Rutgers. So I totally agree that this is probably not a statistical model fit question, but rather what questions we're asking in terms of different models adjusting or offsetting for drug utilization. It really depends on how we see the data, whether or not the decreased utilization is the result of reformulation, whatever the reason might be that the doctors are kind of stayed away from the new formula because of the abuse term, or it was because patient complained it's hard to swallow. But if that's in the downstream of the reformulation of the medication, then that seems like in a causal pathway to the effect of the reformulation. So I think, I don't know if looking at closer at the data about the drug utilization may actually shed more light to understand why that utilization reduced after the new formula of OxyContin.
Yeah, thank you. And I think in that context, several explanations were offered, but we cannot really know, like the deterrent effect, the inconvenience, if you are planning to abuse, the cost we mentioned. I don't know if we are going to go back. Okay, so I don't know if the comments that that you have are related to that, so we might be coming back to this point, but I'm going to follow the order. Dr. Griffin?
Yeah, I just want to say about I think we really have to take utilization into account. I mean, one could make a product in the extreme that nobody wants to take, and then there would be no abuse, no deaths associated with that product that no one's taking. So just to take it to the extreme. So I think there may have been multiple reasons why the use of this product went down, but I think we're most interested in, if you start somebody on this product, I mean, does it really prevent them from from misusing it? I don't think we saw strong evidence for that.
Yeah, thank you. Dr. Coffin?
Thank you. I'd like to second that comment. I mean, fundamentally the question is, you know, the idea here is if I'm prescribing a medication, if it's a patient that I were to prescribe the original formulation of OxyContin to and they would develop a use disorder, would prescribing them this medication avert the development of disordered use? And so to me, the utilization is key in the model. And in fact, I don't think it quite goes, you know, one could argue it doesn't go far enough. By my back of the napkin calculation, the number of tablets dispensed went down to about 33% of the pre-formulated number. But when you calculate in the reduction in milligrams per prescription per tablet, it looks like it went down to about 18% of the milligrams that were being previously dispensed. And that's really how I think about opioids. So to me, the utilization is key, and, you know, arguably maybe didn't go far enough. I think a bigger issue, and I know this has been mentioned a few times, is this abuse topic and, you know, the terminology of abuse. And I really am grateful for the FDA's discussion at the beginning of the session yesterday about the term abuse and that it really doesn't have a medical role anymore. And I think it is fundamentally problematic in not only because it is, we know it's a stigmatizing and it's stigmatizing term. It's very hard to define. It's almost like saying, you know, and it doesn't really capture the things that we're trying to capture. We end up having to use proxies for it because it's, as a concept, it's just not of real utility, and it's not what the reformulation is designed to achieve. So I think that is probably the biggest issue, and is the biggest issue that I have with this question. Another thing I want to bring up is the role potentially of social determinants of health, which was raised by Dr. Dasgupta, and this is in part, you know, in PMR4 there was the finding of potentially some benefit maybe among commercially insured people in some sub-analyses, but not among publicly insured individuals. And so there's something to be said about, you know, how this is deployed and what populations it may or may not be correct for. But, you know, fundamentally to me, the question that we're being asked in this kind of goes back to that first question of if I am prescribing this instead of the original formulation, if I could choose between the two, would I pick this one thinking that it is going to be of a net benefit to my patient? I'll stop there.
Okay. Dr. Green?
Thank you, and I Tracy Green. I was I'm grateful to Dr. Coffin for the comments around social determinants of health, which is definitely a concern of mine as well on the data that were presented across the board, and also recognize deterrent formulations and the perpetuation of a term that is inappropriate and stigmatizing. But my comment, or what I wanted to sort of think about here, with the group here, is really kind of hitting at the question around what is meaningful. And I've been reflecting on this and thinking maybe we should take a step back, and it's unfortunate Dr. Compton's on the call, but to think of how NIDA really came to the conclusion for their healing community study that a 40% reduction in overdose-related mortality was the goal within 3 years, and 4 states heavily affected by prescription opioid use disorders and misuse for better parts of almost 2 decades, are now at the helm to answer this question and incorporate community-based, evidence-based interventions. And I think if that larger question of like, maybe we should align then and try to think about a meaningful number somewhere, somehow at NIH, and otherwise the decision was 40% is a meaningful reduction within 3 years, approximately the time horizons we're talking about here. So maybe that we could use that as a guidepost, and my own back-of-the-envelope calculations doesn't seem to suggest that anything we've looked at is hitting the mark on that number. So just a thought to put out there. And then I think kind of related around this the language issue in the abuse deterrent formulation, if we were to reconfigure and think about risk reduction, maybe a risk reduction formulation, an RRF rather than ADF might be more appropriate, rather than using a term that's both stigmatizing to the patient if they're prescribed it, the provider if they're saying that this patient needs this medication, and it's inaccurate because from all the data we're seeing, it's pretty much nothing is totally abuse, if you will, deterrent, or we're humans. We use substances. We always have and we always will. So we're looking for relative to something or reducing our risks. So those are my comments.
Dr. Kinsley, but could you mind stating again what would you be considering meaningful, maybe based on NIDA, and how far was the evidence presented from what you consider meaningful?
Yeah, the healing community study, which is an NIH initiative, considers within 3 years to focus efforts to significantly reduce opioid overdose fatality by 40%. So that's the targeted, and maybe there's a lot of history that others on the group may be able to share on why 40%, but this is aligns with the other state-based initiatives where I've seen 30% or 40%, but I think it's really meaningful that NIH put the stake in the ground at 40% as being a meaningful reduction.
Okay. And do you think that the evidence presented in the last 2 days was far away from this, or close to it?
Well, let's see, I'm looking at study 1, 57% to 27% for snorting, and 31% to 25% for injecting, roughly an average of 30, somewhere between 30 and 35%. So that's really back the envelope. But is that clinically meaningful? Is it significant? And that's in population of people who are being assessed for substance use disorder treatment. So in using that goalpost of 40% is not quite there.
Okay. Thank you. Dr. Horrow.
Yes, thank you. Jay Horrow, industry representative. The FDA statisticians and the epidemiologists that produced thoughtful, copious analyses of the data and appropriately emphasized their limitations in clear, dispassionate presentations to us, and I think we should thank them for them. Relating to Dr. Follman's comment, George Box, a prominent statistician, said, all models are wrong, but some are useful. So that leads me to ask which of the models offered are useful. In particular, what's the usefulness of the utilization model, that's number 2, and its sidekick, number 3, that uses tablet number as a covariate. While the availability of crushable, soluble tablets plausibly could drive non-oral abuse, I find less plausible that availability of the ADF would drive non-oral abuse, and certainly not in a linear fashion. Even oral abuse of the abuse deterrent formulation challenges plausibility because of the delayed release of the drug, as we've learned even with cut tablets. Further, the absence of any analyses of the residuals of the regressions with tablet number as a predictor, and logarithmic or other transforms of tablet number increase my reluctance to find the utilization models useful. Regarding Dr. Griffin's extreme example in which utilization goes to 0, the model proposed, which is to divide by utilization, would produce a result of 0 over 0. And that is not 0. 0 over 0 is indeterminate. It could produce any number if we tried. And so I find Dr. Griffin's argument one that leads me to shy away from the utilization model rather than embrace it. I find model 1 the most useful of those offered. It shows that ADF reduced non-oral abuse as is intended for this product. While other models might have lower AICs, that's the information number, by ascribing some model variation to tablet counts, tablet volume normalization, in the opinion apparently of several panel members, underestimates the value of the abuse deterrent formulations. In other words, fewer abusers desire the ADF, so fewer prescriptions are written, leading to fewer abuse occurrences. Should this be ignored? The FDA suggests that the lower AIC for models 2 or 3 versus model 1 argues for their preference. Rather, I view neither AIC or any other metric should be a criterion to compare utilization normalized models to others, because utilization models probably misrepresent the impact of ADF. Regarding the meaningful reduction, I agree here again with Dr. Follman for the same reason. In cardiovascular medicine, clinicians and payers consider relative risk reductions exceeding 15%, which usually correspond to absolute risk reductions of about 1% per year or more, as impactful for endpoints of death, heart attack, and stroke, all life-changing or life-depriving events similar in severity to the outcomes of addiction. The magnitudes of estimated reductions in level or step down, whatever you want to call it, and slope exceed 25%. So in my opinion, yes, these reductions are meaningful. Thank you.
Thank you. Dr. Nelson.
Thank you, Lewis Nelson. I do not think that the ADF formulation has shown a meaningful reduction in abuse overall or by any specific route. To me, there are just too many confounders in the existing epi data that we've really spent a lot of time hearing about, but things like shifting drug choice some of the geographical issues that Wilson Compton talked about, some of the subpopulation issues that Nestas Gupta talked about. And I think we're really having a bit of a forest for the trees problem in the sense that we're really looking at these micro populations in a very large population of people who abuse, and I use that word understanding all of the pejorative and stigmatizing nature that it has. And because of this, we're unable to make credible and generalizable decisions based on the data that we currently have. I do believe that we need to look at utilization to normalize the meaning of any data that we find. But I'm very concerned that we're not going to be able to easily find a meaningful reduction because it's a shifting target. If everything stayed the same when the transition from non to abuse deterrent formulation occurred, we might be able to come up with a number. But because it's a non-static, it's a dynamic population, I just don't think we're going to be able to easily do that. I remember, I think few people in the big picture of opioid abuse, used again, understanding the meaning, abuse OxyContin, and few of those who abuse OxyContin use it non-orally. I think finding a meaningful change is going to be very difficult overall, and to come up with a number that's going to be a target, I feel is going to be exceptionally difficult. I do have one comment to make, though, which I hadn't been able to make up till now about the data. And I work at a poison center, and obviously I feel quite dedicated to the work I do. But poison center data is really difficult to interpret, in part just because of the spontaneous reporting nature of it and its lack of a denominator. And I know the investigators and the discussants done a great job trying to explain it. But I really am concerned because it's based on so many subpopulations, right? A lot of the calls come from the public, and many of them are just questions. A lot of the other half of the calls come from healthcare providers. But even among those calls, it's very difficult to really make heads or tails out of poison center data. So if you looked at poison center data, you would think that nobody smokes pot in this country, right? Because we just don't get calls about that. Right, but we know that certainly cannabis use is probably far exceeds opioid use and other things like that. And then we really don't get calls even about opioid overdose because doctors know how to manage those things. So the denominator is really important here. And trying to apply a high standard of evidence to that sort of data is really quite difficult. And it always gives me pause when I try to do that. So looking at the data as a whole, I'm just very concerned about its overall credibility, just given all of the confounders and limitations that are implicit to its use. Thank you.
Thank you, Dr. Nelson. Dr. Sibel?
Thank you, John Zabel, RTI International at Emory University. Thank you, Dr. Nelson. I concur with all you said. You said it so clear. I really appreciate it. I kind of want to build off the utilization argument a bit and kind of bring a real-world perspective to this a little bit. So when I look at this question and I'm thinking, okay, does the new formulation reduce abuse? And when we look at all the data, what we have is we have people using OxyContin in an environment of supply where there are a lot of options. And at that time in 2010, 11, 12, there were a lot of instant release and extended release that weren't abuse deterrent on the market. And so if I have a problem and I've been taking OxyContin, I can crush it up and inject it easily, and now I can't, right? If a friend of mine or a buddy has Opana and I learn how to crush those, why wouldn't I just switch, right? Molecularly similar, both strong drugs, both strong doses, or more so, you got a burgeoning heroin epidemic starting in 2008, right, with iatrogenic precursors from prescription opioids. So people are like, whoa, I'm just going to switch to this. Maybe my dealer, that's selling me the reformulated version also has heroin and says, hey, try this. And so I want to actually give a quick story. When I was in Scott County, Indiana as a CDC scientist for the EpiAid, when we were looking at the HIV outbreak, we talked to a lot of people, interviewed a lot of people who were injecting drugs and people that were HIV infected. And what they all said is they were all using OxyContin before their use of Opana. And they said that, well, first of all, they were sniffing OxyContin a lot. A lot of people weren't even injecting it. But those that were sniffing and injecting, when you could no longer do that, they just switched to Opana. And when I asked them, why did you not switch to heroin? You can just go to Louisville and get some heroin from there. They all said, we don't want that. We don't know what's in it. We don't know how strong it is. With the pills, we kind of know what we're getting, and Opana is equally available. And so our research showed that Opana was dangerous, right? Opana comes off the market, and now those same people, because I keep in touch with the needle exchange there, now they've transitioned to heroin. And so I think my concern is it's hard to look at reductions in use and overdose within real-world situations through the data that we have. So heroin east of the Mississippi River right now is basically non-existent. I want to make that clear. Very difficult to get heroin, even in Boston or New York City. Fentanyl is everywhere. In the West Coast, that's different. Let's say, and people are really scared of fentanyl. Let's say all the pills go away. We say that these reformulation is safe. It gets cheaper, right? It becomes maybe a generic cheap, and now the reformulation is everywhere, right? My fear is that people are going to go back to the reformulation because even though it's harder to do, it's a lot safer than fentanyl. And people are switching a lot of drugs. A lot of the methamphetamine use in the preliminary data we have is switching from opioids to methamphetamine because people are afraid to overdose. And so it's really hard to look at this reduction just in the context of utilization of illicits. So if we look at utilization of supply, legal supply, if there's less prescriptions, less supply, there's less abuse. But if there's illicits that are out there, right, or other medications, the switch is easy. What happens when these are on the market now? Are those people in Scott County going to go back to those ADFs because they don't like heroin? They don't want to use heroin. They don't like fentanyl. They're afraid to die. So it might be harder to do, but it might be safer. So I just wanted to share that with the committee in the sense that for me answering this question, it's hard to disassociate reduction in use, abuse, morbidity, and mortality from the larger environment of supply. Thanks.
Yeah, thank you. Dr. Marshall.
Thanks, Brendan Marshall, Brown School of Public Health. I wanted to reflect on Dr. Coffin's comment around PMR4. I've been thinking a lot about those findings related to overdose and that sub-analysis that maybe there was an effect among commercially insured patients and who were only receiving OxyContin. You know, I guess it's possible that that does show some benefit for that subset of patients, but I think that that whole study is so affected by substantial selection bias. I think that's an equally feasible understanding of those results, in that once reformulation happened, you have all of these patients that are at higher risk for overdose switching or discontinuing and therefore dropping out of the risk set. And so you're left with a much lower risk of people, and that's probably differential by exposure, by product. And I noted as well that a censoring event in that study was termination of commercial insurance. So I was trying to think, like, is it possible that that magnitude of selection bias could be quite large in that specific subpopulation of commercially insured folks? And it might be if many, ran into trouble, started to develop problematic opioid use after the reformulation, lost their job, lost commercial insurance, and then overdosed, those events would not be included. So I just don't, when I look at that study, even that signal in that subset, I think there's biases there that provide an equally feasible explanation.
Thank you.
Thanks.
Yeah. Dr. Zakharov?
Yeah, hi, this is Kevin Zakharov from Renaissance School of Medicine at Stony Brook University. And when I look at this discussion point, I think about a number of things. With respect to the reformulation, the abuse deterrent properties, and meaningfully reducing abuse makes me think about a couple of things. As many people have already mentioned, the definition of meaningfully, Dr. Staffa asked about that specifically. I know in many of the FDA presentations we heard, which were excellent, the word compelling was used. The words non-compelling were used. I consider those to be interchangeable with meaningful in my mind. So if the FDA made a presentation that noted compelling differences, then that's meaningful in my definition. I think as we have heard a number of people just talk about with respect to terminology, I've been frustrated throughout the course of these past 2 days with the interchangeable use of words such as misuse in many of the articles and abuse relating it to addiction necessarily. So I think in the way I'm interpreting this discussion point, it would be as to whether it's compelling or meaningful with respect to reducing non-oral, non-medical use. Those would be the roots that I would be considering for this discussion point to apply to. And then I have to think about who we're really talking about. Somebody who spoke, the last person or the person before, used the word patients. I don't know whether we're talking about people, whether we're talking about patients for whom this medication might have been prescribed for a medical purpose, but I think it's really important for us to consider when we talk about compelling and meaningful who we're really talking about. If we're talking about people who are likely to try and, as Dr. Mizell mentioned, go online, find the recipe, hack the medication, doesn't necessarily make me think about patients specifically. It makes me think about people. So my takeaway with respect to this discussion point, which unfortunately I'm not seeing on my screen right now, but I am looking at the printed version, is that I do believe that since this particular medication was changed to a reformulated version, no longer being offered in the non-abuse deterrent formulation, that by definition it had to have some effect on what would ultimately happen, knowing, as we've heard many people who spoke before me say, that this didn't happen in a vacuum. And the graphic that I typically use when I discuss this is the CDC 3 waves of the opioid epidemic. And I'm sure many of you have the image of that graphic in your mind. And when I look at a specific point in time, I mention a variety of different things that were happening coincident to the reformulation of OxyContin, such as the extended release opioid REMS, and a number of other things that were happening with respect to mitigating risk. So I don't know that I could say single-handedly the reformulation had a significant impact, but I think it did have some meaningful and compelling change in effect. I think that, as we've heard discussed very eloquently over the past 2 days, there is some balloon effect that we can identify that happened. And I think many of us would agree that when you squeeze the balloon, things go in another way, and economics could play a role, availability could play a role, ease of manipulation can play a role. And when I look at this question from that perspective, then compelling and meaningful is what I come away with. And with respect to the scientific rationale, while the 3 studies following it maybe didn't necessarily, in the FDA's opinion, show compelling evidence, the first study, the NaviPro data, in the FDA's opinion, did. And, you know, again, I'm just switching the word meaningful for compelling. So that's the basis of my objection. Thank you.
Thank you. So, thank you. Given the time, I'm going to take two more comments, and then you will have time to explain your points during the right after your response. Dr. Bateman.
Thank you. So I think as we reflect on this question, we have to remember why OxyContin was reformulated. So it was reformulated to make it more difficult to crush, to make it more difficult to syringe in order to decrease two of the most dangerous forms of non-medical use, intranasal or nasal snorting or intravenous injection. And if we think about this intended effect and the data that we have that best evaluates whether that intended effect was achieved, I think the PMR1, the NAVPRO Treatment Center study, is really where we need to look, and in particular the interrupted time series analysis. And there we can look at the intercept to identify the change in intercept before and after reformulation as the place to see the immediate and most direct measure of the reformulation, independent of secular trends, independent of subsequent interventions like the Florida Pill Mill or the REMS training program. And there in the Model 1, where there isn't an adjustment or offset for dispensed prescriptions, the abuse proportion falls by 52%. And then if you look at Model 2A, where there's an offset for the number of tablets dispensed, the effect is a little bit attenuated, but still quite substantial, a 32% reduction in the intercept. And you know, these are proxy measures in terms of how they translate into the impact on misuse in the general population, but these are really substantial immediate reductions, and so I think if we look at the question, is there evidence to suggest it has a meaningful impact on reducing abuse? I would say by the non-oral route, the data are quite compelling. Now, there's a lot of other issues we need to talk about in terms of what the abuse deterrent language, the implications of that for how the medication is prescribed and the perceived safety. There are a lot of other components to this, but I think if we look narrowly at why OxyContin was reformulated and did it have an effect where it was intended to have an effect, to me the answer is the data suggests it does.
Thank you. One last comment, Dr. Gordon.
Thank you, Adam Gordon, University of Utah, and I'll keep this very brief with the time. Many of the comments made by the previous presenters were what I was going to make. I would say first off, I strongly urge FDA to change ADF terminology. The language regarding chronic pain and the language of people with addiction is changing rapidly. We know that abuse is a very pejorative word. And I don't think that you're using abuse in your terminology in a correct way. The public will sense that abuse deterrence means lack of addiction based on the formulation. So I strongly urge the FDA to go beyond just what we're talking about now and change change the name. Second, I want to bring you down to the patient level very quickly. You know, I want to take off my researcher hat and I'm going to put on a provider hat. During the time that the formulation was changed, we had seen in addiction clinics and in clinics where we had patients with opiate use misuse or problems associated with their pain medications. Many were on OxyContin, the old formulation, and when the formulation switched, myself and other colleagues saw a dramatic change in how people were actually using the medication. They were no longer using that medication and then switching to others. Now, I believe, in fact, in that situation, switching is a good thing because we've changed an abused product to a product that is not being used at all by patients. So I think in some ways, as a thought process, a gold mine would be that all opioids have ADFs. And if that's the case, then maybe we wouldn't have so much problems with some of the data that were presented over the last 2 days, as well as kind of thinking that switching and changing an abused product may be a good thing. The last thing I'll mention very quickly is I'm very torn over the last 2 days with regards to a lot of what meaningful outcomes that we're looking at. The data is relatively not clear in many situations, but I'm also very cognizant that we never really talked about the cost effectiveness or cost benefit of these formulary medications or these ADF medications. It does take quite a bit of cost. And I think answering a question that's going to be asked later on to the panel, we got to think in a public health sense is, how much costs are we going to go down in order to make any outcome that's benefit to patients. Thank you.
Thank you. Let me try to summarize before we take a break. I think the committee in general may agree that the product may be there, but there is really no consensus on what meaningfully means. If we consider meaningful as compelling data, particularly in the results from PMR1 with over 52% reduction in some of the outcomes, then we will say yes, if meaningful is a clinically meaningful compared to other aspects where over 25% reduction is meaningful. For some of the members, they see that there is a meaningful reduction, but in others, if we put a higher bar of like an over 40% reduction, then maybe we are not quite there yet. So the evaluation of meaningful, I think it depends on the outcomes that we are considering and the magnitude of the change. Then we had discussion on the role of the utilization. I think in general we agree that there was a reduction in availability and in use of tablets, maybe not so much in the cumulative dose, and that in itself will reduce the abuse, particularly or also in oral use, and how to normalize the abuse by the utilization. There was some discussion about that, and I think it was acknowledged that because the use is not static over time, it is really difficult, and we might not be able to completely evaluate the effects because of that difficulty. And along those lines, we acknowledge a lot of challenges from the data. We are using proxies for what we really want to capture. All the studies have limitations in general, including the ones we look at. The limitations of the data as a whole reduce the credibility of the evidence. So we have to take that into consideration. Another challenge was that the environment itself, the supply around this particular product is changing over time. So it is hard to understand abuse with all the other factors changing in utilization around what we are evaluating. And another limitation that was mentioned in addition to this mediator effect of utilization is the confounders, for example, in the PMR4, who is being prescribed with a new product might affect what we see in terms of overdose. So other than the limitations, other factors mentioned were to consider the social determinants of health and the population issues, and the use of thinking about this as a risk reduction, and because that language is less stigmatizing and maybe more accurate to talk about what we are evaluating. So that's what I took from our discussion. There will be time for further clarification after your responses to the voting question, but let us take the break now. And if you allow me, let's take 10 minutes break and come back at 3:18. And panel members, please do not discuss among yourselves, and we'll be back in 10 minutes. Thank you. Okay, so hello everybody. We will now move on to the next question, which is the first voting question, and Dr. Gil Bautista will provide the instructions for the voting. Yep. Dr. Bautista?
Hi, this is Phil Bautista. I'll now read the instructions for voting through Adobe Connect. Questions 2, 3, and 4 are voting questions. Voting members will be using the meeting platform to submit their votes for this meeting. After the chairperson has read the voting question into the record and all questions and discussion regarding the wording of that vote question are complete, the chairperson will announce that the voting will begin. If you are a voting member, you will be moved to a breakout room. A new display will appear where you can submit your vote. You should select the radio button, that is the round circular button in the window that corresponds to your vote. Yes, no, or abstain. You should not leave the no vote choice selected. Please note that you do not need to submit or send your vote. Again, you need only to select the radio button that corresponds to your vote. You will have the opportunity to change your vote until the vote is announced as closed. Once all voting members have selected their vote, the DFO, myself, will announce that the vote is closed. Afterwards, the vote results will be displayed on the screen. I'll read the vote results from the screen into the record, and then the chairperson will go down the roster, and each voting member will state their name and their vote into the record. You can also state the reason why you voted as you did, if you want to. However, you must address any subparts of the voting question, if any. We will continue down in the same manner until all questions have been answered or discussed. If there are any questions regarding this voting process for question number 2, please raise your hand. Sure, I see a question from Dr. Zabel.
Yeah, hey, I'm embarrassed to ask this. I just walked in a little late as you were saying how to vote. Can you just explain it again on the platform where yes and no is? I've been looking for it.
Sure. Once we move to the meeting breakout room, you will see the vote choices at the bottom of the screen, around where the captioning is currently. I see a question from Dr. Sprint. Dr. Sprint, do you have a question before we move to the voting?
No. I apologize. I was still had my hand up from the previous discussion. Sorry about that.
Okay.
Thank you. I see there are no more questions. Dr. Chair, Dr. Sonia Hernandez, I'll leave it to you.
So I'm going to read the question, and then we are going to clarify any question on the wording before we go into the voting. So question number 2. Does the available evidence demonstrate that the reformulation of OxyContin meaningfully reduced abuse of this product relative to the original formulation by one or more non-oral routes? If you answer yes, we would be asking you to explain after the vote, which routes of abuse you believe have been meaningfully deterred by OxyContin's abuse deterrent properties, in which populations you believe this effect has been demonstrated, and how would you rate the strength of this evidence supporting your opinion, and which evidence did you find most compelling? If you answer no, then we'll ask you to please explain whether you think the available data are sufficient to answer this question, and if so, how would you rate the strength of this evidence supporting your opinion, and which evidence did you find most compelling? And if not, what additional information do you think would be necessary to answer this question? So is the wording clear to everybody? Okay, so if there are no questions or comments concerning the wording of the question, we will now begin the voting on question 2. Remember, non-oral routes.
Sub-conference rooms are open.
This is Phil Batista. The vote is now closed and complete. Once the vote results display, I'll read the vote results into record. This is Phil Bautista, DFO. We have 20 yeses, 7 noes, 1 abstention. And now hand it back to Dr. Hernandez-Diaz.
So thank you. We will now go down the list and have everyone. Thank you. I was muted. Thank you. We will now go down the list and have everyone who voted state their name and vote into the record. You may also provide justification for your vote if you wish. However, please remember to address any of the parts of the question that correspond to your vote. We will have the question up in the screen in a little bit. And so we will start with Dr. Setouchi. If you can please state your vote.
Yes, Stoko Setouchi from Rutgers. I voted yes. In answering the question listed here, which route, I believe that it's, the data showed both in nasal and then also injection of non-oral abuse. And then which population is that? I think it is the population represented in the NAVAPRO study, PMS1, and similar population of patients with history of abuse or access for abuse. I would rate the strength of evidence moderate to strong, especially with the time series analysis design that used in the PMS1.
Thank you. Dr. Amir Shafi?
So my name is Marian Amir Shafi, and I voted yes to the question at hand. I second Dr. Setouchi's sentiment about the data, provided that I did feel that there was a signal that there was a decrease in the non-oral routes of abuse, specifically injection and intranasal abuse. However, I would say the strength of the evidence was moderate at best, and I think likely overstated because there were so many confounding factors.
Dr. Cortez?
Yes, this is Dr. Stefan Kertes from University of Alabama at Birmingham. I will state that I voted yes on this proposition. I will explain that the evidence that swayed me was primarily the NAVAPRO study, in which there was varying on estimates 31 to 54% reduction in report of non-oral abuse of OxyContin in persons entering. I would rate the quality of that evidence as moderate. I wish to note for the record that this is not a question about whether there was protection of patients or of populations, but protection of a drug from its misuse, and I'm affirming yes on that question.
Thank you. Dr. McAuliffe?
Yes, this is Maura McCullough from East Carolina University. I also voted yes on this question. I too believe that the evidence from the studies presented and from published literature gave some fairly compelling evidence that the reformulation reduced the abuse by non-oral routes, nasal, and more so with injecting. I think the consistent decrease from about 29 to 55% supports that. Again, I agree that that is a moderate amount of reduction. I think, too, it was supported somewhat by 3051-2. There were some population-based rates that demonstrated a reduction in abuse that were greater for the reformulated OxyContin relative to the competitors, although that was one model that was not the most adequate in terms of the AIC. And finally, I think that some evidence from published studies, even weaker, but still provide some additional evidence that there was a decrease. A number of papers found a decrease in snorting and injecting OxyContin, and actually the magnitude in the literature was somewhat larger than in the PMR studies. That's why I voted that way. Thank you.
Dr. Foreman. Dr. Foreman? Okay, we can come back to Dr. Foreman at the end. Dr. Meyer.
Hi, this is Dermot Marr from Johns Hopkins School of Medicine. I voted no on this. There was some signal in some of the studies suggesting that there may have been evidence that the reformulation meaningfully reduced abuse. However, I felt that the quality of the evidence and the magnitude of that change was insufficient for me to be able to vote yes on this question.
Okay, thank you. As a reminder, there were some subparts to the question. It would be great if, as part of your response, you touch upon those. Dr. Fidel.
Hi, John Zabel. I voted no. The data for me was not convincing. I do concur that there was some signal on one and a little bit of two, but for this level of decision for me and the implications that this has and the context of everything before us with morbidity and mortality, I just think that the data was weak to moderate, not compelling to me at all. Not just linguistically for abuse, but just more the confounders. And the strength was not strong enough to really make the case. To be honest, I'm a little disappointed in FDA, not individuals, because I felt like there could have been way more data. We had a bunch of years for this, and there's so many of us that could have done some really amazing studies and got at this question. I would suggest thinking about using syringe services programs from now on, treatment data, and poison control data. I've used it before. It's really problematic to use. Treatment data I've used before too. I've published with it, and it's problematic as well. A lot of limitations on it. SSP data, I think it's the only programs that interact with active people using, and I think it's an untapped population that we can go for and ask people that are using what are they doing, rather than ex post facto. So yeah, I think I answered the two questions. Thank you.
Thank you. So this is Sonia Hernandez-Diaz, and I voted yes. I think there was evidence to suggest that there was a reduction in the non-oral routes, and that for me the stronger evidence came from the PMR1, where there was a jump in the slope, and like above the trend. But I do acknowledge that it seems that part of the reduction in abuse came from a reduction in the use itself. And also would like to point out that the formulation does not deter abuse overall, but only for one particular formulation through one or two particular routes. And then regarding the in which population, I think it affected the population of already abusers, that probably because they have more non-oral abuse. Dr. Nelson.
Hi, it's Lewis Nelson. I voted no. And I think that I stated earlier many of my concerns, but I think that the data is exceptionally confounded and dynamic in the nature of the population. I think several of the papers were biased at the source, perhaps not fatally, but it always raised questions about some of the interpretation and study design. I think several of the studies had a lot of subjectivity to it that's difficult to control for, such as the NaviPro data and some of the RADARS data that looks at people entering into treatment, and there's always a certain degree of secondary gain and other concerns we have when we're dealing with people in those situations. I think there are some definitional issues as well, particularly when you get into the big data of study 4, where I think there's a lot of mixing of abuse and addiction and dependence and overdose and hyperalgesia and a lot of other things, and makes those data sets very difficult to analyze. I have to say that if they really wanted to do a study that showed something, it's very hard to do, but they might need to do something prospective and try to follow people over time, and whether that's done in a registry format or another sort of a controlled trial would probably give us a better answer, but I'm not sure there's any real worth in doing that. I think the meaning of this finding, even if they showed it, would be very limited.
Thank you. Dr. Folman, I see that you are connected again. Would you like to state your name and vote? And please answer the sub-questions within your answer. Thank you. Dr. Folman, are you available to vote? Okay, we will come back to Dr. Folman at the very end then. Dr. Hovingwe.
Hello. I said no for the record. I did note that there's some benefit within some of the studies, particularly the NaviPro study. I echo some of the concerns of others in the committee that spoke to the confounding variables and the different populations, some of the subjectivity of the endpoints. And I think also, if we're going to design studies in this space, having some consistent measure of what meaningful benefit might be would be helpful in future deliberations.
Thank you. Dr. Saffron.
Yeah, hi, Sharif Saffron. I voted yes, and specifically that there is evidence of less abuse in the intranasal and the IV form, and less so than the oral. I thought that the evidence was fairly moderate to strong, especially with the PMR1 data. I do think that you have to look at the evidence as it's presented to you, and the confounding factors are there, but it's the best that could be used given the circumstances that we had. So that's my answer.
Dr. Griffin?
Yeah, this is Marie Griffin. I voted yes. I felt that based on the NaviPro, the PMR1 study, both in the analyses that did and did not control for utilization, there suggests that decreased use by the non-oral routes nasally or intravenously, and the evidence for that was moderate.
Thank you. Mr. O'Brien.
Yes, I voted yes. And as with others regarding a product orientation, the goal was to prevent dose dumping, and I thought that PMR1 showed that there was a reasonable reduction, probably moderate evidence of reasonable reduction for both snorting and injection. And I think even though there was weaker data, but even though there was more swallowing, the fact that it could be kept still from dose dumping and the swallowing based on the crushing was important to me. I didn't get to share the meaningful portion of the question in my discussion. I was struck more by PMR4, whereby it showed that the primary population right across the board in all three databases was in fact the joint and musculoskeletal health patient population. And that sort of framed it for me in terms of meaningful with many in the patient population, but also personally. I have to say that after my surgery, I came home with 450 MMEs of opioids, which represented 300 tablets, tapering down to still 105 MMEs, but that still represents 150 tablets. And someone who is the father of 5 children, or married, representing 10 adults, and have 11 grandchildren, it is very meaningful for me to make sure that there's discipline in terms of inventorying the product, monitoring the product, keeping it locked and away from potential experimental things. So it clearly, for me, from a meaningful perspective, the fact that that ADF is there does have a lot of meaning to me.
Thank you. Dr. Jausa.
I voted, this is Mariam Josa, I voted yes, and the reason I voted for that was largely based on the NaviPro data. The trends in the overall use for nasal and the injected forms of abuse had decreased by about 30 to 50%, which I thought was fairly good. The data quality I thought was moderately decent.
Dr. Krebs?
I voted yes after spending a good part of the day on the fence. This was based primarily on the NaviPro, the first study, as well as the literature review. And it seemed that it was consistent that there was a decrease in non-oral use. I wasn't sure if it was truly meaningful. We really talked about relative decreases a lot today, but the absolute difference, even in the highest use groups, those with high addiction severity scores, was only about 3%. So, you know, a relatively rare behavior was reduced a relatively small absolute amount. But anyway, yes won out after having this internal battle. I think that this effect seems to be pretty limited to the specific population of it was patients in, I think, the NaviPro study who were in addiction programs, and those specifically who seem to have moderate to severe addiction severity. And I would rate the overall strength of the evidence here as quite weak. I thought that the study designs were fairly low quality, but they were consistent.
Dr. Bateman.
Brian Bateman, I voted yes. I think the strongest evidence for yes comes from PMR1, as the other panelists have indicated, particularly the interrupted time series analysis of those data. So I think the population where we have the strongest signal for benefit is patients with serious opioid use disorders who are being admitted to substance use treatment facilities. In terms of the strength of the evidence, I guess I would say moderate to strong, but it becomes even stronger when you look at the remarkable consistency of signal for benefit in decreasing non-medical use across all of the data sources that were reviewed.
Dr. Coffin.
Philip Coffin, I voted yes to this specific question that that the reformulation reduced use by injection or insufflation among the treatment-seeking population with opioid use disorder that was studied in the NaviPro PMR1 project. And I found the evidence to be vacillating between weak and moderate and recognizing the weaknesses in the data, and also, as Dr. Zibel points out, there's some heterogeneity across the country in this phenomenon and in what people inject that has a lot to do with street markets that are difficult to measure in this type of analysis.
Thank you. Dr. Green?
This is Tracy Green. I voted yes to answering this particular question, and I interpreted it very literally, focusing specifically on the one route of administration that to me appeared to achieve a meaningful reduction, which is the snorting. I did not see that in the injection data as much, and especially from evidence from the literature review and even demonstration during the public comment that the injection route, there's some easily defeated with time and some heat and some other available implements. But the importance of snorting being a factor that has a route of administration that is meaningfully reduced by the reformulation, that was the basis of my vote. The population that I felt this was affecting and had been demonstrated in were folks with, or patients with moderate to severe symptoms of substance use disorder. And the data that expressed that best, hands down, I think was the NaviPro data, the first PMR study, to meaningfully convey the route of administration. It did see that the poison control data echoed many of these findings, but there was so much missing route of administration data and so much oral use that I didn't find it as compelling to answer the specific question. Thank you.
Thank you. Dr. Woman?
Richard Ehrman. So I struggled with my vote, but ultimately I voted no. And even though I agree that there's definitely some signal in terms of decreasing rates of non-oral abuse, such as injections and intranasal use, and also there is some somewhat compelling data, I should say, looking at poison cold center data, as well as some of the literature reviews that were presented to us and the NaviPro study as well. But ultimately I voted no, because it really doesn't meet, in my mind, the meaningful threshold to me in terms of % reduction, and mostly has to do with the low quality data and numerous confounders that others have already discussed, and also differences in where the data came from, certain regions of the country, certain patient populations, patients already with existing moderate to severe substance use disorder, patients in treatment. And so in my mind, it just doesn't meet the threshold in terms of % reduction, and given the low quality of the studies presented. And so I voted no. On quality of evidence, I would still rate it as, I guess, low to moderate, but it just doesn't quite meet the threshold for me.
Thank you. Dr. Higgins?
Dr. Higgins, I voted yes. I did believe that the evidence was convincing and meaningful enough to show a reduction in the non-oral routes, specifically snorting and injecting. For me, the NaviPro data was most useful in making my assessment with the patients being assessed for SUD treatment. 30511 data I felt were most compelling in answer to the section 3, but the study was underpowered and OxyContin abuse was shown to remain high among any route in the subsequent studies, 30512 and 30513. So I was conflicted with respect to the rate of the strength of the evidence.
Dr. Sprint.
Hi, this is Dr. Michael Sprint. I voted no, and I voted no because I don't believe that the evidence that was presented, while there may have been some signal, I don't believe that it was sufficient quality nor magnitude to answer this question. Dr. Nelson hit the nail on the head about the quality, or rather lack of quality, of the evidence being presented today, with the majority being from poison control centers and the problems with using this type of data. I do have significant concerns about the question when it's observed in a vacuum, that even the results may be seen in an inappropriate way, because as we were talking about earlier, the reality is we don't live in a vacuum, and there are serious consequences of accepting this, especially because, as we've seen, abuse deterrence has been marketed, whether intended or not. it has created in many physicians that don't have any understanding of addiction a false sense of safety to prescribe for at-risk patients or patients with active substance use disorders with chronic pain. And there's a huge danger that comes with this false sense of security. And a lot of folks were mentioning the NaviPro data. And the NaviPro data is measuring patients with opioid use disorders at treatment centers that can pay for this service. So it's a small population of people actually, and it doesn't translate into the general population. But I found it amazing that this is not a drug made for addicts, for people with opioid use disorder. This is for chronic pain patients. And what I mean by that is it highlights a significant problem that we haven't talked about, is that physicians prescribing OxyContin and other opioid medications not having awareness or training in understanding and identifying addiction among patients that present with pain, and then how to manage and handle them appropriately. And so I think that in the future, additional information, there has to be more information from populations other than patients from a treatment center or a poison control center for this kind of to answer these kind of questions.
Thank you. Dr. Zakharov.
Yeah, hi, this is Kevin Zakharov from the Renaissance School of Medicine at Stony Brook University. I voted yes. I do believe that the information presented to us and other publications in the literature point to the fact that for this product, relative to the original formulation, as the question is asking, that there was demonstration with respect to intravenous and nasal routes of administration. With respect to the populations that I believe this effect has been demonstrated, as I alluded to earlier, I think it, for me, is people who would likely attempt to manipulate prescribed medication or a medication that has been diverted to them. So I consider that to be populations at increased risk of either substance use disorder, willingness to try and manipulate a medication, et cetera, and as we've heard many people already say, it has to be compounded by everything else that's going on, but there is no such thing as a vacuum, and there's not a vacuum moving forward either. With respect to the strength of this evidence, I would say that I would fall into the moderate category rating based on, again, the information presented during these past 2 days and other publications in the literature. Thank you.
Thank you. Dr. Davies.
Hi. I agree with the FDA that PMR 3051-1 and 3051-2 provide evidence that the ADF reduces non-oral abuse by inhalation and injection. I also agree that this applies to individuals seeking treatment for substance use disorder. And this is consistent with other evidence provided by Dr. Dart that individuals were more likely to switch from high doses after reformulation, which are more likely to be seeking the use of the drug for not its intended purpose. I agree with Dr. Krebs that the quality of the evidence is quite poor because the reformulation occurs at the same time as large changes in culture that were happening at the time of the reformulation. As discussed by Dr. Dasgupta, members of the public, physicians, and patients drove a variety of programs, policies, individual decisions, prescribing habits that would differentially affect OxyContin around the time of the reformulation. The reformulation itself can send a social signal to patients, physicians, and society about the dangers of the drug that can change behavior even without real changes in the physical deterrence effectiveness of the drug. However, the drug did change, as indicated by the pre-market studies. PMRs 3051-1 and 3051-2 provide evidence in this uncertain backdrop. The population-based models provide strong and consistent evidence of the effectiveness of reformulation through one or two of both mechanisms, reduce prescriptions, and two, reduce non-oral abuse among those prescribed the drug. Population-based estimates are valid if high-risk individuals switch away from the drug because of its reformulation. which is a more likely explanation than physicians prescribing the drug to high-risk patients, as indicated by Dr. Dasgupta and Dr. Dart. If this is the case, one would expect a lower non-oral abuse rates among the remaining patients who accept the drug because the high-risk population has substituted to an easier-to-abuse option. However, the utilization-based rates indicate that the remaining patients have a lower non-oral abuse rate, but the decline was not much larger than the comparator drugs. The result is that the population-based estimates are likely a large overestimate of the reformulation's effectiveness, and the utilization-based estimates are a large underestimate. Considering all of this, I think that there's evidence that the total effect was around 20% with a interval of around +2% to -40% with a poor quality of evidence.
And can you please state your vote into the microphone just for the record?
I voted yes.
Thank you. Dr. Maisel?
Hi, Steve Maisel from mHealth Fairview in Minneapolis. I voted no, and I maybe I'm just overly hung up on this term meaningful. I agree that in that interval between when the formulations were changed, that the data on abuse showed an impact. But there are so many confounding factors. There's little evidence that that impact was sustained relative to everything else that was going on in the community. And we know, we heard it from the public panel. We know it from our own practices and lives and literature that it is easy to convert these products to liquid form or whatever. So I am not convinced that that reduction is sustained relative to the original formulation, and so that therefore the term is meaningfully reducing abuse of the product. I have my doubts, and in fact, I've sat on a number of advisory committee meetings where we've looked at other types of OxyContin or other opioids with suggested abuse deterrence as part of it, and many of them have been turned down. And those products actually have evidence better than that of OxyContin. And I just wonder, if today, 10 years later, knowing what we know today, if we would have attributed or allowed the labeling of OxyContin to have abuse deterrence associated with it based on what we know today back in 2010. Hindsight's 2020, but I just don't know that the evidence here is strong enough to provide a meaningful reduction. Plus the confounding factors of the fact that if it's labeled as abuse deterrence, what does that do to overall prescribing? And are there providers, physicians who would see it as non-addictive and therefore create a different type of population than we had before? And these are questions that are probably impossible to answer unless you had, a population with the old formulation and a population with new formulation and, half the country or something and did a prospective study. That's obviously not ever going to happen for 1,000 reasons. But based on the evidence that we do have, while there was a improvement, I'm not convinced it was meaningful or sustained.
Thank you. Dr. Goldra.
Did you say Gordon?
Yes, Dr. Goldra.
Yeah. So this is Adam Gordon, University of Utah. I voted yes. I believe that it was meaningful for deterrence of intranasal as well as IV use. I think the evidence in PMR1 in particular, as well as the qualitative study of Bauer, B-U-E-R, showed that it did change practices within patients that have opiate misuse and or opiate use disorder. I think I would rate the evidence, though, as extremely weak, mainly because of all the confounding and all the other interventions that were going on during that time. I'm not so sure that there's a causal link in a lot of the data. That's the best data we have, but I would call it weak. The last thing I'll mention is, at least in my perspective, our addiction world in particular is searching for what a meaningful outcome is, not only in clinical trials, but also in observational studies. And I think much of this meaningful outcome assessment that we're trying to wrangle with is a huge problem in our field. Thank you.
Thank you. Dr. Basavana Gowda.
Yeah, Basavana Gowda from Penn Medicine. I decided to abstain because I couldn't yes, because although NaviPro study does, suggest it discourages insufflation and injection, but I don't think a database study is good enough for an answer like this, which has huge ramifications from the prescription standpoint. And at the same time, I couldn't vote no because what else can be done? I don't know whether a prospective study is even feasible because it's going to be prohibitively expensive. Thank you.
Dr. Marshall.
Brandon Marshall, I voted yes. I think there's evidence there that there was reductions in insufflation and injection routes, but that effect is probably only prominent in persons with more severe opioid use disorder. I'd rate the evidence, strength of evidence, as weak, maybe moderate at best. I thought the data from NaviPro #1 was most compelling. I was impressed that the results were robust to model specification, the choice of denominator, and I wanted to commend the FDA for conducting and summarizing such a large suite of analyses with different assumptions. And I did note, as other panel members, the qualitative studies by Havens and Bauer that reported that people reported challenges snorting and injecting the drug after reformulation. So looking at this question very narrowly, considering non-oral routes of abuse of this particular product, I voted yes, but clearly there is a lot of switching and transitioning to other products, including heroin, that is important to consider sort of outside of how I read this question.
Thank you. Dr. Chauvin.
Yeah, Abby Chauvin, I voted yes for reasons that have been stated by everyone. So I agree with sort of the FDA that the NaviPro data was most compelling and most relevant to sort of answering this question. And that sort of the historical sort of counterfactual that I was thinking about was like, if they hadn't introduced this new formulation, what would we have seen? And so I think looking at that exact sort of, as Dr. Bateman noted, sort of that exact drop right away where you're seeing the 30 to 50% reduction is important. And I do think that sort of the dramatic drop in prescribing is important too, because certainly there's a lot of confounders that we've talked about, but I do think there's at least some reasonable belief that some of that drop was due to the reformulation that wouldn't have happened if it hadn't been reformulated. And I guess I would rate the evidence as moderate. Thanks.
And Dr. Holman.
Yeah, can you hear me?
Yes.
Great. This is Dean Pullman. I voted yes. I took sort of the question literally, and I focused on the question of people in the study and not sort of the general, like, broader issue. And for me, the question of whether it improved in abuse by inhalation and injection was pretty clear and consistent across PMR1, PMR2, and PMR4. I thought the strongest evidence was in PMR1, and I think that's the population to which it probably applies the most. I think the evidence was probably moderate. Partly my giving it that rating is due to what I see as a consistency across the different models and the different sets of analyses. That's all.
Thank you. Okay, so we will now move on to question number 3, which is also a voting question. So first we're going to see if there is any question issue with the wording. Can you read it out loud? Does the available evidence demonstrate that the reformulation of OxyContin meaningfully reduced overall abuse of this product relative to the original formulation? So highlighting the overall abuse. And then if you answer yes, please explain in which populations you believe there is an effect that has been demonstrated, and how would you rate the strength of this evidence supporting your opinion, and which evidence did you find most compelling? And if you answered no, then please explain whether you think the available data are sufficient to answer these questions. If so, how would you rate the strength of this evidence supporting your opinion, and which evidence did you find most compelling? And if not, what additional information do you think would be necessary to answer this question? Okay, any question about the wording or clarification before we go into voting? I don't see any hand. Yep.
Dr. Hernandez-Diaz.
Oh, Dr. Bateman, sorry, now I see you. Okay, yes, sorry.
Okay, yeah, Brian Bateman. So could the FDA say a bit more about what they're looking for here? So if we postulate that nasal insufflation and IV abuse are important components of abuse overall, and a majority of us just voted for indicating that we did think there was a meaningful effect there. How should we think about this?
This is Judy Staffa. I'm going to ask Dr. McKinnon if she can expand on this. I tried, but maybe my explanation wasn't so good. So Jana, can you take a shot? I know this focuses on the studies that looked at overall abuse, because when we do that, we're often looking, if something is decreased, sometimes something else is increased, and we've seen
so
that
this
in
would be
other formulations.
interpretation of the studies that looked at the composite of overall abuse, whether there's signal for benefit in those subset of, okay,
right.
that's
why
helpful.
We have them look at that. We don't want them to only look at one route. We want them to look at all routes. And so this composite measure, which was one of the outcomes, we wanted to see what people thought about that. Jana, did you have anything to add to that, or is that pretty much your thinking as well?
No, I think that's right. I hope that clarifies things. But looking at the totality of the evidence.
Thank you. I don't see. Well, Dr. Sakharov, do you have a question about the wording?
Yeah. So again, in line with Dr. Bateman, just to make sure that I'm digesting the question appropriately, when we say reduced overall, does that mean by any route of administration?
That's right.
Okay. Thank you.
Okay. If there are no further questions or comments concerning the wording of the question, we will now begin the voting on question 3.
Hi, this is Phil Bautista, the DFO. All voting members will now be moved to the breakout room. Please be aware that there is no discussion of the question while we're in the voting breakout room, excuse me. Voting members will only be casting their vote. Thank you. Hi, this is Phil Bautista. The vote is closed and is now complete. The vote results are displayed. I will now read the vote results in the record. 2 yeses, 26 noes, 0 abstentions. Thank you.
So thank you. We will now go down the list and have everyone who voted state their name and vote into the record. You may also provide justification for your vote if you wish. However, please remember to address any of the subparts of the question that correspond to your vote. And we cannot put them in the screen because they would be too small, but if you have them handy, please make sure to go through the subparts of the question in your answer. We will start first with Dr. Sotowuchi.
Dr. Sotowuchi from Rutgers University. I voted no. The reason is based on the PMR2 radar study. I did not find any compelling evidence that the reformulation reduced the overall abuse, and also supported by part of the analysis done by FDA PMR1 that there seems like increased abuse by other non-oral routes, so which makes sense. And then especially the product is intended to reduce non-oral route, not the overall abuse route.
Perfect, thank you. And just in the interest of time, I'm going to ask the members that if your arguments are the same, they have been stated before, you can just refer to them as they have been already stated, and so we can move on with the vote faster. Dr. Amirshahi.
I am Marianne Amirshahi, and I also voted no for previously stated reasons. Additionally, there were many confounding factors
as well, and so it was really difficult to determine if there was a meaningful impact. Thank you.
Dr. Kates?
This is Dr. Stefan Kertes from University of Alabama, Birmingham. I voted no. The question was whether there is proof for a proposition that there's an overall reduction in abuse of OxyContin. I found it to be unproven for reasons already stated.
Dr. McAuliffe? Dr. McAuliffe?
Yeah. McAuliffe, Laura McAuliffe. Yes, I also voted no for the reasons already stated. The NAVPRO study is my primary source, and then secondarily, I think a little bit weaker, but corroborating that, was the 51-2. Also, there is some literature to support this position with Cicero demonstrating that while 3% of people stopped because of the reformulation, 66% continued, and 43% changed from injecting to swallowing whole. So I think collectively these do not support that the reformulation led to a decrease. Thank you.
Dr. Fullman?
I voted no, and I think the thing I would add is, this reformulation is meant to cut down on inhalation and non-oral forms of abuse. And so if we really, in terms of finding additional evidence for this, I would try and target on what I would call like a pre-abuse population. And for that population, maybe you could see like an overall benefit basically. But this is a hard target for them to meet because it's not really meant to address this directly.
Dr. Mayer?
Hi, this is Dermot Maher from Johns Hopkins School of Medicine. With regards to the question of does the available evidence demonstrate that the reformulation meaningfully reduces overall abuse, I voted no for the previously stated reasons.
Dr. Stivell?
Hi, John Stivell. I also voted no for the previous stated reasons. Thank you.
And this is Sonia Hernandez-Diaz, and I voted no for the previously stated reasons. Dr. Nelson?
Lewis Nelson. I voted no for the previously stated reasons as well.
Dr. Jovinja?
Hello. I voted no for the previous stated reasons.
Dr. Krebs?
I voted no for the previous stated reasons. In terms of the sub-questions, I would actually rate the overall strength of evidence supporting this no as a little higher than my yes for the first question, mostly because we have more different kinds of studies. I think individually, again, all the studies tend to be kind of low quality, but taken together, since they're looking at this from different angles, maybe the body of evidence is a little bit better, still relatively weak. But I'm not sure how you could do better given all of the different factors happening at the same time with the various secular trends. I think the studies do paint a reasonably convincing picture that probably there's no significant change in overall abuse with the reformulation. Thank you.
Dr. Griffin?
Marie Griffin, and I also voted no, and for the reasons previously stated, I also agree that it would be really tough to do a study because of all the temporal trends, trying to do a before-after study, if the comparison has to be the previous drug. And I think a different comparator would be maybe more appropriate.
Mr. O'Ryan?
Yes, I think appreciate the benefit of the drug being crushed and still not releasing dose dumping. However, I didn't see any data to be able to vote other than no on this.
Dr. Hauser?
Hi, I'm Mariam Joza. I voted no for the previously stated reasons.
Dr. Safran?
Yeah, Sharif Zafran. I struggled with this one a little bit, and actually I voted yes, but primarily actually somewhat for some of the reasons that previous people who said no stated. I think you had a shift from people who are abusing it intranasally and intravenously to orally because they had no choice. In other words, it actually had the intended effect. Now, was that a decrease in overall abuse? I think it was a decrease in people who were able to abuse it in a way that was meaningful to where it was going to actually cause morbidity and mortality. So the question was a little bit unfair, but I voted yes, and I wanted to state the reason why and kind of put that into the record.
Thank you. Dr. Coffin.
I voted no for the previously stated reasons, and in terms of additional research, I'd like to see analyses with milligrams in the utilization as a denominator, and research to really prove this I think would be extremely difficult, requiring prospective or even randomized designs.
Dr. Bateman.
Brian Bateman, I voted no, and I just echo the comment from Dr. Pullman. The overall measure is a composite of oral and then non-oral routes of abuse, and so you're combining an outcome where the drug is not expected to have an effect, which is much more common than the place where the drug reformulation is expected to have an effect, and that makes it really hard to show benefit.
Dr. Norman.
Richard Ehrman. I voted no for the previously stated reasons. I also want to add three things that I think was discussed, that some evidence actually shows that oral abuse had actually increased, which is a concern. There's also no long-term follow-up regarding opioid use disorder. And finally, as already been mentioned, there are way too many confounders, including public health efforts, that certainly could have influenced the results and adjusting for drug utilization. Thank you.
Dr. Higgins.
Dr. Jennifer Higgins. I voted no because I feel the data are insufficient and for many of the reasons that people have previously mentioned, considering the methodological problems and the modest decrease in overdose rates among the Medicaid population in 30514. But as I stated previously, there are methodological problems to my mind with this study in particular, as I was not convinced that the beneficiaries are Medicaid only, and my concern is that dual eligibles are more likely to be older, sicker, and more severely disabled than Medicaid only beneficiaries. And more careful subgroup analysis, I think, is needed, as I said, particularly because there are higher rates of overdose that are evident in the Medicaid only population. Thank you.
Dr. Sprint.
Hi, this is Michael Sprint, and I voted no for the previous stated reasons. And I guess I wanted to also state that, in addition to being, I'm a pain doctor, I'm an addiction doctor, and I've been in recovery for a long time from opioid addiction, including IV. And I can say that information that we would need in the future, I would recommend a lot more research collaborations between addiction medicine and pain medicine, physicians, and doing research that really traverses both the pain management world in the clinics as well as addiction medicine. And I think we could probably start to get more meaningful data out of it and start to basically learn how to ask better questions and get better answers. Thanks.
Dr. Tracy Green.
Hi, Tracy Green. I voted no on this, and I did so for many of the same reasons mentioned by my colleagues here. I do think that the SCIP data and the NAVAPRO data showing concerning trends in the oral route of administration really swayed the overall abuse concern here for me, but the consistency across qualitative and quantitative and published and multiple sources for surveillance really made me vote no and recognize that there was no meaningful reduction in overall abuse. But I would say that the data could be improved by, and I'm sure we'll talk about this soon, but the constellation of challenges around abuse would include initiation of drug use, and that was not part of the consideration of abuse for this product. So I would say investing in that area and perhaps revisiting the whole name of abuse deterrent formulation should be changed with this in mind.
Dr. Sakharov.
Yeah, hi, this is Kevin Zakharov from Renaissance School of Medicine at Stony Brook University. I voted no, and I voted no for reasons previously stated, underscoring what we just heard from Dr. Green. With respect to the strength of evidence, obviously I consider it to be very weak, not even very weak, less than that. And with respect to additional information, I definitely agree with what Dr. Sprint said, but I am not necessarily confident about the fact that there will not be confounders moving forward as well. I think it's going to be very, very difficult to try to measure this in a vacuum. Thank you.
Dr. Basavana Goldra.
Hey, Basavana Goudra from Penn Medicine. I voted no, and I think the reasons have been well stated by other members. Thank you.
Dr. Maisel.
Steve Eisel from mHealth Fairview in Minneapolis. I voted no. I voted no on the prior question, so I don't think it would have the evidence to do it for the nasal and the IV route. Certainly isn't going to do it overall. So I'll just leave it at that. Thank you.
Thanks. Dr. Davis.
Alex Davis, Carnegie Mellon University. I voted no. I think there's a key piece of information missing. In the future, the FDA should ask sponsors to make a causal estimate of the degree to which ADF deters prescriptions and demand from those intending to misuse the drug. There's likely a large component of reduced overall abuse in the form of patients seeking out OxyContin less. However, none of the studies provided causal estimates of that reduced demand.
Dr. Marshall.
Brandon Marshall, I voted no for the previous stated reasons.
Dr. Chauvin.
Abby Chauvin, I voted no. I want to echo Dr. Davis's comment just then, which is sort of it's what you really want at is sort of that causal potential reduced demand overall, and that's what we don't have. I'm not convinced we could ever get it, but that's sort of what would be needed to sort of prove this meaningful reduction in overall abuse. I wanted to state for the record that I don't think that there's evidence that there's this huge shift to oral abuse that would sort of make this sort of fear of the reducing intranasal and intravenous and shifting to oral sort of increasing overall abuse. I don't think there's evidence of that. I just think that there's not a meaningful reduction in overall abuse given the data that we have.
Thank you. And Dr. Adam Gordon.
Adam Gordon, University of Utah. I voted yes for the stated reasons of question number one. I'm particularly concerned about the population of misuse, potential misuse, and abuse. And with the stated reasons of question number one, I believe that this does reduce the overall abuse of a product. I also want to comment that the ADF is a drug deterrent for misuse of the product in a stated way. And the data that at least was presented to me indicated that intranasal as well as intravenous routes were lessened with this product, and that is a more concerning route of administration than oral. Thank you.
Thank you. So we will now move on to question 4, which is also a voting question. Okay, let us look at the question and see if we have any question about the wording first. Does the available evidence demonstrate that OxyContin's reformulation meaningfully reduced the risk of opioid overdose relative to the original formulation? And if you answered yes, please explain in which populations and how would you rate the strength of the evidence? And if you answered no, please explain whether you think the available data are sufficient to answer this question. If so, how would you rate the strength of this evidence? And if not, what additional information do you think would be necessary to answer this question? So we have 2 questions about the wording. Dr. Coffin.
Yeah, so my big question is, what is the population that we're considering here? Is this reduce the risk of opioid overdose overall in the population who were using OxyContin, or the population who were
prescribed OxyContin.
Can
Thank
the
you.
FDA answer these questions? Maybe Dr. Stafa or anybody at the FDA can clarify to which population are we referring to?
Hi, this is Judy Staffa. Can you hear me now?
Yes, thank you.
Okay, sorry, I was evidently double muted. I would welcome Dr. McAninch to weigh in, but my thinking is I believe the study that was submitted, the study PMR4, related to these outcomes, overdose outcome in patients prescribed OxyContin. That was the patient population they were able to access. I don't believe we saw data on any other populations and their risk for overdose, but I'll defer to Drs. McAninch and Green if I'm just forgetting anything from the literature.
Yeah, I think that you can interpret it to be patients who are exposed to OxyContin. Did it meaningfully reduce their risk of opioid overdose? So we're not specifying exactly which study or how they're exposed, but based on the available evidence, if you can try to answer that question as much as you can, that would be helpful. And as you explain your answer, you can also explain exactly how you interpreted the question.
Thank you.
Thank you. Dr. Cortez?
Yes. This question says opioid overdose, but it does not add with OxyContin, whereas the previous two questions we voted on concerning abuse always said of this product, with this product, but this one doesn't. It doesn't say opioid overdose with OxyContin. Is that implied? Are we supposed to think about it in terms of overdose with OxyContin prescriptions as if we were in question 1 or 2, or is it meant to be broad such that we think about overdose in some much broader way that might encompass a very wide range of illicit and illicit products?
I think that we didn't think it was fair to ask you about overdose, like OxyContin overdose, because we don't really generally have data on what drug was specifically causing an overdose the way we have data on a particular drug being abused. So again, I would say it's the risk of overdose associated with OxyContin or exposure to OxyContin. So maybe thinking about it a little bit more in a classic exposure outcome kind of a framework, if that's helpful at all. Yeah.
Thank you.
Thank you. Dr. Sakharov.
Yeah, hi. Dr. Cortez got one of my questions answered. So the other question is, could you please clarify for me what you mean by opioid overdose? Do you mean opioid overdose related deaths, or do you mean any instance of a medically necessary treatment of opioid overdose, et cetera, please? Thank you.
Hi, this is Jana McAninch again. I would say fatal or non-fatal overdose involving opioids.
Okay, thank you.
Dr. Sibel? Oh, Dr. Sibel, do you still have a question? No? Okay.
Oh, yeah, sorry. I just wanted to know what data, you said there's no data on Oxycontin specific overdose or Oxycontin the overdose. What studies could you point us to that we've discussed that would give us the appropriate data to answer this question? It seems really vague.
Well, I think the primary study is the PMR number 4, the claims-based overdose study. But we did discuss some other studies in the literature related to overdose, but I would focus your thinking primarily on PMR 4.
There's no tox data with that.
That's correct. It's based on coded data on overdose from insurance claims and death certificate.
Got it.
Data.
Perfect. Thank you so much.
Dr. Meisel?
Hi, this is Steve Meisel. Just for clarity here, we're talking about the word overdose. We're talking about accidental overdose, intentional overdose, and iatrogenic overdose. By that I mean a doctor prescribes too much or a nurse gives too much, a medication error type of overdose. Or are we just talking about accidental overdose?
This would be overall overdose.
So all three of those, accidental, intentional, and iatrogenic.
In that, we did not think that the data allowed for reliable distinction between those. We're asking you about overall overdose.
Okay.
Thank you. So if there are no further questions or comments concerning the wording of the question, we will now begin the voting on question 4.
This is Phil Bautista. We will now be moving out to the breakout room. Again, there's no discussion of the question in the breakout room. Voting members will only be casting their vote. Thank you.
Hi, this is Phil Bautista, DFO. You have 15 seconds to submit your vote. You can say it then. Hi, this is Phil Bautista. The vote is closed and now complete. Once the vote displays, I will read the vote results into record. One yes, 26 noes, one abstention. Thank you. I'll now hand it back to the chairperson.
Yep, thank you. I have been muted from Central. So thank you. We will now go down the list and have everyone who voted say their name and vote into the record. You may also provide justification for your vote if you wish, and please remember to address any of the parts of the question that correspond to your vote. We will start with Dr. Setoguchi.
Thank you. Soko Setoguchi from Rutgers University. I voted no. For the population with known abuse, substance abuse, there's no data presented in PMR 1 to 3, 1 to 2. And then for the insurance population, the data was not compelling to conclude that there's a reduction in overdose. I believe that in terms of the second question about additional information, it's probably almost impossible to get this overdose information in existing data retrospectively. I guess if this, to me, this is a stronger data result endpoint compared to the abuse reported by personal individuals. So I think if we want to sort of look at this harder endpoint, prospective study would probably be needed for the future PMR.
Dr. Chauvin.
Abby Chauvin, I voted no, sorry, just double checking that you can hear me. I voted no, and I agree with Dr. Setoguchi that sort of the evidence was just not compelling. Like, I don't think that there's not evidence that it's doing any kind of harm. There's just not evidence that it's making a meaningful reduction in opioid overdose.
Dr. Cortez.
Dr. Cortez from University of Alabama, Birmingham. I voted no. I want to state I can conceptualize how someone might argue it could be, but in the population that receives medically prescribed opioids, the fourth post-marketing study that we saw showed no decrease in overdose, and there's a significant range of studies that were not presented to us, but which focus on overdose in prescription-receiving populations, in which there are many non-prescription related factors that determine the likelihood of overdose. And this, of course, creates a significant challenge of signal to noise when considering the impact of a subtle or non-subtle change in formulation. I also believe there is a concern that we will discuss in the next questions about possible harm for the non-medical population to the extent that it can be distinguished from people who are in medical care.
Dr. McCauley.
Yes, Maura McCall of East Carolina University. I voted no for the reasons stated with PMR 4. Also, with that study, I think one of the problems I have with it is that the ICD codes really probably don't capture that data consistently. And as people have said, it was only seen in commercial claims and not in the Medicaid claims. Thank you.
Dr. Fullman.
Yeah, this is Dean Pullman. I voted no. I thought the evidence was kind of weak. I liked it that it was an abuse, an overdose endpoint, but it just didn't seem that strong to me. I thought maybe there's a signal in the oxy alone users, but that's sort of a contrivance in a way because I think they might go from one state to the other. And so another thing, one of the other panel members brought up was they only count people until they, while they have insurance. If they lose insurance, they're not counted. So that seemed to be a censoring problem. I also worried about the switching problem that had been mentioned earlier. So all in all, it just didn't pass the bar for me. Over.
Dr. Mayer?
Hi, this is Dermot Maher. I voted no for some of the reasons that were previously stated, primarily some methodological concerns with study 4, such as the loss to follow-up once patients no longer were carried by insurance, and also the possibility of patients who migrated away from OxyContin with the abuse deterrent formulation to other opioids. And true, yeah, there may be some signal in there in patients who were using OxyContin alone. However, I think that represents a very narrow and very select subset of patients that might not be representative of an overall population. Thank you.
Dr. Sibel?
Hi, this is John Zabel. I voted no, mainly for the reasons that people said before about the study itself and the strength of the findings. I do just want to make one comment that, the evidence, if you do look into overdose data, there's very few overdoses that just involve semi-synthetic opioids, including heroin. They always include something else, and so kind of not dealing with the other stuff with illicits and using the ICD-10, maybe 9, it's just too many confounders, so I just wanted to make that separate point. Thanks.
Tony Diaz, I voted no. I think the quality of the evidence, the strength was low. The study, for all the reasons mentioned, had limitations, but also focused on one particular medication of prescription use in the medical setting. So I think it would be possible an effect on overdose in other populations or later in time. However, if most of the use is oral and the product is bioequivalent, why would the overdoses be reduced? And regarding the non-oral abuse with a lower use, yes, we have seen maybe a lower abuse because of the lower use, and that in itself might end up in lower overdoses from this particular product. But that, together with the injections with more dilution, that might also reduce overdose, will down the line maybe also bring other problems. So I don't know if we need or if we can do any further studies to have better evidence about the effect of overdose. Dr. Nelson.
To Lewis Nelson, I voted no. I think that it's very difficult to tease out cause of death and overdose from poison center data, medical examiner data, and certainly from big data sets like Study 4 tried to do. And I think there's a lot of definitional issues and diagnostic issues. One way to approach this, it's fairly impractical, is to look at people who overdosed and died and try to do sort of a psychological autopsy, so to speak, sort of go back and look at the circumstances of overdose and try to piece things together. Things be very hard to follow these people out prospectively, just given the relatively low rate of death, certainly, and even of overdose, and then trying to capture these people at the time of overdose and put together any sort of cogent understanding of what's going on. But overall, I think the quality of evidence was fairly poor.
Dr. Hemingway.
Hello, Colin Hovengay. For the record, I abstained in many reasons. I border between that and no, and largely from a lot of the recommendations that were suggested in other committee members. I work a lot with real-world data. There's a lot of holes in this. There's not a lot of information about the data was QC'd. There's no like toxicology data or things that would confirm, whether or not someone's on polytherapy. It really, the even 4 was a fair study. It just didn't answer a lot of the questions I would want to know to make a firm determination.
Dr. Safran.
Yeah, Sharif Safran, I voted yes. I guess I'm in the minority today. Again, I had a little bit of an issue from the standpoint of, if the questions were asked the way they were asked, it's almost like it'll be impossible for us to really move forward with any type of medication that could have, any kind of meaningful improvement in reducing risk of overdose. And for that reason, I really just narrowly looked at this drug by itself. If you're going to decrease the incidence of intranasal or intravenous routing of this drug, keeping everything else constant, you're decreasing the incidence of possible overdose from mechanisms of uptake that have a higher risk or chance of overdose. So even if you're shifting it from intranasal or intravenous use to oral intake, where in a long-acting drug you have a lower chance of that type of overdose, then just looking at that, I think you have a decreased chance of bad outcomes. I understand there's a lot of confounding factors. I wish the question was asked a little bit more narrowly. I understand why most everybody voted no. In fact, if I looked at it a little bit a different way, I probably would have voted no also. But I'm really trying hard to just objectively look at what we're measuring here just with this formulation. So I voted yes.
Dr. Griffin.
Marie Griffin, I voted no for the reasons that have already been stated. Thanks.
Mr. Bryan.
It seems to me that based on the percentage of sales overall and the other confounders as mentioned, et cetera, it's almost impossible to answer this question with a yes. Having said that, as someone who has that in my cabinet, I'm glad it's there, and I think it is a safer product than the alternative.
Dr. Yosa.
Hi, I'm Mariam Joza. I voted no for the reasons stated, plus additionally that overdose is usually a polypharmacy phenomenon, so even if we had best designed studies to look at, I imagine it'd be unlikely that a change in a formulation of one agent would have a dramatic effect.
Dr. Krebs.
I voted no for reasons that everyone else has said here.
Dr. Coffin.
I voted no for reasons already stated. A few comments on the research, particularly PMR4, of course. So one comment, the ICD coding for non-fatal overdoses is notoriously insensitive compared to a gold standard of chart review, which is extremely rarely done. Some other issues with the study, which I noted previously, the patient population likely changed. This has been raised a few different times, so it is difficult to compare the pre-formulation and post-formulation patient population. And in addition, I'd like to see an extended, what was referred to as grace period, after an opioid prescription would have run out, because the truth is people stockpile opioids, and sometimes people still have opioids on hand months after a prescription should have ended. They are scared of being without it. And in terms of the one concern that was raised about potential power in these studies, it would be useful to have post hoc power calculations just to determine what kind of an effect size we could have conceivably missed. Thank you.
Dr. Green?
Tracy Green, I voted no for many of the same reasons previously stated. Just to comment, I think that Study 4 was a missed opportunity to do things differently and to many of the analyses that have been suggested. But the very limited results that we found made interpreting it actually extremely difficult, including things like adjusting for benzodiazepine use, making no difference in our findings. Based on the fact that we have a black box warning for benzodiazepine co-use with opioids, you'd expect some sort of change in the effects, just as an example. They did lean more heavily on the literature review to help answer this question of whether there was a meaningful reduction in the risk of opioid overdose. I was concerned that there weren't data to support the non-fatal overdose, and since we were being asked to combine both, I just think that there are data that could be more compelling and certainly less rare of an outcome than fatal overdose. So that's maybe an area to improve upon, and actually are collected in many of the surveillance data sets that were used in PMR 1 and 2 and 3. And then now, of course, we do have wonderful data sets from NCHS with literal text fields in the death files, as well as CDC-based data in the Suitors data sets and ESOS to help us understand overdose risk in a more nuanced way, and that may be helpful going forward in thinking about weighing this question, whether there was a reduction or an increase or no effect over time, and in this product as well as future ones. Thank you.
Dr. Ullman.
Richard Ehrman, I voted no, and many of the reasons already been mentioned. It's really a very difficult question to answer given the data, the heterogeneity of the data, and many confounders have already been discussed, including public health efforts, prescription trends, and obviously a lot of methodologic issues. The other issue I believe was already mentioned, polysubstance abuse, which is present in a lot of these patients, makes it difficult to see the impact of the ADF OxyContin alone. And it appears from the data that we reviewed, they did not impact the overall death. And actually there's an increase in death from synthetic opioids, including heroin. So, thank you.
Dr. Higgins.
Jennifer Higgins, I voted no for the methodological concerns I've already stated previously.
Dr. Sprint.
Hi, this is Michael Sprint, and I voted no for the reasons stated previously. Thank you.
Dr. Bateman.
Brian Bateman, I voted no because of the lack of consistent beneficial effect across the studies in PMR4. The only group where we see evidence of benefit is commercially insured patients that use OxyContin alone, which is a sort of unusual group. I would say though that I think if we expect reformulation to have a benefit on overdose, it's perhaps this is not the group where we'd expect to see it. Patients who are being prescribed opioid analgesics for pain indications, but rather if it may have an effect of decreasing overdose if it reduces the intravenous use of the medication in illicit users. That's a very, very difficult group to study for all the reasons that people have mentioned.
Thank you. Dr. Zakharov.
Yeah, hi, Kevin Zakharov, Renaissance School of Medicine at Stony Brook University. I voted no for many of the reasons previously stated. If this question had been worded differently, as Dr. Zafran mentioned, my feelings might have been different. If it would have been worded to reduce the risk associated with manipulation of this drug and incidence of fatal opioid overdose, then I might have answered differently. I think the strength of evidence supporting my opinion is that I don't think there's a lot of evidence to show that this would be the case. And as Dr. Ehrman mentioned, I'm really not confident about additional information due to the multitude of confounders. Thank you.
Dr. Gowda.
Hey, Basamana Gowda from Penn Medicine. I voted no for the reasons that have been already well discussed. Thank you.
Dr. Michael.
Steve Eisel from mHealth Fairview. I voted no for many of the reasons stated before, and I should say that I'm not convinced that the premise of the question is reasonable, that we would really expect to see a meaningful reduction in the risk of overdose for opioids. We talked about the polypharmacy aspect of this and all the other illicit drugs that are associated with this, and really the only benefit, if there is one, is it's a little bit harder to dilute and inject. But that's not the premise that that alone would have an impact on opioid overdose, considering everything else going on in the community with the opioid crisis, I think is probably not a realistic premise. So I wouldn't have expected there to be a positive finding in this case. Thank you.
Alex Davis, Carnegie Mellon University, and I voted no for the previously mentioned reasons.
Dr. Marshall.
Brandon Marshall, I voted no. I didn't think PMR4 showed robust evidence that the reformulation reduced opioid overdose. And I think the study probably suffers from textbook selection bias, which probably holds the true associations away from the null, making the reformulated product appear protective when it might not be. I was also impressed by the evidence in the state-level analyses and literature review by Powell and Albert and others showing increases in heroin overdose after the reformulation, particularly in states with a high prevalence of pre-formulation OxyContin misuse and heroin overdose. And I think that's important. I think what's going on here is strong effect modification by contextual factors like the presence of heroin markets that were available to quickly meet the high demand for opioids following the reformulation of OxyContin. So I actually believe that some of that evidence shows that the reformulation increased opioid overdose, particularly illicit opioid overdose death, notably in states that were already dealing with, huge OxyContin misuse problems. Thank you.
Thank you. Dr. Amir Shahi.
Marian Amir Shahi, I also voted no for the aforementioned reasons, particularly with concern for the multiple confounding factors that we could not account for and missing data. Thank you.
And Dr. Adam Gordon.
Adam Gordon, University of Utah. I voted no for many of the stated reasons. I also want to echo that Dr. Marshall just a couple minutes ago, or less than a minute ago, stated almost exactly what I was going to say. There's methodological concerns about claim data, and I don't think that there was sufficient evidence at all to support the claim of question number 3. Thank you.
Thank you. So we will now continue with questions 5 through 7, which are discussion questions, which is the good news. The problem is that we are over time, so I'm going to try to go through the questions, and I will understand if some of you may have to leave, but let's go through the questions. But I'm going to ask you to please be very, very concrete in your messages, and that if they have been stated already, not to repeat them, so that we can give FDA just a series of points for the next questions. Dr. Higgins, you have your hand raised. Do you have a question?
Oh, not a question. I have a discussion point.
Okay, about the questions that are coming, right? So we can
correct. Number 5.
Question 5. Okay, correct. Great.
So I do agree. Oh, shall I proceed?
I think we will have question 5 posted on the screen first, and at least I don't see it yet. I still see the vote.
Hi, this is Phil Bautista, the DFO. The question will be posted shortly.
Okay.
Appreciate the patience. Thank you.
Thank you. So hold on a second. We will read the question, and if there is any question about the wording of the question, we will tackle that first, and then we will move on to discussion, and Dr. Higgins, you'll be first. So moving to question 5, which is a discussion question. There we go. Discuss whether the available evidence indicates that the reformulation of OxyContin had any important unintended adverse consequences. And if so, please explain what these consequences were, in which populations you believe they occur, and what evidence you found most compelling. And if not, please explain whether you believe the available data are sufficient to answer this question, and if they were not, what additional information would be necessary to answer this question. Any question about the wording of the question? Okay. If no, we can move on to the discussion. And Dr. Higgins, you're first on the list. Go ahead, please. Thank you.
Thank you. Yes, I do believe that there was evidence that there were unintended adverse consequences post-reformulation. Both secular trends suggested and the FDA literature review suggested that there were increased heroin use, which happened concurrently, though causality was not demonstrated in 30513. But I was most concerned about the age-related overdose, increase in age-related overdose deaths that was shown by Dr. Dasgupta, which I also found persuasive. Thank you.
Thank you. Dr. Marshall.
Yes, thank you. Brandon Marshall, Brown School of Public Health. Yeah, I agree with Dr. Higgins. I think there's evidence showing that this reformulation probably increased rates of transitions to heroin use. And I disagreed with Dr. Dart in an answer yesterday that this should have happened really quickly after reformulation, and yet the heroin overdose rate sort of increased slowly. I think studies show that it takes time for these transitions to occur, and that the speed of that transition is probably effect modified by factors such as availability of heroin in the broader drug market. So I think some states were probably impacted much more quickly and rapidly than others, but I think in totality, that was an important unintended adverse consequence of this reformulation.
Yeah. Dr. Zakharov.
Yeah, hi, Kevin Zakharov here. I agree with some of the comments that have already been made with respect to unintended consequences, the balloon effect, the existence of some number of people who use an alternative route and developed some form of thromboangiopathy. I don't necessarily consider these to be particular to the reformulation of this particular medication to an abuse-deterrent formulation, and think that this could be an unintended adverse consequence of any abuse-deterrent formulation. But since we're talking about this medication, I have to call those out. Thank you.
Dr. Sigal?
Yeah, thank you. I just wanted to concur with Dr. Marshall, just for the record, that I think there's clear evidence, not in these studies, but many other studies that are showing the relationship. And it's hard to do causal, as everyone has said. We can't really show cause. I mean, Dr. Compton didn't even want to say that illicit fentanyl was the cause of the epidemic. He said the data strongly suggests, which is disingenuous at best. And so the relationship between prescription OxyContin as the prescription opioid epidemic and the heroin epidemic is pretty clear as we can get, without saying strongly statistically related. So I just wanted to make that claim because it's really hard to make a lot of the assumptions and scientifically that we're wrestling with here. But, you know, I would just, as an aside, challenge anybody to ask anybody over the age of 40 that's used heroin if what opioid they start with, and be surprised if they wouldn't say OxyContin. So we know from the qualitative data that there's a relationship. And I think that's just something to think about moving forward. I think our decisions are going to have impacts for 10, 15, 20 years for posterity. And I feel like that's what we're making these decisions for. Not really now, but could we see that again? And so there's such an environmental aspect here that's hard to capture, and I just wanted to stress that. Thank you.
Okay. Dr. Sigal?
Nope, that was me. I just went.
Oh, sorry. Mr. O'Brien, yes.
Yes, can you hear me? Okay. I just struggle with calling in unintended adverse consequences. I mean, yes, it's clear that there's switching to heroin, but I don't know whether the individual who overdosed on heroin would have overdosed on OxyContin. I don't know whether or not that would take effect, and I didn't see any data that would tell me that that was a direct relation causal to reformulation of OxyContin. So I would say that if, you know, there was some data that showed infections or the thrombosis from injection because of the POE that was in there, that may be, yes, unintended consequences, but I don't think that the larger scale I would call that. I would say it just elucidates a problem and that we know with the confounding issues that exist with this epidemic.
Dr. Spring?
Hi, I just wanted to state for the record, I do agree with the statements that were stated earlier about definitely there are unintended adverse consequences. I really appreciated and agree with what Dr. Zabel was sharing in regards to that, and especially as they were talking earlier how it moved people from predictable dosing when they went into the illicit market to unpredictable dosing and unpredictable products, and that has caused a lot more deaths and other morbidity with that. Thank you. Thank you.
So I don't see more comments, so I think we can summarize by saying that the committee saw some unintended adverse consequences, and the one that was highlighted was the transition to heroin or other products that have more of an unpredictable consequences, and whether it is, it is hard to know if the associations that we have seen are causal. In the context of the epidemic, it kind of makes sense that these transitions happen. Okay, so no new hands raised. I would suggest, in the interest of time, to move to question number 6. Let's read it and think about the wording first, see if you have any questions. Considering the totality of evidence, discuss the overall public health impact of the reformulation of OxyContin. Explain what evidence you found most compelling and what additional information, if any, you think is needed to address this question. So this is about the overall public health impact. Okay. Dr. Griffin, is a question about the wording, or shall we just go straight to the discussion?
Discussion. Should I do it, or, sorry?
I have Dr. Sibel O'Brien, Mr. O'Brien, and Dr. Griffin. Do you have any question about the wording first?
No.
Okay.
No.
Then, I think it's clear enough, the question, so that we can go on to the discussing the question itself. Dr. Griffin, please go ahead.
Yeah, Marie Griffin. I just felt like I liked the idea of crush resistant to describe what this product really did. And so I think it did have a small impact on nasal and IV use because of that property. And I think the wording is really unfortunate, as other people have mentioned, and I think there really needs to be a lot of thought about changing that wording of abuse deterrent for this product.
Thank you. Dr. Sibel?
Yeah, thank you. I want to take this opportunity. I've been wanting to say this for the whole meeting, and I think it's just really important. I'm going to be really quick because I know it's time. People want to eat and be back with their families. The two overall public health impacts I think are the biggest here are switching to another opioid or another drug, and what we haven't talked about is actually circumventing the abuse deterrent technology. That, in terms of HIV risk and hepatitis risk, is what we found is the biggest public health risk. And so I haven't seen the evidence that there is an effective abuse deterrent formulation with excipients that prevent people from crushing them, putting them into a solution, and injecting them. And we know that a lot of the behaviors and grassroots, for lack of a better word, technologies that people are using or circumventing are putting them at risk. We found that with HIV in Scott County. We're seeing that with hepatitis all over North America. There's 5 studies that show that. And so I feel like this was one big thing that was lacking. I felt like what we were looking at was switching. So was there a risk? Did the formulation cause any harm? Well, it caused a lot of switching. But is switching an abuse deterrent if there's other options? So if I'm going to switch to one I can shoot because I can't shoot one, is that an abuse deterrent? Or is it a supply issue? And if I didn't have access to the other supply, then I would try to really do that thing because I'm only going to shoot something. I want that rush. I don't want just to eat it and get that slow thing. I want that rush, so I'm going to put the time in. And I feel like that's what's missing here. I would have liked to have seen, like we did for Opana, the rigorous studies showing could it be crushed and snorted, could it be injected, what is that right? Because I think if we're talking about infectious disease, that is the risk moving forward with abuse deterrent formulations. And I also want to just in closing say, when I said I was really disappointed with the FDA last previous comment, what I really meant was not having these studies, not giving us really the studies that I think to really answer these questions. I mean, everyone's struggling with these questions, and I think it's because of the data's hard to collect, et cetera. But I also want to cheer you for really summarizing the data and really putting the time in and really trying to be objective, and I just really appreciate that. So I just wanted to close with that, but just highlight the circumventing of abuse deterrent, and is it effective or is it putting people at harm who are circumventing, are some unanswered questions. Thank you.
Thank you. Dr. Maisel.
Thank you, Steve Meisel. I want to echo what Drs. Nelson and Griffin said, very well put from both of you. I think the problem with this product is that the perception or the marketing or the message is that we've got a product that's going to help with the opioid crisis, and it's really easy to overstate that. And so one of the things that we alluded to several times, but there's no good data on, is are there people that are now prescribing more of this stuff than they otherwise might have because they think it's the quote-unquote safe opioid. That's very hard to measure, and it's really hard to understand and measure the public health impact of more people receiving opioids than they might otherwise would have because the providers and other people think that abuse deterrency is addiction prevention. And so I think and this gets into the last question, but I think one of the messages here, we got to get rid of this term abuse deterrent formulation. We've struggled with this for years at this committee, never have a good definition of it, never have a good measure of it, and I think the term itself is problematic, and it's sort of creating unintended consequences in terms of public health, where people assume it means certain things, and it really doesn't. You really got to peel away the onion to really understand what it does mean, and most people don't. And so, everything that Drs. Griffin and Nelson said is true, but I want to make sure we understand that the nomenclature here is bad, and the impact that that nomenclature can make some very unintended negative consequences to public health. Thanks.
Thank you. Dr. Sakharov.
Yeah, hi, Kevin Zakharov. Just briefly with respect to this discussion point, I think that my conclusion would be that there is some incremental change that was made in a positive direction. I think about the fact that this all took place a number of years ago, and it was with the guidance, with the intention that the sponsor was receiving from the Food and Drug Administration. And this was done in a way where it wasn't a choice about how to prescribe OxyContin abuse deterrent or not. The change was made completely so that the only thing moving forward that would be marketed was the abuse deterrent formulation. So I consider that to be a positive incremental change. And I think it's a dangerous thing to say, however many, 9-10 years later, that we could say it didn't necessarily hit the mark because we don't know where we're going to be in 9 or 10 years. And I don't ever think there won't be a balloon effect, but when you squeeze the balloon, then you need to pay attention to the other areas that do balloon as a result of the squeezing. Thank you.
Dr. Coffin.
Hi, thank you. And this sort of builds on what others have been saying. The sponsor's own presentation argues that there was a huge shift from OxyContin, particularly among people who were not using it as prescribed when the reformulation came. And so this is pretty clear. I think most people agree that this happened. And it was clear back then, as it is today, that we had to do something about overprescribing, and this was one of those efforts. So the question was less if we had to do something and more how we did it, which comes back to things like the term abuse deterrent formulation and all the issues that have been raised with that, and how we've done a lot of other things around responding to the opioid crisis. It's not do we need to respond, it's how do we respond. And I'm not convinced overall that this was a positive response. In particular, the very fast way that it happened, we know led to tons of transitions without opportunities for people to, for example, access methadone or buprenorphine and things like that, that could have lessened the devastating societal impact of so many people transitioning from a stable known dose to the illicit market. Thank you.
Dr. Nelson.
Thank you. I actually put my hand down, but I will just say Dr. Mizell gave me credit for comments that were actually made by Dr. Zabel. I put my hand up to make the exact comments that Dr. Mizell made about communication, messaging, safety, and in a paradoxical way, we're back to my original comment at the meeting, which was about the semantics of the term tamper-resistant or crush-resistant. And that comes up at almost all of these meetings because when we say something is abuse deterrent, it really has to have credible evidence that it does just that. Thank you.
Yeah, thank you. Dr. Gordon.
Hi, Adam Gordon, University of Utah. I just want to summarize some thoughts that I had regarding kind of some of the questions that we've had over the last two days. I'm a little concerned that we kind of have a macro approach to the problem and not looking at the micro or what's happening on the ground. I think I mentioned before, and I'll just reiterate that I think knowing kind of how patients are perceiving this change or knowing how providers are perceiving this change is an essential component of ADR. So having that perspective, I think, was missing during the meeting, and the evidence presented was very sparse in that area. So I would have liked the sponsor and or FDA to do a little bit more patient perspectives and surveying potentially provider perspectives of the change. And I think that would be much more compelling in terms of changing practice as well as changing outcomes for patients. Thank you.
Thank you. Dr. Cortez?
Yes, thank you. This is Dr. Cortez from UAB. I want to underscore that we have a dilemma. This entire two-day meeting is, and I deeply appreciate the work of the FDA in preparing the materials, but this entire meeting has felt to me almost like we're at a distance from the real issue. It's like going on a hike through Zoom. The normal path, and I think it has a little bit to do with the tools the FDA has and the problem we're trying to confront. The normal pathway for FDA is to regulate a product, to affirm or assert that the regulation of that product will result in safety and good care for persons. And we can see how that would work in the case of a cardiac medicine where we're all trained in cardiac disease and the problem is the product safe. That linkage, though, in the case of addiction and pain feels broken, and perhaps it never fully existed. There's such a tiny fragmentary connection between a product formulation and the protection of patients in this domain, because the necessary background elements that we would presume and want to have operating effectively in other areas of healthcare are missing here. Those would include training in pain, training in addiction, a compensation around the work of engaging challenging patients and working with them, and protection of individualized decision making, given that this is a high risk endeavor. I think the FDA has a tough order because you fundamentally have to regulate products, not all of healthcare. But I do see and believe and hope that the engagement with the FDA's partners could be part of enhancing the scope of discussion. And since you're fully engaged already, I'm sure, the question is what kind of further engagement with the CDC or with CMS or with medical schools or other health professions training would enable the improvements in care that would put those 4 elements back into place so that when we discuss a product, we can hope that something useful happens out of it. And with that, I'll stop and thank you.
Thank you. Dr. Tracy Green.
Thank you. I think this is Tracy Green. I think the challenge of considering the totality of a public health impact of an ADF change with OxyContin is in this year, in 2020, and to infuse that back in time to the questions and the market shifts and the motivations for ADF and reformulation of OxyContin 10 years ago is a extremely difficult challenge, and one that maybe should have happened long ago. I think Dr. Compton put it very well in reminding us that specifically with prescription medications for the treatment of pain and other abusable medications, it's not one patient, one provider, one prescriber that we're thinking about, but the household, the family, the community in which that medication is dispensed into and used and transported. And so thinking about not a drug-centric or patient-centric, but really a public health-centric approach is what we as a society really need to take with us going into these questions, even when we're considering one product and its impact. If there was a product where we could have that conversation, I feel strongly it would be this one because it has the greatest market penetration of any ADF, and it was the first out of the gate. So it means it gives us the greatest opportunity to measure change before and after. And I know we've been talking about many confounding factors, but there wasn't the pill mill. There weren't PDMPs everywhere. At the time, we had extremely limited medications for opioid use disorder. We didn't have the same societal and social norms change that followed the CDC guidelines. It was a very different time. And so there are a lot of really golden nuggets, if you will, in the data that have been presented. I think that the questions that were asked weren't the ones that would help inform a public health-centric based approach. And I think the time is really now where we're starting to see some data out of some of the same data sets that have been there for a long time, but that aren't 50% industry-sponsored data. And those research studies are starting to give us more insight. Unfortunately, we don't have one balloon that was squeezed. We have many more balloons that have been squeezed over time. And capturing all of those and the full public health impact is probably at least a career or two's worth of epidemiologic and clinical research and certainly policy work to be done. But aligning the opportunities that align with CDC and SAMHSA and FDA to think about some of these questions and use those existing data as well as data sets that informed these decisions that gave little insights. Maybe there's a small indicator that heroin is starting to increase in the SCIP data and a little bit in the Navipro data. To actually listen to it, that's what I think that still needs to happen. That big question of what evidence do we still need? And the most important voice is the one of people who use drugs, who have been there all along in the qualitative data that could be collected and the stories and the life histories that Dr. Zabel and others have been discussing and that are still very much there in needle and syringe exchange and overdose education programs all over the country. They have a lot to share and a lot to tell us about how reformulated drugs, new drugs are being changed and changing their use. We just have to listen and ask.
Thank you. One last comment from Mr. Bryan, if it is different from the points that have been made.
Thank you very much. Yes, I agree with the things that are said, but I guess my last point is, and it's one that has been made, the data shows that the vast majority of OxyContin uses are people who actually need the product and use it for their pain management, or particularly with chronic pain management. But the data also shows that that becomes a primary potential source for others who may abuse it, experimentally or not. Most of the legislation changes we saw years ago, and people that got up before the media, were not people who were users. These were unintentional, accidental overdose of a product that was dump dosing on these kids. We have with this product a safer product. As I've said earlier in my testimony, I am grateful that I have that particular safe. And unfortunately, it doesn't solve all of the problems that we have with this epidemic, but I think it is one step at a time. And I think it was an important change. And I am grateful to the FDA and for their strategy and sessions in trying to get more products like that that are safer for the patients and for the sponsors who are working for them.
Thank you. So let me very briefly summarize only the points about the public health impact. The committee members discussed the impact on switching and on circumventing the formulation that can put all people at risk, like the epidemic we saw with HIV and hepatitis cases. We talk a lot about the perception of safety that the use of the word deterrent can bring, and how we probably want to prevent the use of that term and improve the communication of the reduction of the tampering with the new formulation, and it's not that it's going to take us to less addiction. Even when the reformulation was considered a step in the right direction, there is a lot to be done still in the effort to avoid overprescribing. That was the beginning of the epidemic, and how to respond to that. There was a lot of conversation about like multidisciplinary approaches with training and treatment of pain, addiction, of heart patients, with the involvement of not only FDA but CDC and other public health agencies, and to take this problem as a public health problem and not as just one formulation or one product problem involving users, abusers, family members. However, the data from OxyContin can be a good source of information, since it has been here from the very beginning of the epidemic. Okay, so apologies for the delay. Let's take the last question, question number 7, for those of you that can remain with us on a Friday evening. The question is, discuss what information, if any, you believe is important to convey to clinicians, patients, and the public about the post-marketing evidence of reformulated OxyContin's effectiveness in reducing abuse and related adverse outcomes, and or its overall public health impact. So first, any question, comment on the wording? Dr. Davis, Higgins, Cartez, or Green, any of your questions about the wording?
Not the wording, no. Thank you.
No, not for me.
Okay. Yeah, maybe the wording is relatively straightforward. So, Dr. Alice Davis.
Alex Davis, Carnegie Mellon University. So Dr. McIninch's memo, page 887, the phase 1 results show that the communications about ADF OxyContin are not getting the key issues across to physicians. For example, only 3% of a five question knowledge-based questions about ADF were only 3% got them correct. The FDA should encourage and require robust and empirically based strategy to effectively communicate ADF products to physicians so they can help their patients make informed decisions. And patients and clinicians should continue to be informed that OxyContin is a highly addictive drug and has the potential to lead to serious addiction and use of illegal drugs such as heroin. This risk should be provided quantitatively in some form, because the risk is high enough that many patients would be unwilling to accept. Addiction seems to be highly unpredictable. For example, even after some abusers leave the population, utilization-based estimates of overall abuse and overdose for the remaining low-risk population is relatively unchanged, which suggests that patients and physicians cannot predict whether a patient will become addicted. Addiction appears to be a random event that is hard to predict and puts every user at risk. Those users may switch to drugs different from OxyContin, including illicit drugs and heroin. The patients and physicians should know that the overall risk of addiction is highly unpredictable. Thank you.
Thank you. Dr. Higgins.
Jennifer Higgins. Simply put, mine is much more global. Can you hear me okay?
Yeah, there is some echo.
Okay, so simply put, I would say the message to the age would be that the data are mixed. There's some evidence that some effect.
Hi, this is Phil Baptiste, the DFO for the meeting. As a reminder, please mute yourself when you're not speaking.
I don't think it's coming through what I'm saying. Okay, so that said, however, data are confounding and there cannot be a determination at this time that the reformulated OxyContin has had a positive impact on lowering individual overdose rates or overall public health crises. Thank you.
Dr. Cortez?
That's an error. I apologize. I should have taken my hand down before.
Oh, no worries. Dr. Sprint?
Hi, this is Michael Sprint, and I just wanted to say that, you know, even though that I didn't believe that the post-marketing evidence of the OxyContin showed that it reduced abuse, I feel more importantly that clinicians must understand that it's our responsibility to identify opioid and other substance abuse in our patients and have the basic understanding and skills of how to identify a substance use disorder and either refer or manage these patients in this disease. It's tough, but we need to strike a balance between that appropriately treating our pain patients while minimizing the addiction risk and being competent in identifying and managing a substance use disorder when we identify it. And that requires awareness on our part when we have a patient that that has active disease, and the unintended consequences of unaware prescribing is really a problem. Can anyone hear me? Okay.
Yeah.
I'm very much in support of technologies that help to prevent, identify and manage at-risk patients or those with disease, and we must be able to show up for our patients and get them appropriate help when needed, rather than just assuming an ADF product alone is sufficient to stop addiction. But I do appreciate the purpose of ADF products and its role. I do agree with Dr. Kursitz that the doctors who treat pain, we need to understand the basics of addiction medicine, and addiction medicine providers also must learn the basics of pain management. We're really merging here at this point. So I think if we're able to do those things, we'll be able to better care for our patients as it relates to opioids and other medicines of abuse. Thank you.
Thank you. Dr. Green?
Thank you, Tracy Green. I wanted to echo what Dr. Sprint had mentioned regarding the importance of having physicians who are prescribing pain medication to also have the ability to prescribe, especially buprenorphine, for the treatment of opioid use disorder and withdrawal. And it's very important to consider in every of those instances where opioids are being prescribed to co-prescribe naloxone, the rescue medication. And this is part of the discussion with patients to ground safety in prescribing and to really make clear that there's safety in the home and in the community for naloxone access in case an overdose or respiratory depression event does occur. And then finally, I think speaking very specifically about ADS, I think the name should change to be more specific, and the language and the labeling and communications with clinicians really needs to focus on the route of administration that we're identifying risk reduction in, so that people understand it's really about crush resistance, for instance, in talking with people who may be at risk for using by that route. Thank you.
Thank you. One last comment by Dr. Sakharov.
Yeah, just a quick comment to the FDA with regard to this discussion point. I think these past 2 days have been an unbelievable presentation of important information to us. Maybe one of the best that I've seen since I've been on this committee. And some kind of summary of this information to clinicians, patients, the public, some kind of summary of the debate that we heard actively throughout the course of the 2 days, I think could only do good. So I'll just close with that. Thank you.
Thank you very much. So let me try to briefly summarize. Regarding the public health, there are many comments along the day, but this afternoon we have highlighted that the new formulation still is highly addictive. This is a highly addictive drug, and the risk is high enough, and that has to be communicated. The risk reduction from the reformulation only applies to one route and route of administration, and that has to be clearly communicated. Also, clinicians prescribing need to be aware that their patients can switch to other products and the implications for that. And the product alone, in any case, cannot prevent addiction. Therefore, those clinicians prescribing pain medicine and treating patients with pain need to be also able to identify, refer, and manage patients with addiction and have a discussion with them about the safety, including the use of naloxone. So that's my summary. Thank you all for your patience. And before we adjourn, are there any last comments from the FDA?
Yes, this is Judy Staffa. Can you hear me?
Yes.
Yes, I just want to thank everyone. I know this was a huge effort. It was a huge effort for everyone involved, and I want to thank you for all of your thoughtfulness, your comments, really taking this issue as serious as we do, and we have a lot to take back and think about, and I appreciate your flexibility and patience with the manner in which we did this meeting, and I think your efforts have really made this the most productive meeting that we could have, and we are very grateful for all of your unbelievably helpful comments. So on behalf of the FDA team, I want to thank everybody for a long 2 days. You've given us a lot to think about, and we definitely appreciate that. So thank you. Travel safe.
Thank you. I would like just to thank the members of the public that participated today and the FDA staff that prepared the 888 pages of amazing summary and great presentations today, and also the ones that were behind the technology that I think worked pretty well, considering that this is new for everybody. And thank you to Purdue as well for the presentations. And finally, thank you to my peer committee members for their participation and great and thoughtful comments. And again, their patience for being late today. So thank you all. We will now adjourn the meeting. Thank you. Good evening.
Audio recording for this meeting has ended. The meeting is now over. All the participants have been disconnected.